Very good morning to everyone. So in the crucial state, you are all in you have 13 days more for your exams, and I hope so you are all preparing well. So today we will be completely revising your ENT except your larynx, which we have discussed already. So to begin with your pharynx, one of the easiest chapter as far as your entire ENT is concerned is going to be your pharynx. So pharynx is extending from the base of the skull to the C6 vertebra. Okay, so C6 vertebra is the place where the trachea and esophagus is going to start. At that point, your pharynx is going to end. Now, your pharynx is basically divided into three parts. What are the three parts? Number one, you have nasopharynx. Number two, you have oropharynx. And finally, you're going to have laryngopharynx. Nasopharynx is the uppermost part of your pharynx lying posterior to your nasal cavity. Hence, you are going to give the terminology as nasopharynx. It lies above your oropharynx. Therefore, you also call this as epipharynx. You are also going to call this as epipharynx. Okay. Then comes your oropharynx, which is going to lie exactly behind your C2 vertebra. It is going to lie exactly behind your C2 vertebra. Then you're going to have your laryngopharynx, which is going to lie behind your larynx, and that is going to extend from C3 vertebra to the C6 vertebra. Clear? So your oropharynx and laryngopharynx together, you're going to call it as throat, whereas nasopharynx always lies separately. Now coming towards the definition of your pharynx. Pharynx is a fibromuscular conical tube extending from the base of the skull to the lower border of cricoid cartilage, which is going to form the upper part of your air and food passage. They become continuous with your esophagus, and this area, the width of your cricopharyngeal esophageal junction, is the narrowest part of the entire pharynx, which is going to be just 1.5 centimeter. So what is the importance of this statement? Very easy. The importance of this statement is they are going to form the location of your foreign body in your foot pipe. Foreign body in your foot pipe is going to be at the junction of your cricopharynx and your esophagus. Clear? Now moving on to talk about a very important part, that is going to be the structure of your pharyngeal wall. Okay, so remember guys, the entire pharynx is going to be lined by stratified squamous epithelium, except your nasopharynx, which is going to be lined by your pseudostratified ciliated columnar epithelium. So entire arena is going to be lined by your stratified squamous epithelium, except your nasopharynx, which is going to be lined by ciliated columnar epithelium. Why? Because your nasal cavity is going to be lined by your ciliated columnar epithelium. That is why even your nasopharynx is going to be lined by ciliated columnar epithelium. Okay, so now behind this epithelium, so first layer is going to be epithelium. Behind this epithelium, you're going to have second layer, that is going to be subepithelium. So subepithelium is going to have collection of lymphoid follicles. This lymphoid follicles is going to form a ring-like structure in your pharynx. That ring is what you call it as a Waldeyer's ring, an important short note question. So first point is, what is Waldeyer's ring? Waldeyer's ring, just beneath your epithelium, in the subepithelial layer of your lymphoid follicles, lymphoid tissue is going to have a ring-like structure in your nasopharynx and your oropharynx, and that is called as Waldeyer's ring. Any doubt till now? No, right? Yes. Now moving on towards the next point. Your Waldeyer's ring is going to consist of four important tonsils. What are the four important tonsils in your nasopharynx? In the posterior wall of your nasopharynx, you are going to have the first one, that is going to be your adenoid tonsil. Second is going to be your tubal tonsil, which is going to lie above your auditory tube or eustachian tube. Then you're going to have third one just adjacent to your palate, just between your anterior pillar and your posterior pillar, you're going to have your palatine tonsil. And finally, you're going to have a lingual tonsil, which is going to present at the posterior aspect of your tongue. Okay, so these four tonsils have another name. What are the other name of these tonsils? Adenoid tonsil is called as Lushkow's tonsil, whereas tubal tonsil is called as Gerlach tonsil, whereas palatine tonsil is called as fascial tonsil because it is lying between your anterior fascial pillar and posterior fascial pillar. That is why we are going to call it as a fascial tonsil. Okay, third thing you have to understand is to locate the tonsils. Okay, adenoid tonsil, if they are going to ask you what is the exact location, it is going to be at the midline of the junction of the roof, that is going to be your base of skull and your posterior wall. So base of skull ku posterior wall ku and the roof la and the junction la you're going to have your adenoid tonsil. Now coming towards your tubal tonsil, that is going to be present in the lateral wall behind your Eustachian tube opening. The third one is going to be your palatine tonsil. I told you already, it is going to lie between your anterior pillar and your posterior pillar. Whereas your fourth one, that is going to be a lingual tonsil, lies in the posterior 1/3 of the base of tongue. And fifth one is going to be a lateral pharyngeal wall. So that is going to be some minor tonsils which are present all along your posterior pharyngeal wall. Now you may wonder why I am not writing everything and teaching like I used to do in my YouTube sessions. Very simple. Now you're going to revise. If I'm going to start writing one by one, it's going to take a time. So now I'm going to tell you the points. Some points which are very important, I will be annotating. Some points I will be discussing by oral route only. I want you all to listen carefully and just accumulate and recall all the points which you have read already in your textbook. Probably at this point, you will all would have completed one round of learning of all the ENT chapters. Now, what I am doing is I'm just going to help you to recall the topics. Okay, so that's the ultimate motto of this session. So I hope so that is comfortable for you all. Okay, now moving on to talk about the third layer. So this is going to be the second layer, that is going to be a subepithelial layer. So initially you had a epithelial layer. Second is going to be a subepithelial layer. Now the third one is going to be pharyngeal aponeurosis. What is aponeurosis? It is going to be a fascia that is going to be arising from your pharyngeal wall. Hence, you're going to call it as pharyngobasilar fascia. You're also going to call it as pharyngobasilar fascia. This pharyngobasilar fascia is going to help you in formation of the capsule of tonsil. It is going to help you in formation of capsule of tonsil. Now, next is going to be a muscular coat. Now, talking about your muscular coat, guys, your muscular coat is going to be of two types. One is the inner longitudinal coat, and second is going to be a outer circular layer. So the inner longitudinal coat is going to be the muscles that are going to come and attach to your pharyngeal wall. So from three places, you're going to have the muscle that is coming and attaching to your pharyngeal wall. Namely, it is your stylopharyngeus, salpingopharyngeus, and palatopharyngeus. As the name suggests, it is going to arise from your styloid process, from your auditory tube, and from your palatopharyngeus is from your palate. So all are going to attach to your pharyngeal wall, which is going to be posterior to your thyroid cartilages. So what is the use of these inner longitudinal coat? So they are going to pull up. So you all know that a muscle's action is towards the origin. So the origin is going to be towards your styloid process, your auditory tube, and your palate. Therefore, it is going to pull your pharynx up. That means it is going to elevate, and it is also helping in dilatation of your pharynx. Why this is important? This is important for the swallowing reflex. Now moving on to talk about your outer circular layer. Outer circular layer is going to be of three important layers. One is your superior, middle, and your inferior constrictor muscles. Superior constrictor, middle constrictor, and inferior constrictor. As the name suggests, what does that constrictor means? Constrictor means constriction of your pharynx. Therefore, it is going to cause constriction of your pharynx. Okay, so now you have three layers, something like this. This is going to be your outer longitudinal, first one, superior layer, and your middle constrictor and your inferior constrictor. So what is the important in this is, between your superior constrictor and your base of skull, you have a gap or an opening. That is called as foramen of Morgagni or sinus Morgagni. Foramen of Morgagni or sinus Morgagni. Why this is important? Because there are some important structures that are going to pass through your foramen of Morgagni or sinus of Morgagni. So what are the structures that are passing through? Remember using a mnemonic TALA, T-A-A-L-A. So what does that help you? T stands for tensor villi palatini. A stands for ascending palatine artery. Another A stands for ascending pharyngeal artery, which is a branch of palatine artery. And L stands for levator villi palatini. And A stands for auditory tube. So these are going to be the structures that are going to pass through your foramen of Morgagni or sinus Morgagni. Now coming towards the next one. So now you understood what are the structures that are passing through your base of the skull and between your base of the skull and your superior constrictor. Now we are going to move towards the next one, between your superior constrictor and your middle constrictor. So can you see here, in the area between your superior and middle constrictor, you have a muscle attachment. What is this muscle attachment? Can you tell me what is this muscle attachment? Stylopharyngeus muscle. So you're going to have your stylopharyngeus muscle that is going to come between your superior constrictor and your middle constrictor. Apart from your stylopharyngeus muscle, you have one more nerve. So can you just put this, superimpose this in your body and you can tell me? So in your neck, if you're going to have this, what happens? This area is going to be adjacent towards your, it is very much adjacent to your oropharynx. So in the oropharynx, you have an important organ called tongue. Can you tell me what is the sensory supply of tongue? Anyone? Can you put in the chat box what is the sensory supply of tongue? Anterior 2/3 and posterior 1/3 is supplied by what are the sensory supply of your tongue? Glossopharyngeal nerve. Excellent. And one more nerve. Anyone? One more nerve, a branch of facial nerve. What is that branch of facial nerve? Chorda tympani nerve. Excellent. So you have this glossopharyngeal nerve. This glossopharyngeal nerve is going to come out of your tongue, and they are going to pass through the gap between your superior constrictor and your middle constrictor. So now what is your question? What is your answer? The structures that are passing between your superior constrictor and your middle constrictor are: number one, stylopharyngeus muscle, and number two is going to be glossopharyngeal nerve. Now moving towards the third one, between your middle constrictor and your inferior constrictor. Now this middle constrictor and inferior constrictor, that junction is going to be lying exactly at the level of larynx. So in the larynx, you divide your larynx into three parts. Do you remember? Supraglottis, glottis, and your infraglottis or subglottis. So supraglottis is a region where you're going to have superior aspect of your thyroid. So all your superior laryngeal nerve and superior laryngeal vessels are going to pass through the gap between your middle constrictor and your inferior constrictor. So can you tell me what are the structures? Number one, it is going to be your superior laryngeal nerve, and your number two, it's going to be your superior laryngeal vessels. In superior laryngeal nerve, to be very particular, it's going to be internal laryngeal nerve. Now, can you tell me what is the internal laryngeal nerve? Which structure is pierced by your internal laryngeal nerve in your larynx? Anyone? Which structure is pierced by your internal laryngeal nerve in your larynx? Anyone? Can you just recall and tell me? In larynx, there is a membrane. That membrane is pierced by your internal laryngeal nerve. Excellent. It is your thyroid membrane. Now, the second part of the question is, can you just locate at which point this foramen is there in your thyroid membrane? Which place you're going to have your insertion or your innervation of your internal laryngeal nerve in your thyroid membrane? Can you tell me? Anyone? Can you tell me, anyone? So it is going to be just superior to, just above your greater cornu of thyroid. So it is going to be just above your greater cornu of thyroid in which part, as you all told, it's a thyroid membrane. In your thyroid membrane, you're going to be having a internal laryngeal nerve that is going to pierce and get in. Clear? Now moving on to talk about the next part. That is going to be your the area that is going to lie between the two parts of inferior constrictor. Now you will ask me, what is this two parts of inferior constrictor? Remember guys, your inferior constrictor is basically divided into two. What are they? Number one, it is going to have a thyropharyngeus. You're going to call it as thyropharyngeus. And number two is going to be your cricopharyngeus. As the name suggests to you all, thyropharyngeus is going to be attaching to the thyroid. posterior, okay, it is going to attach to your thyroid. Whereas cricopharyngeus, it is going to be having attachment in your cricoid. Now what happens is thyropharyngeus originate from the oblique line of your thyroid anteriorly, and it is going to run posteriorly and attach to the middle raphe of your pharyngeal wall. So this orange color line is called as your midline raphe. In this midline raphe, you're going to have the attachment of your thyropharyngeus. Next is going to be cricopharyngeus. Similar to your thyropharyngeus, your cricopharyngeus is also going to arise from the anterior aspect of your cricoid cartilage, and it is going to just circle yourself, and it is going to come and attach to the midline raphe of your posterior pharyngeal wall. Okay, so now what happens is in between the two parts of your inferior constrictor, that is going to be between your thyropharyngeus and your cricopharyngeus, you're going to have a small opening. What is the small opening called as? This small opening is called as Killian's dehiscence, otherwise called as gateway of tear. So it is called as Killian dehiscence, otherwise called as gateway of tear. What is the importance of this? See, this gateway of tear, why do I call it as gateway of tear? It is not the tear that is coming from your eyes. This tear is going to be the literal meaning. So this is a place where there is a easy laceration that can take place. So this area, they can easily get torn off. Your pharyngeal wall get torn off. So that is why this area is important. And you have to remember that the most common site for development of a pharyngeal pouch is going to be from this area. So the pharyngeal pouch that forms from here, that is going to be a Killian's dehiscence, you're going to call it as a Zenker's diverticulum, which you will be reading in a while. Next, coming towards the second important aspect of Killian's dehiscence is this is a probable site of perforations during the rigid endoscopic procedures. When you're going to perform an endoscopic procedures, this area can easily get torn off or perforated. Okay, now moving on to talk about the next layer. Now we have completed mucous membrane, subepithelial layer, then pharyngeal aponeurosis, muscular coat. Now the fifth layer is going to be your buccopharyngeal fascia. What is this buccopharyngeal fascia? Let me show you with a diagram. See here, so this is going to be your pharynx. So your pharynx order last layer, outer surface of your constrictor muscles. So here you're going to have your constrictor muscles. Just above your constrictor muscle, you're going to have a small layer of fascia. That is called as your buccopharyngeal fascia. That is going to be called as the outer layer of your pharynx. This outer layer of the pharynx is the place where your pharyngeal wall is going to end. Behind this buccopharyngeal fascia, you're going to have another fascia that is called as alar fascia. Behind your alar fascia, you're going to have the another fascia that is called as prevertebral fascia. So you're going to remember three important fascias here. The first one is buccopharyngeal fascia. Number two is going to be your alar fascia. Number three is going to be your prevertebral fascia. Now, the problem with all these fascias is they will be having a gap between the two fascias. For example, between your buccopharyngeal fascia and your alar fascia, you're going to have a space. Similarly, between your alar fascia and your prevertebral fascia, you're going to have a space. Similarly, between your prevertebral fascia and your vertebra, you're going to have a space. So, whenever a space is present, two important things can occur. One, a tumor can develop in these spaces. Or number two, any infection can actually present as an abscess here. Clear? So now let's see one by one. The first space that is going to lie between your buccopharyngeal fascia and your alar fascia, that is called as retropharyngeal space. This is going to lie between your buccopharyngeal fascia. It is going to start from your base of the skull, but it is going to extend down to the level of T4 vertebra, where there is a bifurcation of trachea. Clear? Where there is a bifurcation of trachea. But you all know that this is an area just adjacent to your pharyngeal wall. You know, in pharyngeal wall, there is a center midline raphe, which is going to be a thickening. That midline raphe is going to extend into your retropharyngeal space. So when it is going to extend into retropharyngeal space, if you can see here, so this is going to be your buccopharyngeal fascia. So in your this is going to be a buccopharyngeal fascia. Just adjacent, just behind your buccopharyngeal fascia, you're going to have your retropharyngeal space. You're going to have retropharyngeal space. So this retropharyngeal space, what you're going to remember is, in this retropharyngeal space, what do you have? So can you see here? Is the image clear? Yeah. So in the retropharyngeal space, you're going to have the raphe attachment, which is going to divide your retropharyngeal space into two. So in the retropharyngeal space, renda pirikidi, this space that is going to be a midline raphe. Now, this space that is going to lie in the lateral to that of your raphe, the space that lies lateral to that of your raphe, you're going to call it as a space of Gillette. So this is called a space of Gillette. This space of Gillette is going to consist of certain lymphatic nodes. What are those lymph nodes called as? These lymph nodes are called as nodes of Rovier. So you're going to call these lymph nodes as nodes of Rovier. Nodes of Rovier. Clear? So now what happens is, whenever there is going to be abscess in this space, what happens? It will be looking like a unilateral. It will not be crossing, because there is going to be a division of the space of Gillette. So there is going to be unilateral paramedian. So just adjacent to your medial area. So you're going to have a unilateral paramedian bulge in the posterior pharyngeal wall. So that is going to be the presentation of your retropharyngeal abscess. Now coming towards the next one, that is called as your danger space. This space is going to lie between your alar fascia anteriorly and prevertebral fascia posteriorly. This area is called as either danger space, or we are going to call it as alar space. Now the question arises, why do they call this as danger space? You all know that your retropharyngeal space is going to extend from your base of the skull to T4 vertebra. But here what happens is, your danger space is going to extend. Your danger space is going to extend from the base of the skull, and it is going to go into mediastinum. So because of that, what happens? The abscess can actually travel to your mediastinum, and they can actually affect your mediastinal structures. Since it is going to affect your mediastinal structures, you're going to call this as a danger space. So what are the complications of your danger space abscess? So the complications include mediastinitis, purulent pericarditis, cardiac tamponade, pleuritis, pyoneumothorax, empyema, bronchial erosion. So all your lung and heart is going to get involved in this. So that is why you're going to call it as the danger space, and this as a worst prognosis. Now moving on to talk about the next one, that is going to be a prevertebral space. So this space is just anterior to your vertebra. Okay, so this space starts at the base of the skull, and it is going to extend till your T4 vertebra. Again, this is going to extend till your T4 vertebra, where they are going to fuse with your prevertebral fascias. So where the prevertebral fascia is going to fuse along your fourth thoracic vertebra. Now, after this, you have something called as parapharyngeal space. So what is this parapharyngeal space? Just adjacent to your retropharyngeal space, lateral to your retropharyngeal space, you're going to have an important area called as parapharyngeal space. This parapharyngeal space, so it is going to have it is going to be related to many structures. So that is why we are giving more importance for your parapharyngeal space, otherwise called as lateral pharyngeal or pharyngomaxillary space. Just lateral to your pharyngeal wall, there is another space called as parapharyngeal space, as I told you, and this is going to communicate posterior-medially with the retropharyngeal space. It is going to communicate posterior-medially. This is going to be a posterior-medially. It is going to communicate with your retropharyngeal space, and anterolaterally, it is going to communicate with it is going to communicate with various other structures, which I am going to tell you. Now, medially, if you're going to see, you're going medial to your parapharyngeal space, you're going to have a mandible. Along with mandible, there is going to be attachment of medial pterygoid medially and masseter lateral to your mandible. So you're going to have medial pterygoid and masseter, which is going to attach to your mandible laterally and medially. Now what happens? This is going to lie medial to that of your parapharyngeal space, point number 1. Point number 2, you're going to have parotid. So this parotid is going to lie lateral to that of your parapharyngeal spaces. Okay, now what happens is, this is going to be looking like an inverted pyramid. This inverted pyramid base, it is going to present in the base of the skull. Whereas laterally, it is going to be the apex is going to be present between your medial pterygoid and your buccopharyngeal fascia. Now, parapharyngeal space is actually divided into two components by your styloid process and the muscles attached to your styloid process. Now, can you tell me what are the muscles that are attached to styloid process in the chat box, please? What are the muscles that are attached to your styloid process? Can someone respond in the chat box? What are the muscles that are attached to your styloid process? Styloid process. The name itself will be having stylo. Stylo. What are the muscles which you remember using this stylo name? Stylopharyngeus, excellent. Then stylohyoid, excellent. Stylohyoid, stylopharyngeus. Then you're going to have your styloglossus. Very good, Lankeshwar Ravi Krishna and Lankeshwar Ravi Krishna and others, those who are answering. Okay, so your stylopharyngeus, stylohyoid, and styloglossus muscle, which is going to be arising from your styloid process. So these three are going to be the muscles. Now, this is going to divide your parapharyngeal space into two. So one is called as your pre-styloid compartment. Pre-styloid compartment is going to consist of one artery, and there are three nerves that are going to be present. Okay, so the artery and the nerves that are going to be present in your pre-styloid compartment are maxillary artery. So this maxillary artery, and you're going to have mandibular nerve. This mandibular nerve will be giving three important branches at this area. So what are the three important branches? Number one, it is going to be your auriculotemporal nerve, lingual nerve, and inferior alveolar nerve. So auriculotemporal nerve, alveolar nerve, inferior alveolar nerve, and you're going to have your lingual nerve. Clear? Now moving towards the posterior aspect of your or posterior styloid compartment. Though the posterior or your post-styloid compartment pass very important structures from the base of the skull to the neck or vice versa. So what are the important structures you have here? Number one is going to be your internal carotid artery, internal jugular vein, and you're going to have four important nerves. What are the four important nerves? The last four nerves, 9th, 10th, 11th, and 12th nerve. And along with that, you're going to have your sympathetic chain, which is also present. Along with that, you're going to have your sympathetic chain that is going to be present. Now, this is going to be your parapharyngeal space. Hope you are clear. Now, whenever there is going to be any abscess that is formed in your parapharyngeal space, you're going to call it as parapharyngeal abscess. So what will this parapharyngeal abscess do? You see here. So this green color marked is going to be your tonsil, which is present between your anterior pillar and your posterior pillar. Now, whenever there is going to be a abscess that is formed in your parapharyngeal space, that is going to push your tonsil outside. So when you're going to just examine these patients, you will think that the patient have a peritonsillar abscess or quinsy, but the patient would have a parapharyngeal abscess. Clear? So any mass in the post-styloid compartment, what it will do, it is going to push the lateral pharyngeal wall medially, and this causes bulge of your lateral pharyngeal wall behind your posterior pillar. So this is going to be a posterior pillar. At this area, this is going to be a posterior pillar. At this area, you're going to have a bulge like this. So when you're going to have a bulge like this, that is going to be a post-styloid abscess. Clear? So now coming towards, so this is going to be the end of your wall of your walls of your pharynx or pharyngeal wall. Now moving on to discuss about the three important divisions of your pharynx. So what are the three important divisions of your pharynx? Number one, you know that you have your nasopharynx, then you're going to have your laryngopharynx, and you're going to have your oropharynx. Now let's discuss about the anatomy of individual pharynx. Okay, so I will talk about the oral cavity later, guys. Now I will complete the pharynx first, then go to the oral cavity. So you all know that you're going to have three important pharyngeal areas: nasopharynx, oropharynx, and laryngopharynx. So the first one is going to be your nasopharynx. Remember, nasopharynx is going, so you're going to have three important structure: nasopharynx, oropharynx, and laryngopharynx. So let me talk about your laryngopharynx first. Okay, so first one is going to be your laryngopharynx. Why I am talking about it now itself is laryngopharynx does not have an importance because we have talked numerous things in your larynx chapter itself. So I'll tell you some important points in your laryngopharynx. Laryngopharynx. Remember, your laryngopharynx is going to consist of three important parts. Number one, you have pyriform fossa or pyriform sinus, number one. And number two, you're going to have your posterior cricoid area. Posterior cricoid area. And number three is going to be your posterior pharyngeal wall. Posterior pharyngeal wall. Pharyngeal wall. How to represent this in the diagram? Very easy. So as a schematic representation is, this is going to be your larynx. Okay. So behind your larynx, you're going to have your pharynx like this. So this pharynx, okay, so this area is called as your pyriform sinus, and this area is called as your pyriform fossa and pyriform fossa, and this is going to be your post-cricoid area, and behind your post-cricoid area, you're going to have your spinal cord or your vertebra, and between your vertebra and posterior spinal cord, you're going to have a posterior cricoid area, you're going to have a small fascia or a wall. This wall is called as your posterior pharyngeal wall. Posterior pharyngeal wall. Clear? So this comes to the end of your first topic, that is going to be a laryngopharynx. So in laryngopharynx, what are the important things which you are going to see? Okay, the first thing is going to be your pyriform sinus. So you need to understand that your pyriform sinus, pyriform fossa is an area where the foreign body can get accumulated. So first thing you have to remember. Second thing is the internal branch of laryngeal nerve. So this area entirely is going to be supplied by your internal laryngeal nerve. So internal laryngeal nerve give rise to branches that is going to supply your supraglottis in your larynx, and it is also going to supply your pyriform sinus. So because of this, what happens is whenever there is going to be a injury or whenever there is going to be injury to your internal laryngeal nerve, what happens? It is going to affect your supraglottis and pyriform sinus. Because of that, what happens? There is going to be a aspiration chances. So there can be a chance of aspiration. So there is a high chance of aspiration in the internal laryngeal nerve palsy. Clear? So this is okay. This is very important point you have to remember. And your pyriform sinus is a place where it is the most common site of malignancy, in your hypopharynx, Now moving on to discuss about next important point, that is going to be your laryngeal crepitus. What is this laryngeal crepitus? Very simple. Laryngeal crepitus means the clicking sensation that you're going to feel when your larynx is moved over your cervical vertebra. This is absent in your post-cricoid carcinoma. So normal people, laryngeal crepitus will be present. So it is going to be absent in conditions like, number one, post-cricoid carcinoma. It is going to be absent in your retropharyngeal abscess. It is going to be absent in your prevertebral abscess. And it is going to be absent in your laryngeal fractures. It is going to be absent in your laryngeal fractures. Clear, right? So now coming on to talk about the next important thing, that is going to be about your nasopharynx. So nasopharynx is going to be in the posterior wall. Okay, posterior wall of your nasopharynx is going to be at the junction of the roof and posterior wall of your midline. So they are going to be like a cuboid in nature. Posteriorly, you're going to have your C2 vertebra. So can you see here? You're going to have your C2 vertebra and prevertebral muscles and your fascia. Superiorly, you're going to have your base of skull. That's what you call it as basisphenoid, occiput. And inferiorly, you're going to have your oropharynx. The area between your nasopharynx and oropharynx is going to be your nasopharyngeal isthmus. Clear? Now coming towards your, at the same area, you're going to have something called as ET orifice or the fossa of Rosenmuller. Before moving towards the fossa of Rosenmuller, you have to remember that at the same site of adenoid, you all know that in the nasopharynx itself, you're going to have something called as adenoid like this. So this is going to be your adenoid, which is going to present, and you're going to have your tubal tonsil, something like this. You're going to have a tubal tonsil, something like this. Okay. So above, you're going to have your tubal tonsil. So here, you're going to have your tubal tonsil. So at the same site of adenoid, at the junction of roof and posterior wall, you're going to have the remnant of notochord. So this remnant of notochord, you're going to call it as a nasopharyngeal bursa. So you're going to have something called as nasopharyngeal bursa. Now moving on to discuss about the lateral wall of your nasopharynx. So if this is going to be a lateral wall of your nasopharynx, just remember, nasopharynx is the posterior continuation of your lateral wall of the nose. So this is going to be your lateral wall of the nose. Posterior continuation of your lateral wall of the nose, you're going to have your nasopharynx. So in this nasopharynx, okay, so in the lateral wall of nasopharynx, you're going to have first one, that is going to be opening of eustachian tube. So this This opening of eustachian tube is present in the lateral wall 1.25 centimeter behind your posterior end of inferior turbinate. This is going to be your posterior end of inferior turbinate. From here, you're going to 1.5 centimeter. So you're going to 1.5 centimeter at which you're going to have the opening of eustachian tube. The cartilage of eustachian tube produces a bulge above your eustachian tube opening. This bulge, can you see here? You're going to have some bulge, right? So you're going to have some bulge, isn't it? This bulge is nothing but they are called as torus tubaris. They are going to call us torus tubaris. Now, just behind and above your bulge of torus tubaris. So behind your bulge of torus tubaris, you're going to have a fossa or recess. That fossa or recess is called as your fossa of Rosenmuller or lateral pharyngeal recess. So இதுக்கு பின்னாடி தான் you have the origin of. So this is called as your fossa of Rosenmuller. This area is a place where there is a common origin of your nasopharyngeal carcinoma. So common origin of nasopharyngeal carcinoma. Now moving towards the next one, that is going to be your the next important point is in the lateral wall, 1 centimeter above the middle turbinate. So this is going to be a middle turbinate. Just 1 centimeter above your middle turbinate is going to have your spinopalatine foramen. So this spinopalatine foramen is going to present somewhere around a 1 centimeter above your middle turbinate. This is going to be a middle turbinate, just 1 centimeter above your middle turbinate. Somewhere here you're going to have the spinopalatine foramen. So this is the most common site of origin of your angiofibroma. So this is the most common site of origin of angiofibroma. The spinopalatine foramen connects the nasopharynx with your spinopalatine fossa. So spinopalatine fossa we nasopharynx connect பண்ணி வைக்கிறது உங்களோட வேலை. What are the major vessels and your nerves that are going to be entering to your spinopalatine fossa? You have to remember. Before that, your spinopalatine fossa is going to be something like this. A pyramid, a small pyramid-like structure. Okay, it's a small pyramid-like structure. Okay, it's lying in the maxillary antrum. So if you're going to see here, this is going to be a zygoma. So this is going to be your zygoma and you're going to have maxillary antrum here somewhere around here. You're going to have your maxilla. Okay, so in this maxilla, then you're going to have your zygoma like this. Okay, so in the area, it's going to be bounded anteriorly. Okay, in this area, behind your maxillary antrum. So maxillary antrum in the area. In the area, you're going to have your spinopalatine fossa. It's a small pyramidal space. It is bounded anterior by your posterior wall of maxillary antrum and posterior by the anterior border of pterygoid plate. So the medially it is going to be a lateral wall of your nasopharynx on which there's going to be opening of your spinopalatine foramen. Later the fossa is going to open into the intertemporal fossa through the pterygomaxillary fissure. The contents of your spinopalatine fossa, can you tell me? Number one, it is going to be a maxillary artery. You have your maxillary nerve, spinopalatine ganglion. So that is a very important thing. Spinopalatine ganglion, it's going to be a parasympathetic ganglion. It's going to be a parasympathetic ganglion. Next, coming to talk about your oropharynx, guys. That's all. That's all about your nasal pharynx, nasopharynx. Now, if you want, you can copy these important points. So in the nasopharynx, you're going to have all these tonsils and everything. Now, finally, we're going to move towards the oropharynx. Oropharynx is going to be bounded anterior-superiorly by a soft palate and posterior-superiorly it is going to communicate with your nasopharynx through your nasopharyngeal isthmus. Or you're going to call it as a velopharyngeal isthmus. Can you tell me in which condition you're going to have velopharyngeal insufficiency? In which syndrome? You would have probably read in your pathology. In which syndrome you're going to have velopharyngeal insufficiency? Velopharyngeal insufficiency. In which condition you have? Can you tell me? In which condition you're going to have? In which syndrome you're going to have? Anyone? 22q11 deletion. 22q11 deletion. Catch 22. Where did you read this catch 22? Which syndrome? Dijot syndrome. So remember, in Dijot syndrome, you're going to have your velopalatine insufficiency. What is this velopalatine? They are nothing but they are going to be the nasopharyngeal isthmus. So nasopharyngeal isthmus is what you're going to call it as a velopalatine. And this velopalatine, when it is insufficient, you're going to have a Dijot syndrome. Clear? So the lateral wall of your oropharynx is going to be having a palatine tonsil. Can you see here? So this is called as your palatine tonsil. Okay, that is going to be lying between your anterior pillar. This is called as anterior pillar. This is called as posterior pillar. Okay, so your anterior pillar extends from your palate to the tongue, and they are going to contain palatoglossus muscle. Your palate, okay, for first one, there is going to be your anterior pillar. This anterior pillar is going to extend from the palate, extend from the palate to the tongue, and they are going to contain palatopharyngeal muscle. This is the only muscle of the tongue which is supplied by the pharyngeal plexus. The first point you're going to remember is the only your pharyngeal, only muscle, tongue muscle, which is supplied by pharyngeal plexus is going to be palatoglossus muscle. So palatoglossus muscle alone, what happens? They are going to be supplied by your pharyngeal plexus. Pharyngeal plexus. Others all are not supplied by your pharyngeal plexus. Now coming to the posterior wall, your posterior wall is going to be extending from your palate to the pharyngeal wall, and they will be containing longitudinal muscles of pharynx. So the palatopharyngeus muscle. So first one is going to be your palatoglossus muscle, whereas your posterior pillar is going to carry palatopharyngeus muscle. I'll write down. So you're going to have anterior and posterior pillar, anterior and posterior pillar in your oral cavity. Your anterior pillar is going to carry palatoglossus muscle, palatoglossus muscle, palatoglossus. Okay, and you're going to have your posterior pillar, which is going to be palatopharyngeus. Okay, palatopharyngeus muscle. Clear, right? Any doubt in this? Remember, the posterior pillar, the palatopharyngeus muscle, they are also have a circular fibers. So this is going to also have a circular fibers, and this circular fiber is going to go posteriorly the posterior pharyngeal wall along with the lower fiber of superior constrictor muscle, and they are going to form a ridge. So what is the ridge that is formed called as? That ridge is called as Passavant's ridge. That ridge is called as Passavant's ridge. Clear, right? So that ridge is called as Passavant's ridge. Now, moving on to talk about when we eat or speak the word which do not have to pass through the nose, the soft palate moves posteriorly and meets your passavant ridge to close your nasopharynx or velopharyngeal isthmus. When the soft palate is unable to meet the passavant's ridge, that is going to be your cleft palate or bifid or your submucous cleft or your paralyzed palate. So now what happens? There is a gap that is going to be produced posteriorly through which the words which usually do not pass through the nose now pass through, and they acquire a nasal resonance. This nasal resonance is what we have called already as rhinolalia aperta. Do you remember rhinolalia aperta, which we read in your larynx? Yes, right? Do you all remember rhinolalia aperta? Do you all remember what is rhinolalia clausa and rhinolalia aperta? So two things are very, very important. Rhinolalias, both rhinolalias are going to be an important question that is asked in your university exam. So I want everyone to be thorough with the difference between your rhinolalia and you have your rhino. Okay, you're going to have two important things, rhinolalia. Number two is going to be your rhinolalia aperta. Okay, you're going to have your aperta also. Clear, right? Any doubt till now? Rhinolalia clausa and rhinolalia aperta. Aperta means AP. P stands for your palate. So it is going to be having hypernasality. So rhinolalia clausa is going to be closed nose. Okay, so what are the causes of rhinolalia aperta? Can you tell in the chat box? Already completed larynx, isn't it? Can you put in the chat box what are the causes of rhinolalia aperta? Number one, it is going to be your cleft palate. Number two, submucosal cleft palate. Number three, palatal perforation. Number four, palatal paralysis. Number five, bifid uvula. And number six, palatal weakness or velopharyngeal insufficiency. Can you again repeat along with me? What is called as your rhinolalia aperta? It is hypernasality of voice. So what are the structures that are going to, what are the causes of your rhinolalia aperta? Number one, it is going to be a cleft palate. Number two, submucosal cleft palate. Number three, septal perforation. Number four, palatal paralysis. Number five, bifid uvula. And number six is palatal weakness or velopharyngeal insufficiency. Do you guys have any doubt in this? No, right? Yes. So now going towards the next one. So this is all about your, this is going to be your uvula. This is your soft palate. This is going to be your palatopharyngeal arch. This is going to be palatoglossal arch, and this is going to be a palatine tonsil. So can you see here? So this is your hard palate, soft palate, uvula, palatine tonsil, and you're going to have your tongue. Okay, now coming to the last one, that is going to be your laryngopharynx, otherwise called as hypopharynx. The laryngopharyngeal cavity can be visualized as a space with anterior and anterolateral posterior limitation. Anteriorly, it is the mucosa covering the posterior surface of cricoid, that is called as post-cricoid area. So what is the importance of this post-cricoid area? So anteriorly, the superior aspect, you're going to have your post-cricoid area. So this post-cricoid area is the most common site of cancer in females suffering with Plummer-Vinson syndrome. Can you put in the chat box what is the other name of Plummer-Vinson syndrome? Other name of Plummer-Vinson syndrome? Anyone? What is the other name of Plummer-Vinson syndrome? Anyone? Can you put in the chat box? What is the other name of Plummer-Vinson syndrome? Can you put in the chat box? Peterson-Killey. Full complete பண்ணுங்க. Patterson-Killey Brown syndrome. It's called as Patterson-Killey Brown syndrome. Very good, Ravi Krishna. So anteriorly, you're going to have your post-cricoid area, and anterolaterally on the both the side of your mucosal fold that comes from your thyroid anteriorly to your cricoid posteriorly. So this mucosal folds you're going to have. This mucosal fold is called as your pyriform fossa. Remember, there are some mucosal fold that is coming from your thyroid. So that is called as your pyriform fossa. This pyriform fossa is going to act as a lateral channel for passage of food. And they are also a very important area for the lodgement of foreign body. And the internal laryngeal nerve that passes in between your middle and superior constrictor is going to lie superiorly in your pyriform fossa. Because of that, what happens whenever your pyriform fossa is going to get injured? What is the nerve that is going to get injured? It is again your internal laryngeal nerve. Okay, so now coming to the nerve supply of pharynx, write it down separately. So what is going to be the nerve supply of pharynx? Nerve supply of pharynx. So the nerve supply of pharynx is going to include, okay, sensory supply of nasopharynx is done by, can you tell me, can you guess and tell me, in nasopharynx, what is going to be the sensory nerve that is going to be supplying? It is going to be your maxillary nerve. It is going to be your maxillary nerve. Similarly, the sensory supply in your oropharynx. In oropharynx, it is going to be glossopharyngeal nerve, and partially it is done by your maxillary nerve. Partially it is done by your maxillary nerve. And then you're going to have your sensory supply of hypopharynx. Your hypopharynx is going to be supplied by your vagus. So it's going to be supplied by your vagus. So all the muscles of your pharynx are supplied by your cranial part of accessory nerve through the branches of vagus, except for the stylopharyngeus, which is supplied by glossopharyngeal nerve. So remember, all the pharyngeal muscles are going to be supplied by your pharyngeal plexus, except your stylopharyngeus, which is actually supplied by your glossopharyngeal plexus. The inferior constrictor also receives supply from your recurrent laryngeal nerve. Is it clear, guys? Do you have any doubt till now? Is there any doubt till now? So we have already seen the layers of your pharyngeal. This is going to be a Waldeyer's ring. If you want, you can take a screenshot. This is going to be a Waldeyer's ring. So now coming to the lymphatic drainage of your pharynx. So lymphatic drainage, oral cavity is drained in first, second, and third, whereas oropharynx is derived from the deep second, third, and fourth neck nodes, and nasopharynx is going to be 2, 5, 3 neck nodes. Okay, so now you know what are the spaces, different spaces we have already seen. So we have seen already the different spaces, and taste pathway you all know. Now the function is basically one is to conduit of air, ventilates your middle ear through eustachian tube, and similarly it is going to help in the conduit of air and food. Now, okay, deglutition can be of 3 stages: oral stage, pharyngeal stage, and esophageal stage. So these are the 3 stages that are going to be present. Now, after completing all these, now we are going to move towards the oral cavity. So dingrala வந்து oral cavity தனியா ஒரு 4-5 chapter கொடுத்திருப்பான். But I'm going to just combine and tell you what all important. That alone I'm going to teach you. Okay. So now coming to the first one, that is going to be development of tongue. You need to remember the development of tongue. See, after completing the anatomy, I'll give you a 10 minutes break. So around 10-15. So in next 15 minutes, I'll complete the entire anatomy of your oral cavity also. also. After that, I'll give you a 10 minutes break or 15 minutes break. 10:30, you can join again, and we will start with the pathology of your pharynx. Clear, right? Now coming to the development of tongue. So in development of tongue, you have to remember that from the mesoderm of first brachial arch. From the mesoderm of first brachial arch, there are three thickenings that are going to develop. So there are going to be three thickenings that are going to develop. So these three thickenings, what happens is, so what are the three thickenings? Two is going to be your lingual swelling. So you're going to have two lingual swelling like this. And then you're going to have one tuberculum impar. So there is going to be a two lingual swelling and one tuberculum impar. So these three fuse together to form the anterior two-third of the tongue. So these three are going to fuse together and they are going to form the anterior two-third of the tongue. Anterior two-third of tongue. Now coming to the posterior, okay, anterior two-third develops from the first arch. That is the first point you're going to remember. And now coming to the second thing, from the mesoderm of the third and fourth brachial arch, okay, there is going to be another midline thickening that is going to be arise. Can you see here? There's going to be a third and there's going to be a fourth. Between your third and fourth brachial arch, you're going to have a midline thickening. So this midline thickening, you're going to call it as hypobranchial eminence. Hypobranchial eminence. Okay, you're going to call it as hypobranchial eminence. Clear? So you're going to call it as hypobranchial eminence. Now, hypobranchial eminence divides into two parts. One is a cranial part and another is a caudal part. So upper part it goes as cranium and lower part is called as your caudal part. Okay, the cranial part, which is derived from your third arch, they lead to the formation of posterior one-third of the tongue, except the posterior most part. So this area, it is going to form the posterior one-third of the tongue. So it's going to form the posterior one-third of tongue, except posterior one-third of tongue, except the posterior most part. The posterior most part is formed by the caudal part of your hypobranchial eminence. This hypobranchial eminence caudal part, this is going to be fourth arch. Going to be fourth arch derivative. So the rest of the caudal part leads to the formation of epiglottis. So for caudal part or konja part on the tongue develop agudhu. Meedi ellame they are going to help in formation of epiglottis. Clear? Now, during the formation of posterior one-third of the tongue, the third arch overgrows the second arch. Now, what happens? The third arch is going to overgrow your second arch. This is going to be a third arch. This third arch is going to overgrow to your second arch. So what happens is, because of this overgrowth of your third pharyngeal arch into your second pharyngeal arch, third pharyngeal arch into second pharyngeal arch, the second arch does not contribute to formation of tongue. So second arch does not contribute to the formation of tongue. So it's going to be either the first arch or the third arch, okay, and fourth arch. So the muscles of the tongue are derived from the occipital somite. Now coming to the muscles of tongue. Muscles of tongue. So muscles of tongue, remember, so they are derived from the occipital somite. Occipital somite. Okay, it is going to be occipital somite. Okay, and hence they are supplied by your hypoglossal nerve. So hence they are supplied by your hypoglossal nerve, except for palatoglossus, which is supplied by your pharyngeal plexus. So they are formed by the vagus along the cranial part of your accessory nerve. Now coming towards, I'll just summarize it in the table. I want you all to write it down along with me. So tongue oda development, I'm just going to write along with you. So remember, first arch develop agudhu, third arch develop agudhu, fourth arch develop agudhu. First arch anterior two-third of the tongue. So third arch posterior one-third, fourth arch posterior most. So it's going to be posterior most. Okay, now coming to the sensory supply. What are the sensory supplies? Number one, it is going to be lingual nerve. So lingual nerve is a branch of mandibular nerve, which is a first nerve branch. Okay, then coming to your glossopharyngeal nerve. So it is going to be in the third nerve arch. Then you're going to have the internal laryngeal nerve, branch of superior laryngeal nerve. Clear? This is going to be your sensory nerve. Now coming to the motor sensation. So first one is going to be a chorda tympani, otherwise called as pre-tympanic nerve of first arch. Then it is going to be your glossopharyngeal nerve, and finally you're going to have your internal laryngeal nerve. Internal laryngeal nerve. Any doubt in this? Any doubt till now? Do you have any doubt till now? If you have, you can put it in the chat box. With this, next we are going to talk about the anatomy of oral cavity. So the external surface of your lips are not included in your oral cavity. Oral cavity lips நம்ம include பண்ண மாட்டோம். So lipsல சில discoloration, ulceration, vesicles அதெல்லாம் இருக்கலாம், but we won't include. Next comes your soft palate. Soft palate with uvula, tonsil, posterior one third of tongue are not component of your oral cavity. They are component of your oropharynx. அப்ப எதுதான் oral cavity? Oral cavity is something that extends from the mucous surface of your lip to the anterior pillar of tonsil. So can you see here? So this is going to be your anterior pillar of tonsil. From your anterior pillar, you're going to call it as oropharynx. So therefore, from the mucosal membrane of your lip to your anterior pillar, that area is called as your oral cavity. So the oral part of the tongue is separated by its two oropharyngeal part by a V-shaped groove known as sulcus terminalis. Just anterior to your sulcus terminalis, large papillae called as circumvallate papillae are arranged in the V-shaped. Now, the circumvallate papillae gets a special afferent tissue innervation from the cranial nerve 9. So, I'll show you the diseases. We will go later, don't worry. Now coming to talk about your, now when you're going to talk about this layer, so what happens is, you're going to have your circumvallate papillae. So if this is going to be your tongue, you're going to have a circumvallate papillae all around. So what is this role of your circumvallate papillae? They are going to help in the identifying the taste sensation. So they get special afferent taste innervation from the cranial nerve 9, that is glossopharyngeal nerve, even though they are anterior to your sulcus terminalis. Now coming to the lymphatic drainage, tip is drained by a submental, that is level 1, and tip anterior 2/3 வந்து drained by your submandibular lymph node, anterior 2/3 remaining part it's going to be derived from your submandibular lymph node, and finally posterior 1/3 is otherwise called a jugulodigastric lymph node, and middle deep cervical lymph node, and the upper deep cervical lymph node. So these are the lymph nodes that are going to carry. So with this, I'm just completing a very important topic, that is going to be anatomy, as I promised. So let's come back at 10:25. So I want you all to come back at 10:25 a.m. where we will start discussing the pathology behind all these structures. Now we know what is the anatomy. So next we are going to go into the structures and its a problem. Okay. So see you all at 10:25, guys. I want you all to join. And if you, in the meanwhile, if you have any doubt in the anatomy, you can post it in the chat box so that I will be answering. Okay. Okay. Now we are discussing about your adenoid hypertrophy. So what are the causes of adenoid hypertrophy? Number 1, adenoid hypertrophy is going to be present in the school-going children. Okay. Number 2, they are associated with recurrent upper respiratory tract infection. Physiologically itself, in some children, there is going to be hypertrophy present, and allergy in the upper respiratory tract can be there, and low socioeconomic status is one important problem which you are going to have, and crowding and environmental pollution. All these are going to be the causes of your adenoid hypertrophy. Now, moving on to talk about the causative organisms, the most common upper respiratory tract infection caused here is going to be your Haemophilus influenza, group A beta hemolytic streptococcus, and your streptococcal pneumonia. So all these are going to be the most common. So because of these, what happens is now this is going to infect your area, and that is going to cause increase in the size of your adenoid, because basically adenoid is a lymphatic tissue. So lymphatic tissues will be, your lymphatic follicles will be like proliferating whenever there is some infection. Because of that, that is going to stimulate your lymphoid follicles. Okay, so what are the clinical features? Remember, there are 3 common features in all your nasopharyngeal disease. So what are the 3 common features in all your nasopharyngeal diseases? Can you tell me? So whatever we are going to discuss, so there is some common symptoms that is present in all the nasopharyngeal diseases. So what are they? Number 1, you will all will be having a nasal obstruction. Any disease that is going to be pertaining towards your nasopharyngeal area, so that is going to have a nasal obstruction. Number 1. And number 2, there will be a Eustachian tube obstruction. Whenever there's a Eustachian tube obstruction, it's going to lead to serous otitis media. And third one is going to be your rhinolalia clausa. rhinolalia clausa. So these three are going to be the common symptom which you can write in any nasopharyngeal diseases. Now moving on to discuss about the particular symptom in your adenoid. In adenoid, apart from these three symptoms, nasal obstruction, eustachian tube obstruction, rhinolalia clausa, the patient will also have a occipital headache. Occipital headache will be there. The patient will be having a sore throat and fever. Sore throat will be there. Fever will be there. And the patient will have a persistent post-nasal dripping will be there. Post-nasal dripping will be there. And the patient will also have a sleep apnea. The patient will also have a sleep apnea. So let's discuss one by one. Okay, first one, nasal obstruction. Why there is a nasal obstruction here? Because your adenoid is going to block your nasopharynx. So because of the nasal obstruction, the nose is not able to breathe. So when the nose is not able to breathe, what happens? When the nose is not used for breathing, what happens, guys? Can someone tell me? First thing that is going to be happening is there is going to be a disuse atrophy of nose. Disuse atrophy of nose. So that is the first thing that is going to occur. Second thing is going to be now there is going to be a your nose is not used for breathing. Because of that, the alar prominence which are present in your external framework of nose, that is going to become absent. So there is going to be a absence of alar prominence. Alar prominence. There's absence of alar prominence. Number 2. Number 3 is going to be there will be a loss of nasolabial crease. Nasolabial crease. இது எல்லாமே ஏன் ஏற்படுது? Because of the nasal obstruction and because of the disuse of your nose. Now, whenever there is a loss of nasolabial crease, this will lead to pinched up appearance. Pinched up appearance. Okay. Now, after this, what happens? Now, the child will be starting to breathe through the mouth. When the child starts to breathe through the mouth, what happens? The child will always have a open mouth. The child will always have a open mouth. Number 5, now the teeth will be starting to crowd. So there is a crowding and the prominence of anterior upper teeth. So there is going to be a prominence of upper teeth. Upper teeth. Okay. And next important point is there is going to be eye arched palate. Eye arched palate is going to be present. So all these will be leading to a dental malocclusion. Dental malocclusion will be occurring. Okay, clear, right? So these are the 6 important points you have to remember. Now, the next thing is because of the nasal obstruction, so child will also have a recurrent sinusitis. Recurrent sinusitis. Recurrent sinusitis. So these all the 7 points is what you're going to call it as a adenoid facies. You call this child as adenoid facies. What is adenoid facies? An important 2-mark question before your CBME curriculum. So disuse, atrophy of nose, absence of alar prominence, loss of nasolabial crease or pinched up nose, and then you're going to have your open mouth. Then there is going to be prominence of your upper teeth, eye arched palate, and recurrent sinusitis. So ultimately what happens? The patient will be having a failure to thrive. That is, inadequate weight gain will be present. Inadequate weight gain will be there. So this is all about your features that is going to occur due to the nasal obstruction. Next is going to be, you're going to have a eustachian tube obstruction. So whenever there is a eustachian tube obstruction, since your adenoid is a midline mass, it leads to obstruction of both your eustachian tube. So that leads to bilateral serous otitis media. It leads to bilateral serous otitis media, and the patient will be having a conductive hearing loss. The patient will have a conductive hearing loss. Okay, now because of this hearing loss, the child will seem to be lost, or during the normal conversation, the child will be always looking dull, and the child will be always lost in between the conversation because the patient will be having a difficulty in hearing. And because of this, what happens is the child will have a recurrent attack of otitis media, OM. So ear pain patient will be experiencing, and there can be acute otitis media sometime because of infection can come because of the obstruction, right? So it can lead to a acute otitis media. So the appearance with this pinched nose, alar prominence absence, loss of nasolabial crease, along with the dull look in the face. Along with the dull look in the face, you're going to call it as a adenoid phase. Is a very important. Then, due to the obstruction of your nasopharynx, the child will have a hyponasal voice. The child will have a hyponasal voice. Hyponasal voice, that is called as rhinolalia clausa. Then coming towards your fourth one, that is going to be your sleep apnea, very important. So the chronic adenoid hypertrophy is often associated with the tonsillar hypertrophy. So this leads to sleep apnea, leading to daytime somnolence. So more than 30 apneas, an episode of apnea. When do you call it as apnea? Anyone? Do you know when will you call it as apnea? So whenever there is going to be more than 30 apnea, whenever there is going to be more than 30 apnea, that is going to be loss of breathing. Okay, so there is a episode of cessation of breathing. So there is going to be episode of cessation of breathing that is going to last for more than 10 seconds. So that is called as apnea, and there will be more than 30 seconds, 30 apneas, then you're going to call it as, okay, if there is going to be more than 30 apneas in 7 hours of sleep, in 7 hours of sleep, then you're going to call it as a sleep apnea. Okay, clear, right? So now remember, long-standing sleep apnea will lead to hypoxemia, and that leads to pulmonary vasoconstriction. So pulmonary vasoconstriction இருந்தா என்ன ஆகும்னா, so for a prolonged period, if you're going to leave the sleep apnea without treating the patient, they will lead to pulmonary hypertension. It will lead to pulmonary hypertension. This pulmonary hypertension will lead to right heart failure. You call it as a cor pulmonale. Cor pulmonale. So that can be the result of your sleep apnea. Therefore, sleep apnea is a very important pathology that needs to be treated. Now, moving on to talk about how do you diagnose. Now we have completed all this, right? Now we are going to move towards how do you diagnose this. So this is going to be your adenoid phases. So now on examination, so you're going to go for examination. Rhinoscopy பண்றீங்க. Bilateral purulent nasal discharge will be there. Then post-nasal mirror examination you're going to do, you can actually see this adenoid. Okay, bilateral adenoids can be seen. Now you are going to go for the diagnosis. How do you go for diagnosis? Either you can go for direct visualization, okay, direct visualization under endoscopy. But many patients will not accept to do endoscopy immediately. So what you will do is you go for X-ray. So in X-ray, if you're going to see, can you see here? So in X-ray, in your X-ray nose and nasopharynx lateral view, you can see that there is going to be hypertrophy of adenoid mass. So can you see here? So there is going to be a hypertrophy of adenoid mass as I have shown in the, as I have shown in your in your image. Okay, so in your image, I have just pointed out like this. So this is called as adenoid. So S-shaped adenoid can be seen in the X-ray. Okay, so X-ray. How to interpret this X-ray? This is also very important. X-ray interpretation is kept in your Viva, right? So first you have to tell that this is an X-ray lateral view of head and neck. So I can identify that this is a skull. This is going to be your this is going to be your mandible. This is going to be your maxilla, and you're going to have your palate. This is going to be a soft palate. So just behind your soft palate, I can see that there is a adenoid hypertrophy. So there's going to be your adenoid, and you can see adenoid hypertrophy somewhere here. So அந்த மாதிரி நீங்க explain பண்ணணும், and you will be also expected by the examiner to tell the normal structures. So than telling the abnormal structures, the usual examiner's expectation is going to be to examine for you to tell the normal structures. So this is going to be a trachea. This is going to be your epiglottic fold. This is epiglottis. This is palatine tonsil. And this is going to be your esophagus. And esophagus is going to go start from here. So this is your pharynx. And here you're going to have your esophagus, which is going to start. Clear, right? So this is your X-ray. And this you have to determine the enlargement of adenoid in proportion to that of your nasopharyngeal airway. So crescent sign will be absent. Okay, now moving on to talk about the differential diagnosis. Either it can be a nasopharyngeal angiofibroma, it can be antroconal polyp, it can be nasopharyngeal tumors, it can be rhinosporidiosis. How do you manage this patient? So, acute adenoiditis should be treated first with antibiotics. Any acute adenoid Congenital. So adenoid inflammation must be treated with antibiotics. They have to be treated with antihistaminics and they have to treat it with decongestion. Okay, well, so you have to wait and watch if there is going to be acute adenoid infection. So if the patient does not benefit from a medical management, or at least 6 weeks you're going to give, even after 6 weeks there is no change, but there is a significant adenoid hypertrophy, then you're going to take the patient for adenoiditis. If not, you have to just symptomatically manage the patient. So how do you manage symptomatically? Symptomatically manage the patient is, number one, you're going to give antibiotics. Number two, you have to go for antihistaminics. Antihistaminics. Number three, you're going to go for decongestants. Can you tell me an example of nasal decongestants? Anyone from your pharmacology, which you read last year, can tell me an example of nasal decongestants? So what is the name of the nasal decongestants which we are using? You would have read in ANS chapter. Anyone? Anyone, do you remember? Very good. Oxymetazoline, other name, other drug. Oxymetazoline and other drug. Can you recall and tell me the other drug, oxymetazoline and other drug? Xylometazoline, excellent. So you have oxymetazoline and xylometazoline, which is going to be acting as a nasal decongestants. So you're going to use nasal decongestants. But in some conditions where the adenoid is very big and causing nasal obstruction, snoring, sleep apnea, so you have to do adenoidectomy. So now we are going to see what are the indications of adenoidectomy. Adenoidectomy. Let's see the indication of adenoidectomy, guys. Number one, it is going to be your recurrent sinusitis. So this is a short note question. So what are the indications of adenoidectomy? So recurrent sinusitis. Recurrent sinusitis. Number two, it is going to be your recurrent serous otitis media. Recurrent serous otitis media. Number three, when the patient is going to have a recurrent CSOM. Okay, CSOM, or when the patient is going to have a sleep apnea. Sleep apnea, when there is going to be a dental malocclusion. Dental malocclusion. So you're going to perform adenoidectomy. So these are the indications of adenoidectomy. Then knowing the procedure of adenoidectomy, what is expected from you is indication, complication, contraindication. Any procedure in your surgery or your ENT or in your ophthalmology, the thing which the examiner will be expecting from you is indication, complication, contraindication. Next, we are going to move towards the contraindications of adenoidectomy. So what are the contraindications of adenoidectomy? So first contraindication is going to be DiGeorge syndrome. Can you tell me what do you have in DiGeorge syndrome? DiGeorge syndrome. What do you have in DiGeorge syndrome? Can you tell me? What do you have in DiGeorge syndrome? Anyone? So we call it as catch 22. So catch 22 stands for chromosome 22 is going to be affected. So what do your catch stands for? Anyone can tell me what do your catch stands for? Anyone can you tell me what do your catch stands for? Velopalatal insufficiency is one part. Others. So remember, so you should never forget this catch 22 in your DiGeorge syndrome. Okay, so this is a very important question if you're going to especially go for USMLE or other aspects. So catch 22 is a repeated question. C stands for conotruncal cardiac anomaly. Okay, ma. And what is A stands for? Abnormal facies. And T stands for thymic hypoplasia. And what does C stands for? Cleft lip and cleft palate. And this cleft palate is the one that leads to velopalatine insufficiency or velopharyngeal insufficiency. Then H stands for your hypocalcemia. Okay, this is a very, very important thing. So what happens in this? So what happens when there is a cleft palate? See here, whenever you're going to have a cleft palate or bifidula or your palatal paralysis, the soft palate will not be able to move posteriorly. when the soft palate is not able to move posteriorly and meet your Pavlov's ridge, that is close to your nasopharyngeal isthmus. So nasopharyngeal is the end of your nasopharynx. The isthmus la poi, unga Pavlov's ridge has to meet. If this Pavlov's ridge is not meeting, if there is a gap present posteriorly because of the because there is going to be a insufficiency in the palate. Okay, you're going to have your soft palate like this. This soft palate will be having a something called as Pavlov's ridge. So this is called as your Pavlov's ridge, and this is going to be your nasopharynx. Okay, this is going to be your nasal cavity, oral cavity, nasopharynx, oropharynx, and this is going to be your nasopharyngeal isthmus. So this is a place where you're going to have your nasopharyngeal isthmus. So your Pavlov's ridge has to meet your nasopharyngeal isthmus. If it is not meeting, can you see there is a small gap between? If there is a small gap between, what happens is, okay, the patient will be having a hypernasality. Okay, the patient will be having a hypernasality and nasal regurgitation of food. So there is going to be a hypernasality, and the patient will be having a nasal regurgitation of food. Now, if the patient is going to develop a adenoid hypertrophy, you all know adenoid hypertrophy is something here. So whenever there is going to be adenoid hypertrophy, what happens is this is going to close your palatal ridge, the gap between your palatal Pavlov's ridge and your nasopharyngeal isthmus. Because of that, what happens? You will not have hypernasality now. There won't be any nasal regurgitation of the feeding milk which the child is going to take. Because of that, what happens is, now if you are going to do adenoidectomy in this patient, so what happens? Again, there is going to be hypernasality or nasal regurgitation. Therefore, you should first correct that, and then you should go for your adenoidectomy. So adenoidectomy is not going to be done in these conditions. So contraindication of adenoidectomy you need to remember. So first correct the cleft palate or correct your Pavlov's ridge, then you are going to go for the adenoidectomy. Second thing is going to be your acute adenoiditis. So whenever there is going to be acute adenoiditis, so you should never perform a adenoidectomy, because so there is a chances. Why? Because chances of hemorrhage will be present, and number two, there is going to be a increased chance of infections and septicemia. And third thing is going to be whenever patient is going to have any bleeding disorders. Bleeding disorders. So these are going to be the complications of your adenoidectomy. Now coming to the third one, what are the complications of adenoidectomy? What are the complications of adenoidectomy? So let's talk about the complications of adenoidectomy. The complication includes first one, that is going to be hemorrhage. Okay, so this hemorrhage can be managed by post-nasal packing. So how do you treat this hemorrhage? By post-nasal pack. And what are the other complications? Number two is going to be your hypernasality. As I told you, see, if there is going to be a velopharyngeal insufficiency which is unrecognized, so that can actually lead to, when you're going to remove your adenoid, what happens? It is going to increase the gap, and that is going to lead to hypernasality. And number three is going to be your eustachian tube may get injured, and that can lead to stenosis of eustachian tube. That can lead to eustachian tube stenosis, and the very rare complication is going to be your Grissel syndrome. So rare complication is going to be Grissel syndrome. Grissel's syndrome. What is this Grissel syndrome? Let me tell you. Grissel syndrome is a inflammatory subluxation. So Grissel syndrome is nothing but inflammatory subluxation of atlantoaxial joint, and it can result in local post-operative inflammation or infection. So it can lead to local post-operative inflammation or infection. Okay, wow. So the child will be presenting with post-operative neck pain, stiffness, fever. So how do you treat this? Treatment is very easy. You're going to give antibiotics, and you're going to make the patient immobilized. So you're going to make sure that the neck is not mobilized for next few days. So you're going to give a cervical immobilization. Cervical mobilization. So now to remember about your surgical technique of adenoidectomy. So what are the surgical technique? So remember the surgical technique of adenoidectomy is going to include number one. So nowadays we are going to use a endoscopic visualization. So nowadays we are actually using an endoscopic visualization. Nowadays we are not actually going for a proper manual methods. So we are not going for manual methods. Instead, we are nowadays going for a mechanical methods. Nowadays, we are going to move towards the mechanical methods. So the first one among them is going to be your what type of surgery we are going to perform. So now we are going to perform adenoidectomy. So how is adenoidectomy performed? Anyone, can you tell me what is the position you're going to keep in adenoidectomy? What is the position you're going to keep the patient in adenoidectomy? Come on. What is the patient? How is the patient kept in adenoidectomy? Adenoidectomy in the patient in the position. Very good. So you're going to keep the patient in the rose position. So after keeping the rose position, next procedure in anyone? What will be a next procedure? After keeping your patient in the adenoid, okay, you're going to keep the patient in rose position. Then you're going to go for anesthesia. Very good. General anesthesia is given. The third thing is you're going to use a Davis Boyle mouth gag. So mouth gag and tongue depressor. And you're going to use a tongue depressor. Okay, tongue depressor. So they are going to consist of a Davis gag and Boyle's depressor, tongue depressor. So Davis is going to be your, it's going to be your gag, and you're going to have your Boyle's is going to be your tongue depressor. So tongue depressor. So you're going to have this, you're going to put it under. So you're going to first put that, and then you're going to gag the mouth, and now you will be able to visualize your tonsil. Now what you're going to do is, you're going to give what you're going to do. So you're going next procedure in that. You're going to take a curette. What is that curette called as? Saint Clair's Thompson adenoid curette. Adenoid curette. I'll show you the images, don't worry. So you have St. Clair Thompson adenoid curette. So with this St. Clair Thompson adenoid curette, what you're going to do? You're going to do this adenoid curette will be having a strong handle, a shaft, and a curette. That curette will be curved so that you're just going to remove the tissues. You're going to just remove the tissues, and after removing the tissue, you're going to just suture your all your vessels, and then you're just going to close. So you're going to pack and then close. So this is all about your adenoidectomy. Clear, right? Any doubt in the adenoidectomy? Nowadays, we use some cold methods also, or we can use hot methods like your electrocautery. So I'll just show you the procedure step by step. So you have to remember all the steps. And adenoidectomy, you can perform a traditional curettage method or endoscopic assisted curettage method. Nowadays, you have micro debrider or co-ablation technique. Okay, these are the techniques of adenoidectomy which is performed nowadays. Okay, we have already discussed about the complications. Next, you are going to have something called as Thornwald's disease. What is the Thornwald's disease? It's nothing but a nasopharyngeal bursitis. So they are nothing but they are going to be what is the Thornwald's bursa? It is an inconstant blind sac that is located in the midline. So they are going to be the cystic remnants of your notochord. They are present as a median recess at the junction of the roof and the posterior wall of your nasopharynx. So it extends from your mucosa of your nasopharynx to your occiput. So because of this extension, what happens is there is going to be, whenever there is going to be inflammation, so this inflammation will be causing a postnasal drip, crusting in the nasopharynx. You will have a hard of hearing because due to otitis media, there will be a dull occipital headache, recurrent sore throat, and low fever. How do you diagnose? By using a X-ray. So we have clinical features, but prominent is going to be by X-ray. And how do you treat this patient? So treatment is going to be gram-positive and anaerobic organism against the antibiotics you have to give. And remember, in the clinical features, on examination, so examination finding bookla clear irukadu, write it down. On examination, you will be having a cystic fluctuant swelling in posterior wall of nasopharynx. Posterior wall of nasopharynx. That is going to be the examination finding you're going to have. So you can have a crusting also. So whenever there is a crusting, you go for marsupialization of the bursa using endoscope or micro debrider. So with this, we are completing the adenoid hypertrophy or Thornwald bursitis. So next 2 minutes, I'll ask you some questions if you are going to answer me. In a patient with hypertrophied adenoid, what is the voice abnormality you're going to see? A patient with hypertrophied adenoid, what is going to be the abnormality of voice this you are going to see? Can you put in the chat box? Can you put in the chat box what is going to be the voice abnormality you're going to see? What is going to be the voice abnormality you're going to see? Come on, come on. All 10, those who are in the those who are in the session, can you just put in the chat box? What is going to be the voice disorder? Rhinolalia. You're going to have rhinolalia. You're going to have rhinolalia. Clausa. Excellent. So you're going to have rhinolalia clausa. Next question. What is Dodge sign? I think I haven't told you this. Remember, whenever you're going to have an antroconal polyp, still we haven't referred to the nose, right? So in antral conal polyp, whenever it is going to be there, that is going to come and it is going to look like your adenoid. So that's what we are going to call it as Dodge sign, D-O-D-D, Dodge sign. Can you tell me what is the most common complication of your adenoidectomy? Most common complication of adenoidectomy. Anyone? What is the most common complication of adenoidectomy? Most common complication of adenoidectomy. எந்த ஒரு சர்ஜிக்கல் கண்டிஷன்ஸ் இருந்தாலும் மோஸ்ட் காமன் அப்படின்னு கேட்டாங்கன்னா எமரேஜ். கண்ணை மூடிட்டு எமரேஜ் அப்படின்னு நீங்க சொல்லலாம். ஓகேவா? So that comes to the end of your adenoid. So now we are going to move towards the next one. That is going to be after completing your adenoid. Now we are going to move towards the next one. That is going to be your angiofibroma. Are you all ready? Are you all listening? Shall we move towards the angiofibroma? So very, very important topic is going to be your angiofibroma. Okay, so this is going to be the tumors of your nasopharynx. So in tumors of nasopharynx, remember, you're going to have two important tumors. Okay, there is going to be two important tumors of your nasopharynx. There is going to be a two important tumor of your nasopharynx. So this is a slide I prepared during my third year. So while I was taking a seminar in my college, I prepared this slide. Okay, so that same slide I'm using with some modification and some updates. Okay, so what are the tumors of nasopharynx? So tumors of nasopharynx, there are two tumors. One is going to be a benign tumor and second is going to be a malignant tumor. So benign tumor is going to be your angiofibroma. Angiofibroma. And what is a malignant tumor? Your malignant tumor is going to be nasopharyngeal carcinoma. So these are the two important tumors which we are going to read. So let me start with your angiofibroma. Remember, angiofibroma is the most common. So angiofibroma, otherwise called as juvenile nasopharyngeal angiofibroma. This is going to be the most common benign tumor of your nasopharynx. It is benign, but they are locally invasive. Though we call it as a benign, they are going to be locally invasive tumor. So that's why you call it as a nasopharyngeal fibroma. So it is typically occurring in the young adolescent male, especially during whenever they are going to near their puberty. That's why we call it as juvenile nasopharyngeal angiofibroma. Exclusively, they are going to be occurring in the male who are going to be near the puberty. So this indicates that there may be some hormonal etiology. There may be hormonal etiology, but still we are not sure of etiology, what exactly causes your nasopharyngeal angiofibroma. Recently, it was proposed that it is actually due to some vascular malformation. Because of some testosterone, there is some vascular malformation, and that vascular malformation, which is going to be arising from the remnants of first brachial arch. So இது வந்து ரீசெண்டா வந்தக்கூடிய research finding. So this is thought to be one of the probable cause, but we are still don't know exact cause. And remember, this juvenile angiofibroma, nasopharyngeal angiofibroma, they are going to originate from, they are going to be originating from spinopalatine foramen. Spinopalatine foramen. They are going to be originating from your spinopalatine foramen. Okay, which connects the nasopharynx with your spinopalatine fossa. Okay, so you have to know what is spinopalatine fossa and what is the anatomy, spinopalatine foramen, everything that we will be discussing in the nose. Okay, probably in the afternoon. And coming to the clinical features, you are going to remember that from the sphenopalatine foramen, it grows into. Now what happens? I am just skipping all this pathology. This is all not important for you. Even if your textbook has all these points, kindly skip this. This is not important for you because all those are going to be some of the they are some hypothesis, but you don't know what exact cause. So what is the exact cause? And no one knows. Okay, no one knows what is the exact cause. So it's not important to remember. It's not important to remember. Okay. Now coming to the angiofibroma. So angiofibroma, it may be hormone sensitive அப்படின்னு சொல்றாங்க. Genetics. So in genetics, what happens is, remember CMYC gene. CMYC gene is a common gene that is associated with your angiofibroma. So angiofibroma is going to be a locally invasive tumor. So they are going to come from your, okay, so remember, they are going to be firm, lobulated, pink, white, no capsule. And when you're going to do a microscopic examination, there will be a vascular spaces with varying size and shape. So origin எங்கேருந்து இருக்குன்னு பார்த்தீங்கன்னா from your sphenopalatine foramen. So from your sphenopalatine fossa, it is going to come into your sphenopalatine foramen, and from your sphenopalatine foramen, it is going to grow into your nasopharynx and adjacent nasal cavity. As the name suggests, it is an angiofibroma. So angio means blood vessel. Fibroma means fibrous tissue with no muscle coat. So because of that, what happens is recurrent. What happens? These blood vessels will get injured, and they will be causing a recurrent episode of epistaxis. The patient will have a recurrent episode of epistaxis will be there, and they are going to come through your sphenopalatine foramen into your nasopharynx. Because of that, there will be an obstruction in your nasopharynx. So you are going to have an obstruction in the nasopharynx, and because of its growth in the nasal cavity, there can be a splaying of your nasal bone, which will be leading to widening of your nasal bridge. So this leads to widening of your nasal bridge. Okay, so widening of nasal bridge. On anterior rhinoscopy, when you're going to look, there will be a red fleshy mass will be present. On anterior rhinoscopy, you can see a red fleshy mass in the nasal cavity. Due to obstruction of the ET tube opening, which is present in the lateral wall of nasopharynx, the patient will also have a unilateral serous otitis media. So the patient will also have a unilateral serous otitis media, and conductive hearing loss will be present. Later, it is going to spread to the opposite side also, and it can lead to bilateral serous otitis media. Then this tumor grows laterally from your sphenopalatine foramen into the sphenopalatine fossa. So it fills the fossa completely, and it is going to derive the blood supply from your maxillary artery and sphenopalatine artery, which is present there. On further expansion, what happens? They are going to push your posterior wall of your maxillary antrum anteriorly. So when it is going to push your posterior antrum anteriorly, what you can see is, you can see some swelling over here. Can you see it? You can see some swelling over here. And when you're going to perform a X-ray, okay, when you're going to perform a X-ray and your CT scan, especially when you're going to perform a CCT, what you can see is there is going to be widening of your sphenopalatine foramen. There will be a widening of your sphenopalatine foramen. Okay, so your sphenopalatine foramen will be widened, and what happens is this is going to be your nasopharyngeal angiofibroma, JNA. So this what happens? There is going to be widening of your there's going to be widening of your sphenopalatine foramen. There's going to be widening of your sphenopalatine foramen, and there is an anterior bowing of your posterior wall of maxillary antrum. Can you see here? So this is going to be a posterior wall of maxillary antrum. This is your posterior wall of your maxillary antrum. In this side, can you see here? There's a posterior bowing. So there's a bowing of your maxillary antrum by a hypervascular enhancing mass. This hypervascular enhancing mass, which is going to cause bowing of your posterior wall of maxillary antrum, is called as your antral sign. You call this as antral sign, otherwise called as Allman-Miller sign. Allman-Miller sign. Now, next sign which you are going to see here, next important symptom which you are going to see is, now because of this, what happens? There is going to be a this is going to enter into orbit. So this is going to slowly enter into the orbit. When this mass enters into the orbit, that is going to push your eyeball forward. Can you tell me through which your there is going to be enter of your entry of your your nasopharyngeal angiofibroma into your orbit? Through your inferior orbital fissure. Now it is going to enter into inferior orbital fissure and cause proptosis, and then it can grow into the sphenopalatine fossa, and it can actually go into pterygomaxillary fissure, and that leads to swelling of cheek. So that leads to swelling of cheek will be present. Swelling of cheek will be present. So there can be swelling of cheek is present. Now, coming towards the nasal bridge broadening will be there. This nasal bridge broadening like this. Can you see here? This is going to be a nasal bridge broadening like this. This nasal bridge broadening, you're going to call it as a frog face deformity. You're going to call it as frog face deformity. You're going to call it as frog face deformity. It can also grow intracranially, and they're going to go into the floor of the middle cranial fossa or your sphenoid sinus or into your cribriform plate or into your orbit. So it can go into in every direction it can go, and it can going to cause a problem over there. Now coming to the investigation, the best investigation or investigation of choice is going to be your CECT. You can also take X-ray for visualizing your paranasal sinuses. You have to go for CECT compulsory. You can also go for angiography, digital subtraction angiography, and you can go for biopsy. But remember, biopsy you should never do. Okay, biopsy should be never done because initially they were doing, but you should never do because it's an angiofibroma. If you're going to do biopsy, what happens? There is going to be excessive blood hemorrhage will be occurring. So biopsy is contraindicated because they can cause profuse bleeding, and it is going to be contraindicated here. So contraindicated here. Next one is going to be the staging. So how do you stage your angiofibroma? So staging of angiofibroma is very, very important. The staging is basically done by, okay, the staging is basically done by, you have an important staging name. Can someone tell me what is the staging name? What is going to be the staging name? How do you stage? Anyone? How do you stage? Let me write it down. So initially there was a staging called as session staging. Very good. So initially there was session staging. So session staging divided your tumors into 3 stages. Stage 1, stage 2, stage 3. Stage 3 is direct intracranial extension. Intracranial extension. So whereas grade 1 is going to be, they are divided into 2, A and B. A is going to be limited to nasal cavity, whereas 1B is going to be extension to one or more paranasal sinus. Now coming to the 2, stage 2 is again divided into 2A, 2B and 2C. What is 2A, 2B, 2C? 2A means minimal extension through your sphenopalatine foramen into sphenopalatine fossa. So this is going to be a minimal extension, minimal spread into sphenopalatine fossa. Sphenopalatine fossa. That is going to be your sphenopalatine fossa. So that is going to be your stage 2A. Then comes your stage 2B. 2B is going to be complete filling into the orbit. So it is going to completely going to go via inferior orbital fissure, and it is going to fill your orbit. It's going to fill your orbit. Okay, 1C is going to be extending into sphenopalatine fossa into the cheek. So it is going to extend into the sphenopalatine fossa completely. So that is called as 2C, and you're going to third one is going to be intracranial extension. Now what happens? The same thing whichever we have read till now. So this is going to be your session staging, isn't it? So this is going to be your session staging. Now what happened? This session staging. So this session staging is going to be relabeled. So this was relabeled in future. So how is this session staging is going to be relabeled? They were called as Rodensky staging, Radowski staging. So what is the difference between your session staging and Rodowski staging? In Rodowski staging, there's a recent staging. Here what happened is the third stage alone is divided into 2. In session staging, third stage is just intracranial extension. But here you divided into 3A and 3B in Rodowski staging. What is 3A? 3A means erosion of base of skull with minimal intracranial extension, intracranial extension. That is called as your stage 1, 3A. Stage 3B is nothing but when there is going to be a significant, extensive, unresectable intracranial extension. Intracranial extension, you are going to call it as a 3B, and this is the exact thing which you are going to remember in the nasopharyngeal angiofibroma irukkakoodiya staging. Now, how do you treat the patient? So, remember, the treatment is very easy. So, primary treatment on the surgical excision. So, you have to perform surgical excision has to be performed. After surgical excision, you have to go for a pre-operative embolization of maxillary artery. Pre-operative embolization of maxillary artery should be performed. Now, that main advantage of your angiofibroma is going to be the surgical excision. Okay, since it is a very vascular tumor, pre-operative embolization has to be done in your maxillary artery. So, what are the surgical excision methods you have? Number one, you can go for an endoscopic procedure. Endoscopic procedure. So, endoscopic is nowadays common. External approach use pandro, except when it is going to be 3A or 3B, you have to go for you cannot go for an endoscopic procedure. Number two is going to be your transpalatine procedure. Transpalatine. இங்க என்ன பண்ணுவீங்கன்னா, you are going to give incision between your hard and soft palate. So here incision is given between your hard palate and your soft palate at okay, when the tumor is confined to your nasopharynx. Now coming to the next one, that is going to be your transpalatine plus sublabial. So this transpalatine plus sublabial, you're going to call this as Sardana staging. Sardana's approach. So when the tumor from your nasopharynx is extended into cheek, இது வந்து when tumor is confined to nasopharynx. Confined to nasopharynx, you're going to go for transpalatine approach, whereas transpalatine plus sublabial, otherwise called as Sardana's approach, this is performed when the tumor is going to extend to the cheek. You're going to have an extension to the cheek. So here the incision is going to be sublabial incision. Sublabial incision is going to be given. Now the third one is going to be your medial maxillectomy. Medial maxillectomy. Okay, medial maxillectomy and lateral rhinotomy approach. Lateral rhinotomy approach. When do you go for this medial maxillectomy and lateral rhinotomy? Here the incision is given in the nasofacial crease. Now incision is given in the nasofacial crease. Nasofacial crease. You're going to give it in the nasofacial crease or lateral rhinotomy. That's what you call it as lateral rhinotomy. And then you're going to have another incision at the medial wall of maxilla. Medial wall of maxilla, otherwise called as lateral wall of nose. Then you're going to now enter into your sphenopalatine foramen. Sphenopalatine foramen valiya sphenopalatine fossa porenga. Then what you're going to do is you're going to go for a midfacial deglowing procedure. You're going to go for a deglowing procedure. What is this deglowing procedure? So it can also be done by midfacial deglowing procedure. Here sublabial incision is given from one molar to another molar. Then you can go for a flap rise. So இந்த மாதிரி நீங்க deglowing procedure போனீங்கன்னா உங்களுக்கு scar form ஆகாது. Whereas நீங்க nasopharyngeal crease and medial wall of maxilla incision போடும்போது you will have a important scar formation will be there. So அதனால தான் you have two important approach. One, you can go for a transmaxillary approach. Okay, then you have your next one, that is going to be your transmaxillary approach. That is going to be a lateral rhinotomy alone you're going to perform. And finally, you're going to have your infratemporal approach. Infratemporal approach. Okay, so these are the different approaches of your surgery for your nasopharyngeal angiofibroma. Since the patient here is going to be young and radiotherapy is not preferred. Since the patient is very young, you will not go for radiotherapy. Very, very important point. So you should never go for radiotherapy. So radiotherapy is indicated. When do you go for radiotherapy? Radiotherapy is indicated only when the patient is going to be in the stage 3. That is going to be your intracranial extension. Okay, so remember, this is going to be infratemporal incision. This is going to be a lateral transtemporal incision. This is your lateral rhinotomy transfacial incision. This is mid-facial glowing. This is transpalatal. This is mandibular swing. This is transmandibular incision. So these are the various incisions that is going to be performed in your nasopharynx. Clear, right? Yes. So hormonal therapy can also be given. Stilbestrol 2.5 mg TID is going to be helpful for the patient, or radiotherapy na 3000 to 3500 centigrade 3 to 3.5 weeks for the period of 3 years, up to 3 years you're going to give. Chemotherapy like doxorubicin, vincristine, decarbazine and combination can also be used. Now coming towards the other benign lesions which are going to be present, teratoma seen at birth, pleomorphic adenoma, amartoma, choristoma, and paraganglioma. All these can also be present. Now, I will be asking you one question. You are going to answer me 5 important questions. After 5 important questions, I will go. So, what is the face deformity you're going to see in juvenile angiofibroma? Can you put in the chat box? I give you 5 seconds time for each question. So, can you put in the chat box what is the face leaf? What is going to be the face deformity you're going to see in the juvenile angiofibroma? Others. I don't want only Berlin to answer. Others also should answer. Lankeshwar, Balashruti, others. Very good. Frog face deformity is the right answer. I'll tell you now, you're going to tell me what is going to be the important investigation you're going to perform. A 12-year-old child presented with a unilateral pink nasal mass. Remember, listen carefully. A 12-year-old child coming to you with a unilateral pink nasal mass. Which is the most important investigation you're going to perform before undertaking a surgery? What will be your important investigation of choice before performing a surgery? Can you tell me which test you are going to take? I'll give you option whether ultrasound, FNAC, biopsy or CECT. Which you will be taking? CECT. Very good. Biopsy and FNAC are contraindicated. Biopsy and FNAC are contraindicated. Can you tell me why angiofibroma bleed excessively? What is the reason why angiofibroma is bleeding excessively? Anyone? Why angiofibroma is bleeding excessively? Any idea why angiofibroma bleeds excessively? Come on. Why angiofibroma bleeds excessively? No muscular coat in the vessel. Because of that, there won't be any contractile component present. So that is the reason why it is going to bleed excessively. Very good, Ravi Krishnan. Excellent. Now the last question before moving into the nasopharyngeal carcinoma. Juvenile nasopharyngeal angiofibroma is supplied by which artery? I'll give you 4 options. Internal maxillary artery, ascending pharyngeal artery, facial artery, lingual artery. Which is going to be the most important or common artery? Again, I'm repeating. Internal maxillary artery, ascending pharyngeal artery, facial artery, and your lingual artery. Anyone? Internal maxillary artery is the right answer. Excellent. And final question. A 13-year-old boy, unilateral nasal obstruction with recurrent epistaxis. CECT is showing a minimal extension to sphenoid sinus and no lateral extension. Can you tell me what is the stage here? So, unilateral nasal obstruction, recurrent epistaxis, the CECT is going to show minimal extension to sphenoid sinus, and there is no lateral extension. What is going to be your staging? One is telling 2B. Can others try? Can others also try? What I am telling, minimal extension to sphenoid sinus. So 2B ன்னு சொன்னீங்கன்னா it has to fill the orbit. இங்க orbit பத்தி எதுவுமே கொடுக்கல. I'm telling just a minimal extension to the sphenoid sinus. Sphenoid sinus. It is not extending into sphenopalatine fossa. I'm not telling it is extending to sphenopalatine fossa. I'm telling it is extending to sphenoid sinus. If I am telling it as a sphenoid sinus, it comes under paranasal sinus, right? All 4 paranasal sinus, maxillary sinus, if it is going to go to ethmoid sinus, maxillary sinus, or if it is going to go to your sphenoid sinus, any sinus, if it is going to extend, it is going to be 1B, guys. It is not going to be a 2B, 2A, or 2C. Clear, right? Clear? No doubt, right? Next, we are going to move towards an important essay that is going to be your nasopharyngeal cancer. Nasopharyngeal carcinoma is an important essay. How you are going to write? Number 1, you have to start with introduction. So start with introduction. Always start with introduction. Then second thing is going to be, after that introduction, the second important thing you're going to go is etiology. So these are the headings you should write. Number 3, pathogenesis. Number 4, It's going to be clinical features, clinical feature. Number 5, investigations. Number 6 is treatment. Number 6 is treatment. So these are going to be the endings under which you are going to actually write in your exam. So now first let's see what is introduction. What introduction you're going to remember. See, this is the most common carcinoma of nasopharynx. Okay, it's a squamous cell carcinoma. Note that the nasopharynx is lined by your nasopharynx is lined by what? Can you tell me? What is the lining of your nasopharynx? What type of epithelium? What is the lining of your nasopharynx? Can someone put in the chat box? What is going to be the lining of nasopharynx? Anyone? What is the lining of ciliated columnar? Excellent. So you're going to have a ciliated columnar epithelium. Very good. So what happens here is that ciliated columnar epithelium is going to get converted into a squamous cell. That's why we are going to call it as a squamous cell carcinoma. Squamous metaplasia is going to occur. Okay, well, squamous metaplasia is going to occur. Remember, the most common site of origin of your nasopharyngeal carcinoma. Can you tell me what is the origin of your angiofibroma? Where does your angiofibroma get originated? Anyone? Put in the chat box. From where you're going to have the origin of? From where you're going to have origin of angiofibroma? Very good. Spinopalatine foramen. Here it is going to be from the fossa of Rosenmuller, or nothing but your lateral pharyngeal recess in the lateral wall of nasopharynx, just behind your eustachian tube cartilage. I told you in the morning, right? Behind your eustachian tube cartilage. Okay, so there are some various etiology. Number 1 is going to be your genetic etiology. This is most commonly seen in the Chinese areas, especially in the areas of Guangdong province. So that's why this tumor, your nasopharyngeal carcinoma, is otherwise called as Guangdong tumor. So exam la oruvela ungalku Guangdong tumor nu ketangana, don't think something Greek and Latin. The question is asked nothing but your nasopharyngeal carcinoma only. They have given it under other name. Okay, so ivangalku vandu pathangana, they had a problem in the HLA chromosome 6. HLA present in the chromosome 6. So adula dhaan problem irukku சொன்னாங்க. Next is the environment. Environment also it's a very important. So due to nitrosamine consumption, nitrosamine from dry salted fish, that is also going to be one of the cause. Okay, so HLA na enna type of HLA also they can ask you. HLA A2, A8 and B46. So these are the HLAs that are associated with it. And now third one is going to be the occupation. So the people who are working in the woodworker or the coal workers, they are also commonly affected. And viral, remember your Epstein-Barr virus is commonly involved. Your Epstein-Barr virus is commonly involved. So Epstein-Barr virus commonly involved. How you are going to screen the patient? So how you are going to screen the patient at the earlier days? You are going to go for IgA antibody. So IgA antibody to your viral early antigen. Viral early antigen will be the first marker that is going to be coming. Next is going to be IgA antibody against your viral capsid antigen. That these two, if you're going to see, they are going to be your serological marker. They are going to be the serological marker which will be elevated prior to the clinical onset. Next comes the epithelial tumor cells which have a intimate relationship with the T cell lymphocyte which are CD8. Now what happens is, so when they're due to some genetic, environmental or viral factors, there will be a silent period. Suddenly what happens, there will be an invasion, and that invasion will be causing a blood-stained mucus and ET tube obstruction. Idella common present aavo. Then primary lymph node station ku varum. Apra retropharyngeal lymph node will get they will be getting infected, and that can go to your parapharyngeal spaces, and from parapharyngeal space it is going to go to the systemic spaces. So that is why nasopharyngeal carcinoma is a very important topic. Okay, so before moving into this, I want you all to remember the clinical features which you have to write in your exam. So nasopharyngeal carcinoma will be having a bimodal age group distribution. Bimodal age distribution. First peak occurs in 15 to 25 years and second peak occurs around 55 to 65 years. Okay, so around 75% of patient will be presenting to you with a painless cervical lymphadenopathy. Cervical lymphadenopathy. Okay, lymphadenopathy. So the patient will be mostly presenting with cervical lymphadenopathy. Mainly in the area and level 2, level 5. So level 5 and level 2. Do you all remember the levels, right? Yesterday, day before yesterday, when I was telling about your larynx, I was discussing, right? Yes. Okay, so those two areas are the one that is going to be mainly involved. Your level 5 is going to be your posterior triangle, and your level 2 is going to be your deep cervical lymph node. Deep cervical lymph nodes. Okay, so the nasopharynx is going to drain into the retropharyngeal lymph node of Rovier, but this is inaccessible due to inspection as well as your palpation. So adanal inge it goes towards your retropharyngeal and it goes towards your deep cervical lymph node. Deep cervical lymph node. So in the deep cervical lymph nodes are the first palpable lymph node. Deep cervical lymph node as well as your posterior triangle lymph node. Posterior triangle lymph node, these two are going to be the first palpable lymph node. Then you're going to have your nasal. So nasal enna problem nasal obstruction, hyponasal voice, unilateral serous otitis media will be there. Inferiorly, if you come, so if inferiorly there is going to be oropharynx. So you have to examine your oropharynx whether there is any spread to your oropharynx also. And whenever it is going to spread to your parapharyngeal area, do you remember when I was discussing, I was telling you, whenever it is going to spread to your parapharyngeal area, because parapharyngeal area, you have deep cervical lymph nodes. When it is going to extend into your parapharyngeal area, what happens is they are going to cause obstruction to your 9th, 10th, 11th, 12th cranial nerve and sympathetic chain. So whenever your sympathetic chain is going to get compressed, can you tell me what is the problem you're going to get? Whenever sympathetic chain is going to get compressed, what is the problem you're going to get? Anyone? Anyone? Whenever sympathetic chain is going to get obstructed. So what is going to be the syndrome you're going to get? What is the syndrome called as? Very good, very good. Only when your 9th and 11th, 12th is obstructed, that is called as when your 9th, 10th and 11th and 12th nerves are going to get compressed, that is called as, what do you call it as? Jugular foramen syndrome. Jugular foramen syndrome. Okay. So when only these three are affected, you're going to call it as a jugular foramen syndrome. And whenever there is going to be obstruction here, that is going to lead to corner syndrome. Corner syndrome. Clear, right? Yes. Now, coming towards your orbit, whenever it is going to involve your orbit, so whenever it is going to involve your orbit, so whenever it's going to involve your orbit, it can lead to exophthalmos, it can lead to blindness, and it can lead to diplopia. Why do diplopia occurs? Because of the involvement of third, fourth, sixth arch. Okay, so third, fourth, sixth muscle, extraocular muscles and nerves, third, fourth, sixth cranial nerves. Okay, what? Next, coming towards your superiorly, it is going to enter into your foramen lacerum. It can enter into your foramen lacerum and it can enter your foramen ovale. So because of this, what happens is there is going to be a cranial nerves involved. What cranial nerves? Fifth cranial nerve involves. Especially in the fifth, you have your V2 and V3, maxillary and mandibular components, they are going to be involved. And they can also get, they are also going to get infiltrate in the sinus of Morgagni. Morgagni, can you tell me what are the structures passing through your sinus of Morgagni in the chat box? Structures passing through the sinus of Morgagni in the chat box. Can you put in the chat box? Sinus of Morgagni. How to remember, I told you, right? Auditory tube, excellent. Eustachian tube or auditory tube. T stands for tensor villi palatini. A stands for auditory tube. And what is the, okay, you're going to have a tensor villi palatini. You're going to have auditory tube. Come on, others. You're going to have ascending pharyngeal artery, tensor villi palatini. You're going to have ascending palatine artery. You're going to have ascending pharyngeal artery. You're going to have levator, villi, palatini, and what does A stands for? Auditory tube. Very good, Aishwarya. Very good, Lankeshwar. Excellent, excellent, all excellent. So now we are going to move. So all these areas, all these are also going to get affected. Now, from this, what you have to remember is, so sinus of Morgagnia, there is going to be all these areas are going to get affected. So apart from this, what happens? You are going to have, so you are going to have very important things that are going to happen here. Number one is going to be ipsilateral conductive hearing loss. Ipsilateral conductive hearing loss. Why? Because of auditory tube involvement, there is going to be ipsilateral conductive tube hearing loss. And then you are going to have a ipsilateral akinesia of soft palate. There will be ipsilateral akinesia of soft palate. Why akinesia is occurring? Because of the levator villi palatini. So because of your auditory tube involvement, you are going to have a ipsilateral conductive hearing loss. Ipsilateral conductive hearing loss. And because of your levator villi palatini, which is going to get affected, there will be a akinesia of palate. Because next is going to be, now you have your ascending pharyngeal artery, tensor villi palatini, and your tensor villi palatini. Apart from that, what happens? Your sinus of Morgagni is going to be in a close contact with your foramen ovale. So they are going to be in close contact with your foramen ovale. Now the structures that are passing through your foramen ovale, they are also going to get affected. What are the structures that are going to pass through your foramen ovale? Mainly your V3, mandibular nerve. So they are going to exit through your foramen ovale, and they are responsible for the pain in the lower ear or your jaws and the lateral side of the face. Now can anyone tell me what is going to be the structures that are passing through your foramen ovale? How do you remember that? MALE. So mandibular nerve. Then you're going to have A stands for anyone. Can you tell me in the chat box? Can you tell me in the chat box? So mandibular nerve. Then you're going to have your accessory meningeal artery. Accessory meningeal artery. Meningeal artery is going to pass through your foramen ovale, and L stands for lesser petrosal nerve. Lesser petrosal nerve, and E stands for emissary veins. So this you should never forget. Okay, emissary veins. In this, your mandibular nerve is the one that is going to get problem. Because of this mandibular nerve, what happens? There is going to be, okay, neuralgia. There is going to be neuralgia in temporomandibular, in temporoparital area. So this is going to be due to your mandibular nerve involvement. Now the second one is going to be your palatal palsy can occur. Palatal palsy can occur. And number 3, there is going to be a conductive hearing loss. So you can remember with the mnemonic NPC, nasopharyngeal carcinoma. N stands for neuralgia in your temporoparital area, P stands for palatal palsy, and C stands for conductive hearing loss. So this is called as Trotter's triad. Trotter's triad of nasopharyngeal carcinoma. Very, very important 2-mark question initially. Now they can ask you as a short notes also, or they can ask you as a MCQ also. So you should be very thorough in this. Okay, so remember, in your nasopharyngeal carcinoma, all nerves are going to get involved except your 7th nerve and 8th nerve. 7th nerve, 8th nerve தவிர எல்லா nerves-உமே involve ஆகலாம். Okay, now coming to the last one, how do you diagnose this patient? So diagnosis is going to be by nasopharyngioscopy you have to perform, and after performing a nasopharyngioscopy, you're going to take a biopsy. That is going to be your investigation of choice. Anyone, so you would have learned, right? You would have seen this next step of management and investigation of choice. Next step of management, investigation of choice. Investigation of choice, na meaning enna? What is the meaning of investigation of choice? So investigation of choice is something that you're going to perform before giving a definitive treatment. So the investigation which is performed before starting definitive treatment. So இங்க வந்து பாத்தீங்கன்னா உங்களுக்கு X-ray எடுக்கலாம். You can go for your by CT scan, MRI scan, everything can be taken. But if they are going to ask you investigation of choice, they are asking you what is the investigation you're going to perform before doing a surgery or before doing a medical management. So that answer here it's going to be the investigation of choice here it's going to be your biopsy. So you have to perform a biopsy, nasopharyngoscopy பண்ணி biopsy எடுக்கிறோம். So now once you're going to take a biopsy. So what is the thing you're going to see in the biopsy? Whether it is going to be a well differentiated or moderately differentiated or poorly differentiated. Then grossly you're going to see whether they are proliferative, ulcerative or infiltrative. So all this you're going to see. So your WHO gives classification as epithelial tumor, soft tissue, malignant, tumors of bones and cartilage, secondary tumor, tumor-like lesion. In the mind they are dividing. Okay, so based on the histopathology, you're going to have type 1, type 2, type 3. So இதெல்லாம் தேவையில்லை. Actually, it's not required. If you want to score honors, so you're going to write this also. So present WHO terminology also you can write. So squamous cell carcinoma type 1, non-keratinizing carcinoma type 2, undifferentiated carcinoma comes under type 3. Now moving on, okay, keratinizing squamous carcinoma, non-keratinizing carcinoma is type 2. Type 2 is going to be further divided into type 2A, type 2B. Type 2A no non-keratinizing, type 2B no non-keratinizing, non-differentiated, undifferentiated. That is called as your type 2B. And then you have your type 3. That is going to be your undifferentiated carcinoma. Clear, right? So prognosis of this tumor is very poor. So prognosis is very poor. So now you know the clinical features and all. So you can just take a screenshot or you have this in your Dingra textbook itself. There is nothing new. So this is there in your Dingra textbook itself. That will be helping you to remember all the features and all the extensions where all it is going to extend. Okay, now coming towards your diagnosis is done. Now TNA, you have your very important thing that is going to be your staging of the tumor. How do you stage this tumor? Actually, வந்து பாத்தீங்கன்னா இப்ப ஸ்டேஜிங் பண்றது இல்ல யாருமே. ஸோ ஏன்னா இது 2012 முடிஞ்சு போச்சு. இப்ப ஸ்டேஜிங் பத்தி பெருசா நம்ம எங்கேயுமே பேசுறது இல்ல. But still, if you want to learn, you can learn from your textbook. That's all. And this is not a compulsion. Okay, not a compulsion. Okay, now coming towards your regional lymph node, I think you all know this. So now moving towards your treatment. So treatment basically, how do you treat this patient? So you're going to go for a chemo. It's a radio-sensitive tumor. So remember your nasopharyngeal carcinoma is a radio-sensitive tumor. So radio-sensitive, so you can go for radiotherapy. Or you can go for a concurrent chemo radiation can also be given. Or intensity modulated radiotherapy. So intensity modulated radiotherapy, that will be like avoiding to affect your eyes and your brainstem. Okay, eyes and your brainstem. Brachytherapy can also be given. That is rapid fall of radiation at a short distance. So high dose you can give. It can spare the neighboring structures. So transnasal intracavity brachytherapy can also be given. Surgery in Panangana, you have to go for a radical neck dissection you have to do. And post-reduction salvage surgery can be performed. Okay, so chemotherapy in sonona, chemotherapy is going to be a cisplatin or cisplatin with 5-fluorouracil. You can actually go for cisplatin or cisplatin with 5-fluorouracil. Okay, also this is going to be helpful to control the metastasis. So the ultimate treatment of choice அப்படின்னு கேட்டாங்கன்னா chemo radiation, concomitant chemo radiation is going to be the treatment of choice. Okay, other malignant tumors of nasopharynx also you should know: lymphoma, rhabdomyosarcoma, plasmacytoma, chordoma, adenoid cystic carcinoma, and melanoma. So these are going to be the other features which are going to be present. Now, as usual, I'll be asking you some questions that can be asked from your from this chapter, and you're going to answer me. Nasopharyngeal carcinoma is the most common in which people? Can you tell me this? I think I didn't tell you in detail, but let me see who's going to answer. In which people you're going to have the nasopharyngeal carcinoma more common? So nasopharyngeal carcinoma is seen more common in which people? Like if you want a choice, Mongoloid, Caucasians, Aryans or Dravidians. In which people the nasopharyngeal carcinoma is most common? So I told you this is present in the China. But China la எந்த people இருக்காங்க? Mongoloid race. Very good. So Mongoloid race is going to have the most commonly they will be having. Okay. Next, branch of trigeminal nerve involved in your trotus triad. In trotus triad, which trigeminal nerve branch is going to get involved. Mandibular nerve, excellent. So only one or two, please don't answer. I want everyone to answer. Category of non-keratinized squamous carcinoma, squamous cancer of nasopharynx. Non-keratinized squamous cancer, which type of WHO classification? It's going to be type 2. Excellent. It's going to be type 2. Then most common presentation of nasopharyngeal carcinoma. Most common presentation, which will be the first presentation in your nasopharyngeal carcinoma. Option A, neck mass. Option B, trotus triad. Option C, ophthalmoplegia. Option C, glue ear. Can you tell me? Neck mass. Excellent. So neck mass is going to be the. Okay. Next question. Treatment of nasopharyngeal carcinoma T1 and T2. If it is T1 and T2, what is going to be your treatment of choice? T1 and T2, now what is your treatment of choice? It is going to be radiation therapy. So you go for radiation therapy. If it is going to be advanced nasopharyngeal carcinoma, you go for concurrent chemoradiation. Concurrent chemoradiation can be performed. Now coming towards your next question. So you're going to answer this. A 70-year-old male presents with the neck nodes and right-sided deafness. Examination reveals a dull tympanic membrane. Tympanometry shows curve B. Curve B tympanometry. What is going to be the probable diagnosis? I myself will tell the answer. Curve B, it's going to be your serous otitis media. So serous otitis media along with neck nodes, neck mass is there. Then the answer is going to be your nasopharyngeal carcinoma. So the answer is going to be nasopharyngeal carcinoma. From where nasopharyngeal carcinoma gets originated? Can you tell me? From where nasopharyngeal carcinoma gets originated? From where nasopharyngeal carcinoma gets originated? Origin of nasopharyngeal carcinoma. What is the origin of nasopharyngeal carcinoma? Can you put in the chat box? What is the origin of nasopharyngeal carcinoma? Someone? What is the origin of nasopharyngeal carcinoma? Fossa of Rosenmuller. Excellent. So now we are going to move towards the next one. That is going to be your tonsil. So adenoid is already covered. Now we are going to move towards the next one. That is going to be your tonsil. Remember, your tonsil develops from your second brachial pouch. Okay, ma? So they are going to be lined by non-keratinizing stratified squamous epithelium. So before moving into the tonsil, now we have completed nasopharynx completa. So nasopharynx is over. Now we are going to come into the next one. That is going to be oropharynx. Before moving into the oropharynx, first you need to understand. Your oropharynx. So you're going to imagine two lines. Okay, ma? So imagine two lines. You have an upper line and you have a lower line. Upper line is going to be at the junction of your soft palate and hard palate. So lower line is going to be in the anterior 2/3 and posterior 1/3 of the tongue. So on the part that you're going to call it as a oropharynx. So from here to here. So after your okay, so இதுக்கு முன்னாடி பாத்தீங்கன்னா you have your oral cavity. So behind your posterior 1/3 of your tongue, you're going to have your oropharynx. Now in the oropharynx, you're going to have now in the oropharynx, you're going to have some important points to be discussed. So what are the things that you're going to see in your oropharynx? Number one, so this is going to be your soft palate. Okay, so this is your soft palate. Then behind your soft palate, so you're going to have your uvula. So soft palate, two side they are going to join to form uvula. And you're going to have your base of tongue, that is going to be posterior 1/3 of the tongue. And in the base of tongue or posterior 1/3 of the tongue, you're going to have your lingual tonsil. Okay, and then you're going to have your anterior pillar. This is going to be your anterior pillar, and you're going to have your posterior pillar. So between your anterior and posterior pillar, while we are discussing anatomy, I told you that is going to be your tonsil or palatine tonsil. So it is going to be lying between your anterior and posterior pillar. And then you're going to have your posterior pharyngeal wall. This is going to be your posterior pharyngeal wall. And the space between the base of the tongue and epiglottis. When I'm going to look further down, there will be a space between your base of the tongue and epiglottis. I'm going to call it as a vallicula. Clear? Now we are going to move towards the tonsillitis. Okay, first thing you have to remember, what is a tonsil? So this is your tonsil, palatine tonsil. They develop from the second brachial pouch. They are lined by non-keratinizing stratified squamous epithelium. They have a cryptations. The longest crypt of your tonsil, you're going to call it as a crypta magnus or magna. Then coming to your largest cryptus, you're going to be crypta magna. Upper layer, you're going to have your plica semilunaris, and below you're going to have your plica triangularis. Plica semilunaris, and you're going to have your plica triangularis. Now I am going to draw, you're going to draw along with me, okay, all your tonsillar bed. So first you're going to have your tonsillar bed. So how you're going to have tonsillar bed? So let's draw together. So that this, if they ask you in a 5-mark question or peritonsillar abscess, if they are going to ask you, you will be able to remember. So you're going to have your anterior pillar, posterior pillar like this, and you're going to have your ula. So you're going to have anterior pillar, you're going to have posterior pillar like this, and this is going to be a ula. Okay, this is going to be a ula. Just hold on. So take a paper, draw along with me. Okay, this is going to be a ula. Now, in the wing, here you're going to have your anterior pillar. Then you're going to have your posterior pillar like this. So this is going to be a posterior pillar like this. Okay, ma. So you're going to have posterior pillar like this. So between your anterior pillar and posterior pillar, you're going to have. So between your anterior pillar and your posterior pillar, you're going to have. What is this? So what do you have between your anterior pillar and posterior pillar? You're going to have your palatine tonsil. You're going to have palatine tonsil, something like this. So you have your palatine tonsil now, right? So palatine tonsil is going to be having a covering. Your palatine tonsil will have a covering. That covering is called as your capsule. So first you are going to have the capsule. So behind your, whenever I'm going to ask you the bed of tonsil, you're going to tell that the first layer is going to be the first layer of your bed of tonsil is going to be your capsule. So first layer is going to be your capsule. So after capsule, what happens? After capsule, okay, so you're going to have your capsule. After capsule, you're going to have your soft palate. So this is going to be your soft palate. So in the soft palate, you're going to have an artery. So in the soft palate, you're going to have an artery. So what is that artery? So just let's draw. So you're going to have one artery which is going to be coming above. So you're going to have one artery which is going to be just above like this. Okay, so you're going to go above like this. This is going to be your artery. What is the artery named as? This artery is going to be your, anyone? Any guess? What is this artery? This is going to be your tonsillar artery. So your tonsillar artery is going to get a branch. From where your tonsillar artery is going to get branch? Anyone? So your tonsillar artery is going to come like this and it is going to supply. So what is going to be the blood supply of your tonsil? Anyone, do you know? What is the blood supply of tonsil? Your tonsil is supplied by your maxillary artery. It is supplied by your lingual artery. It is supplied by your facial artery. So there are some branches arising from your facial artery. There are some branches that is going to be supplied by your maxillary artery. There are some branches of your artery that is going to be supplied by your lingual artery. Now, after this, you have some blood vessels. Okay, you're going to have some vein. So this vein is going to be present all along here, something like this. So there is going to be a vein that is going to be present. Okay, there is going to be a vein that is going to be present like this. So there will be a vein that is going to be present like this. So these veins, they are called as peritonsillar vein. So this is called as peritonsillar vein. Okay, this is called as peritonsillar vein. Just label it. This is called as peritonsillar vein. Peritonsillar vein. So after peritonsillar vein, you're going to have some fascias that is going to cover. So you're going to have some fascias that is going to cover. Can you tell me which fascia covers your tonsil? In anatomy, I discussed, right? Which fascia covers your tonsil? Which fascia is going to cover your tonsil? I told in anatomy. Can someone respond? Which fascia covers your tonsil? That is going to be your pharyngobasilar fascia. So the first fascia you're going to have is going to be your pharyngobasilar fascia. Pharyngobasilar fascia. Basilar fascia is going to be there. Above your pharyngobasilar fascia, you are going to have your muscular coat. So what is that muscular coat you have? That muscular coat is nothing but, okay, what is that muscular coat you have? So this is going to be a muscular coat. That is going to be a superior constrictor muscles. So you're going to have your superior constrictor muscles. So above your pharyngobasilar fascia, you're going to have superior constrictor muscles. Above your superior constrictor muscles, another fascia is there. Can someone recall and tell me what is that fascia present above your superior constrictor muscle? That is going to be your buccopharyngeal fascia. Buccopharyngeal fascia. Buccopharyngeal fascia is going to be there. So above your buccopharyngeal fascia, you are going to have mandible. So this is going to be your angle of mandible. This is going to be your angle of mandible. This is going to be your angle of mandible. So lateral and medial to angle of mandible, what are the structures present? So medial to your angle of mandible, you're going to have medial to angle of mandible, you're going to have what is the structure? Medial to angle of mandible, you're going to have medial pterygoid muscle. Medial pterygoid muscle is going to be there. And lateral to your angle of mandible, what do you have? Lateral to the angle of mandible, what is the muscle you have? What is the muscle you have? And lateral to the angle of mandible, you're going to have masseter. You're going to have masseter. You're going to have masseter. Okay, so angle of mandible, masseter is going to be there. So you're going, then below you're going to have your submandibular gland. Submandibular gland is going to be there. Between your submandibular gland and your mandible, between your submandibular gland and your mandible, there is going to be your, who is going to go? So you're going to have your facial artery. This facial artery is going to divide into two. So what is the division? One is going to supply your submandibular gland, then one is going to enter and it is going to go inside. And once it is going to go inside, it is going to contribute. It is going to be contributing to the nerves. It is going to contribute to the artery supply in your mandible. It is going to give contribution to the artery supply in your mandible. Okay, something like this. Now, if you want to understand in detail, if you want to understand in detail about how you are going to have, so in detail, if you want to understand, 1 minute. So just draw along with me. So please don't take your time and please don't draw afterwards. So draw now itself. That will be helping you. Okay. So draw now itself. That will be helping you. Okay. So now what I'm going to do, I'm going to draw how your tonsil gets blood supplied. Tonsil or the blood supply is very, very important short note that can be asked. Okay. This is your tonsil. Now your tonsil is going to get supply from, first, you're going to start with your internal carotid artery. So first start with your internal carotid artery. Your internal carotid artery is going to get, so it's going to have two branches, right? Common carotid artery give rise to internal carotid artery, and you're going to have external carotid artery. Your external carotid artery is going to give rise to first branch. Your external carotid artery is going to give rise to first branch. That is going to be your lingual artery. So this lingual artery is going to give one branch that is going to supply your tonsil. You're going to have lingual artery that is going to supply your tonsil. So you're going to have your lingual artery that is going to supply your tonsil. Then what happens? Slowly you're going to have the next artery that is going to be your facial artery. This facial artery, it is going to go like this. And from your facial artery, you're going to have the first branch. What is that first branch called as? Ascending palatine artery. So you're going to have the first branch that is going to be ascending palatine artery. From your ascending palatine artery, you're going to have a branches that is called as ascending palatine branch of your facial artery. So this is going to be your ascending palatine artery, which is again it is going to supply your, it's going to be supplying your palatine tonsil. Next, you're going to have the another artery that is called as tonsillar branch of facial artery. The tonsillar branch of facial artery, direct branch from your facial artery, it is going to supply your tonsil. Next is going to be your ascending pharyngeal artery. Now what happens? From your external carotid artery, you're going to have ascending pharyngeal artery like this. This ascending pharyngeal artery, so you're going to have your ascending pharyngeal artery. This ascending pharyngeal artery give rise to a branch that is going to go and supply to your palatine tonsil. That is called as your ascending pharyngeal artery, branch from ascending pharyngeal artery. Then you're going to have the continuation of your external carotid artery. External carotid artery is going to divide into superotemporal and maxillary artery. This maxillary artery, okay, this maxillary artery, they are going to give rise to descending palatine branch of maxillary artery, which is again going to supply your tonsil. So what are the arteries that is going to supply your tonsil? Number one, descending palatine branch of maxillary artery. Then you are going to have your ascending pharyngeal artery. Then you are going to have your ascending palatine artery. Then the fourth one is going to be your tonsillar branch of facial artery. Clear? So these are going to be the four branches which you are going to remember. Now, if you're going to look carefully between your tonsil, okay, this is your capsule of tonsil and this is going to be your tonsil. Between your tonsil and your posterior pillar, there is a gap where you're going to have your peritonsillar vein, isn't it? This space is called as peritonsillar space. This space is called as peritonsillar space where you have your external palatine vein or peritonsillar vein. Now, if there is any injury to the peritonsillar area, that is going to cause hemorrhage during your tonsillectomy. Whenever you're going to perform a tonsillectomy, so you're going to get injury in your peritonsillar vein. That will be leading to hemorrhage. Second, whenever there is going to be any infection in this peritonsillar space, you're going to call it as a peritonsillar abscess. Whenever there is going to be any infection in this particular area, you're going to call it as peritonsillar abscess. Okay, so this peritonsillar abscess is otherwise called as quinsy. Otherwise called as quinsy, an important short note. The other structures that are present are glossopharyngeal nerve. So you will also have another nerve here. I forgot to mention the entry of nerve that is called as your glossopharyngeal nerve, which is present between your superior constrictor and your middle constrictor. Okay, and buccopharyngeal fascia will be there. Okay, now coming towards where, okay, at the end, what happens? You have a styloid process. Okay, so whenever there is going to be enlargement of styloid process, you're going to call it as a styalgia or eagle syndrome. So in the styloid process, pakatliye, you're going to have glossopharyngeal nerve. Because of that, you can have glossopharyngeal neuralgia. இது எல்லாமே tonsillectomy பண்றப்ப we will be like commonly causing injury either to your styloid process it will be leading towards your eagle syndrome or styalgia. What is eagle syndrome? It is odynophagia and foreign body sensation in the throat. That is called as your eagle syndrome or styalgia. Glossopharyngeal neuralgia occurs. அப்படின்னா என்னென்ன symptom இருக்கும்? We have a stabbing pain in the oropharyngeal region because of compression or irritation of your glossopharyngeal nerve. Now, last and final, we are going to move towards the blood supply is finished. Now, we are going to go to the acute tonsillitis. So, what is acute tonsillitis? So, it's a most commonly seen condition in everyday or GP and in your MBBS முடிச்சிட்டு when you're going to practice, you will see this acute tonsillitis. Like your rhinitis, sinusitis, pharyngitis, very most common. Among the bacterial infection, the most common organism that is going to cause is going to be your group A beta hemolytic streptococci. But you have other organisms like your viral infection or Haemophilus influenza, staphylococcal or pneumococcal, diphtheria. All these can also be there. But most common, if you're going to ask me, that is going to be your group A beta hemolytic streptococcus. Now coming to the presentation. So how the patient will be presenting to you. So etiology, it is going to occur in the younger age group. Endogenous UTI, pre-existing UTI will be there. So before moving into the types and all, you have to know the symptoms. The most common symptom is going to be your sore throat. Pain in the throat, fever will be there, referred otalgia, raw sensation in the throat, odynophagia, muffled voice, all these things will be there. And on examination, if you're going to see, on examination, there will be yellowish spots will be present. So yellowish spots will be present. Yellowish spots will be present. These yellowish spots on the tonsil due to purulent material. This is called as your follicular tonsillitis. Follicular tonsillitis. Now I will tell you what are the types of tonsillitis. So you have acute parenchymal tonsillitis. You have acute follicular tonsillitis, acute membranous tonsillitis. When do you call it as acute follicular tonsillitis? When you're going to have a yellow spots on tonsil. Yellow spots on tonsil. Okay, so when do you call it as a acute membranous tonsillitis? See, you have a crypts, right? So I told you, I have just drew and told you. So this is going to be your palatine tonsil. You're going to have crepitations. So in from your crepitation, you're going to have a exudate that is going to be coming out. These exudate, what happens? They are going to form a layer like this above your tonsil. This layer is going to be called as membranous tonsillitis. So this is actually not a membrane, but a pseudo-membrane. Why I call it a pseudo-membrane? Because it is going to be a collection of exudate. That's all. So any bacterial infection involving your tonsil will lead to the formation of pseudo membranes. Okay, so that's why you're going to call it as a membranous tonsillitis, or very common if you want to give it a correct name, the pseudo membranous tonsillitis. Okay, so what is going to be a treatment you're going to give for this patient? You're going to give just antibiotics you're going to give for this patient. Now, what is parenchymal tonsillitis? Just a uniform enlargement. Uniform enlargement. So whenever there's a uniformed enlargement, then you're going to call it as a acute parenchymal tonsillitis. Acute parenchymatous tonsillitis. Clear? So this is good. Can you tell me what is this? Can you tell me which type of tonsillitis is this? Which type of tonsillitis is this? Can you put in the chat box? Which type of tonsillitis is this? Which type of tonsillitis is this? Come on, put in the chat box, no? Aishwarya, Al Faisal, Balashruti, Ravi Krishnan, Berlin. Everyone, can you put in the chat box? What is this? Very good. It's a membranous tonsillitis. There's going to be a membranous tonsillitis. So now you're going to move towards the whenever you're going to have any membranous tonsillitis, or if you have any formation of membrane, if you have any formation of membranes, okay. So how will you identify what is going to be a differential diagnosis? Remember, write it as L vitamin D, AL vitamin D. Write down. This is a mnemonic which you are going to follow. A stands for agranulocytosis. L stands for leukemia. V stands for Vincent's angina. I stands for infectious mononucleosis. T stands for trauma. And A stands for aphthous ulcer. T stands for tonsillitis also. Then M stands for monocalcinoma. M stands for moniliasis. It's not monaliasis. Monaliasis nothing but candidiasis. Candidiasis. Okay, wow. So, and you can have gram-positive infections. Okay, any infections of the throat, neoplasia, and finally D stands for diphtheria. So let's. This is going to be the differential diagnosis whenever you're going to see any membrane over the tonsil. Let it be a pseudo membrane or let it be a membrane. So whenever you're going to find any whitish covering, then your mind should go to is some membranous disease among your L vitamin D. So agranulocytosis, leukemia, okay, V stands for Vincent's, and what is going to be your Vincent's angina? Vincent's angina is otherwise called as trench mouth. Okay, then you have to remember trauma or tonsillitis. Then you have aphthous ulcer, monoliasis. Then you have your gram-positive infections. Then you have neoplasia and diphtheria. So now coming to talk about your diphtheria. Diphtheria is a bacterial infection of pharynx caused by your Corynebacterium diphtheriae. So it is going to be an airborne infection, incubation period 2 to 5 days. Why it is occurring? Because of the release of toxins. They are going to cause necrosis, resulting in the mucosal ulcer. Fibrinosuppurative exudates from this ulcers going to form a pseudomembrane. The diphtheric membrane is a dirty gray in appearance. They are slightly tightly adherent and they are going to bleed on removal. It extends beyond your tonsil and may involve your nose and other part of your pharynx also. There occurs a soft tissue edema of neck tissues that you're going to call with your cervical lymphadenopathy. In your diphtheria, you're going to have cervical lymphadenopathy. That's what we are going to call it as bull neck appearance. Okay, ma? So how do you manage your diphtheria? You're going to give diphtheria antitoxin and you're going to start with your beta-lactam antibiotic, especially your penicillin or macrolides. Now coming to erythromycin, azithromycin, etc. Now coming towards your Vincent's angina. Vincent's angina or trench mouth, it is caused by Borrelia vincenti. So this is caused by Borrelia vincenti. So Vincenti is going to be the one, Borrelia vincenti. Okay, so they can cause acute necrotizing ulcerative gingivitis. Acute necrotizing ulcerative gingivitis is caused, and the infection starts in the interdental papillae, and they are going to spread to the surface of your gingiva and tonsil, forming ulcer and grayish black necrotic membrane. Management is going to be a penicillin and metronidazole. Now coming to the last one, fourth one, that is going to be infectious mononucleosis. They are also called as glandular fever. It is caused by Epstein-Barr virus. Here along the enlarged tonsils, there are enlarged lymph nodes in the neck and splenomegaly. Diagnosis is going to be done by Paul Bunnell or monospot test. So diagnosis is going to be done by your Paul Bunnell or monospot test. So that is your infectious mononucleosis. The test is going to be your Paul Bunnell test. Okay, Paul Bunnell test. So blood smear shows atypical lymphocytosis. So malignancy of tonsil, trauma, aphthous ulcer, leukemia, agranulocytosis, all these can occur. Now, what is a chronic tonsillitis? Chronic tonsillitis, now it is nothing but a chronic follicular crypts full of cheesy materials. You have a yellowish spots. So chronic parenchymatous, now it's have a uniformed. Fibrotic tonsillitis is very small. So can you see this is chronic parenchymatous tonsillitis. So there is going to be uniform enlargement of your tonsil. Okay, va? So what are the three cardinal signs of your tonsillitis? So what are the three? Okay, before that, I want to tell the complications of your acute tonsillitis. Remember, the complication of acute tonsillitis is going to include chronic tonsillitis, peritonsillar abscess, parapharyngeal abscess, cervical abscess, acute otitis media, and finally subacute bacterial inflammation, endocarditis can occur, renal failure can occur, rheumatic fever can occur. All these are going to be the complications of your tonsillitis, acute tonsillitis. Now, moving on towards your chronic tonsillitis. So, this is going to be your parenchymatous tonsillitis. This is your follicular, and this is going to be your chronic fibroid type. This is going to be a chronic fibroid type. Okay, so now coming to the clinical features. Remember, you have to remember three important features. So I can call it as a cardinal signs. So cardinal signs of your chronic tonsillitis. Number one, flushing of anterior pillar. Flushing of anterior pillar. So that is going to be the first one. Second is going to be your Irwin-Murray sign. Irwin-Murray sign. That is going to be second one. Flushing of anterior pillar. Number two is Irwin-Murray sign. Number three is enlarged jugulodigastric lymph node. Enlarged jugulodigastric lymph node. Jugulodigastric lymph node. Okay, va? So you have flushing of anterior pillar, Irwin-Murray sign, and enlarged jugulodigastric lymph node. Flushing of anterior pillar, Irwin-Murray sign, and enlarged jugulodigastric lymph node. So you're going to have flushing of anterior pillar, Irwin-Murray sign, and enlarged jugulodigastric lymph node. These three are going to be the cardinal signs of your cardinal signs of your recurrent chronic tonsillitis. Okay, so what is going to be your Irwin-Murray sign? Irwin-Murray sign is an important 2 mark previously, but now they can ask you as a 1 mark MCQ. So when you're going to apply a pressure, so on pressure on the anterior pillar, on pressure on your anterior pillar, what happens? There is going to be expression of cheesy material from tonsil. That is called as your Irwin-Murray sign. Okay, now coming towards the features, recurrent sore throats, difficulty in swallowing, chronic throat irritation, poor weight gain, and all these things will be there. And examination, you're going to find all these squeeze tests. That is going to be a Irwin-Murray sign. And this is going to be your neck notes. I guess I explained you already. Submental, submandibular, jugulodigastric. Then you're going to have your deep cervical lymph nodes, superficial cervical lymph nodes, then posterior cervical, supraclavicular, occipital, posterior auricular. இது எல்லாமே you know actually. So இது எல்லாமே lymph nodes will be getting enlarged. So what is going to be investigation? So you're going to perform a blood test, ASO titer you're going to perform, and urine value, albumin and sugar you're going to see. Okay, well, then coming to your treatment. Before going to your treatment, I want to tell you what are the complications. I told you, right? Acute and chronic tonsillitis. So already told you that complications. Now we are going to move towards tonsillectomy. So tonsillectomy, adenoidectomy. Adenoidectomy na adenoid remove பண்றது. Tonsillectomy na when you're going to remove your tonsil. So what are going to be the indications? So indications is going to be recurrent episodes of infection. 7 recurrent episode, 3 infection for 3 years. 3 infection per year for 3 years, 5 infection per year for 2 years, or 7 infection per year in a single year. Then you're going to consider it as an acute tonsillitis. Or when the patient is going to have a febrile seizures due to fever and tonsillitis. Or if the patient is going to have a chronic tonsillitis. Or if the patient is going to have a peritonsillar abscess. Okay. Or whenever the patient has some malignancy, if you're going to suspect some malignancy, obstructive sleep apnea, dysphagia due to hypertrophic tonsils, or unilateral enlargement of tonsil, or whenever there is going to be a unilateral enlargement of tonsils. In all these conditions, what you will do? You will go for a tonsillectomy. So these are the indications of tonsillectomy. These are the indications of tonsillectomy you need to remember. These are the indications of tonsillectomy you are going to remember. Clear, right? Okay, now moving on to talk about what are the contraindications. So remember, there are some relative indications. What are the relative indications? So these are absolute indication. Relative indication அப்படின்னா styialgia, glossopharyngeal neuralgia, or when you're going to have uvulopalato-pharyngoplasty. In all these conditions, you're going to go for a relative indication of your tonsillectomy. Now, what are the contraindication of tonsillectomy where you should never perform? Number one, when the hemoglobin is going to be more than 10 grams. If the hemoglobin is going to be more than 10 grams, or whenever there is acute tonsillitis, or whenever there is an epidemic of polio, bleeding diathesis, submucosal cleft palate, uncontrolled systemic disease during menstruous, or during child less than 3 years. In all these conditions, you will not go for a tonsillectomy. Contraindication. Now, finally coming towards your, what is the procedure? How we are going to perform your tonsillectomy, guys? Listen carefully. Put the heading as tonsillectomy. So how we are going to perform tonsillectomy surgical procedure? Remember, position. Can you tell me what is the position, guys? What is the position for tonsillectomy? Can you put in the chat box? What is the position for tonsillectomy? Can you put in the chat box? What is the position for tonsillectomy? Adenoid ko tonsillectomy ko ore position da. Adenoidectomy, what is the position I told you? Okay. Next, what you're going to do is, you have two type of procedure for tonsillectomy. Just hold on. Okay, you have two types of tonsillectomy basically. One is a extracapsular. Other is a intracapsular. What is extracapsular? Extracapsular is going to be total tonsillectomy. Whereas intracapsular is going to be partial or subtotal. Okay, or partial subtotal tonsillectomy is called as your intracapsular tonsillectomy. So, எங்க நீங்க intracapsular பண்ணுவீங்க? In condition like sleep apnea. Sleep apnea எல்லாம் வெறும் ஒரு small part of tonsil remove பண்ணிட்டாலே போதும் பேஷண்ட்டுக்கு. So, அதனால அங்கெல்லாம் நீங்க வந்து intracapsular பண்ணுவீங்க. Extracapsular is done whenever there is any infection. You're going to remove the tonsil along with your capsule. That is called as your intracapsular. So, that's called as extracapsular. Clear? Now, moving on to talk about the techniques. What are the techniques you have? So, one is going to be a cold technique, other is going to be hot technique. Cold technique, now you can use dissection and snare method. Dissection and snare method. So, it's a sharp dissection technique using scissor, knife, dissector, and tonsil snare. Or you can go for a micro debrider. Micro debrider. So, this micro debrider is a powdered rotatory shoving device with continuous suction made up of a tube and connected to the hand piece. Then you're going to have the third one that is called as your harmonic scalpel. Remember, your harmonic scalpel will be having a RPM of 55,000. They are going to use the ultrasonic energy. They are going to transfer this energy, vibration energy to your tissue, providing a simultaneous cutting and coagulation. These are going to be your cold method. Then comes your hot method. So in hot method, you can either go for cautery, either you're going to go for cautery method, or you're going to go for coblation method. Or you can also in the cold method add on cryosurgery. You can also perform a cryosurgery. So cryosurgery, you're going to apply a cold instrument over the tonsil. The tonsil here is removed by the process of repeatedly freezing and thawing. This procedure requires a lot of operating time, and but the ultimate advantage is they will not, this patient, the patient who they are going to be doing this cryosurgery, they will not have bleeding. So whenever a patient you're going to encounter with a bleeding diathesis, any bleeding disorders, that time you can go for a cryosurgery in those patients. Okay, so or you can also go for radio frequency ablation procedures, or you can go for a laser procedure. So what is a laser procedure? CO2 laser, or you can go for a KTP laser. Okay, CO2 laser or KTP laser, that can be performed. Now coming to the contraindication, we have already seen for tonsillectomy, right? acute infection, bleeding disorder, polio epidemic, and cleft palate. So what are the complications of tonsillectomy? So what are the complications of tonsillectomy? Remember, complications are going to include hemorrhage. First thing is hemorrhage. So hemorrhage or three types of hemorrhage can occur. One is going to be your primary hemorrhage. Primary hemorrhage. Second is going to be your reactionary hemorrhage. Third is going to be a secondary hemorrhage. Primary hemorrhage na during the surgery. Secondary reactionary hemorrhage na post-operative ward la 24 hours kulla. Secondary hemorrhage na 24 hours la 10 days kulla varadhu secondary hemorrhage. Now coming to the primary hemorrhage, this is the hemorrhage occurring during surgery. Okay, ma? So while operating, if you are going to have a primary hemorrhage or if you're going to have your reactionary hemorrhage or secondary hemorrhage, so what you're going to do is immediately you're going to remove the clip. Remove the clip, the clot or the clip. Then you're going to apply pressure. You're going to give vasoconstrictor. Okay, then you're going to perform cauterization and you're going to ligate the vessel. So this is the ultimate treatment of hemorrhages. Clear. Next, you are going to go for the, what is the other important, what are the other complication you can have? Can tell me what is the common, most complication, rare complication of your adenoid hypertrophy? Can you tell me what is the complication you are going to get in the adenoid hypertrophy? Adenoidectomy. So when you're going to perform adenoidectomy, what is the rare complication you can get? Rare complication in adenoidectomy. We saw hemorrhage, we saw hypernasality, we saw eustachian tube injury in your adenoidectomy. Apart from that, I told you one important rare complication. Do you remember? What is that? Inflammation of inflammatory subluxation of your atlantoaxial joint. Grisel syndrome. That Grisel syndrome can also occur here. So Grisel syndrome can also occur in this tonsillectomy while doing a tonsillectomy also. So that's all. That comes to the end of the discussion of your tonsillitis. Now, can you tell me two important questions? I'll ask you, then I'll move to the next one. Okay, I'll move towards the next one. What is the commonest post-operative complication in tonsillectomy? What is the most common complication that is going to arise in the tonsillectomy? Most common complication post-tonsillectomy. Hemorrhage, excellent. Okay, laser uvulopaltoplasty is done for which condition? Uvulopaltoplasty is done in which condition? In which condition you perform uvulopaltoplasty? Uvulopaltoplasty is done in which condition? Anyone? Uvulopaltoplasty is done in which condition? Uvulopaltoplasty is done in which condition? Remember, snoring. Whenever the patient comes to you, uvulopaltoplasty is done. So in case of obstructive sleep apnea or snoring due to the hypertrophic tonsil and bulky oropharynx. Okay, wow. So that is a very important point you have to remember. And next question is, where do you contraindicate tonsillectomy? I'll give you options. You're going to tell me contraindication of tonsillectomy, URTI, epidemic of polio, chronic tonsillitis, age less than 4 years, bleeding disorder. Among these five, which are going to be the contraindication for tonsillitis? Among these five, which are going to be the contraindication of tonsillitis? I'm telling polio is a contraindication. Excellent. URTI, is it a contraindication? URTI, is it a contraindication? Is it a contraindication, guys? URTI. Of course, acute conditions are going to be a contraindication. And acute condition is contraindication. Polio is contraindication. What else? Among one, I told you. Bleeding disorders. Okay. Whenever there is going to be a bleeding disorder, there is going to be a contraindication. You cannot perform. Okay. You cannot perform. Remember, age less than 4 years, it is not an absolute contraindication for tonsillectomy. Age less than 4 years is not a absolute contraindication for tonsillectomy. URTI, epidemic of polio, bleeding disorders, they are going to be the absolute contraindication for tonsillectomy. With this, I am completing the pre-lunch session. So let's come back at 1:30. So let's come back at 1:30. We have only one more topic in your pharynx, that is going to be your abscess of pharynx. So once we complete this abscess of pharynx, we can move towards the next topic, that is going to be your nasopharynx. So we can move towards the nasopharynx. Okay. So before starting with nasopharynx, I'll send you the important questions in your nasopharynx also. Then we will start. Okay. Thank you. We will come back at 1:30. So around at today 1:30 to 5, we will be discussing about your nasopharynx, and from 6 o'clock or 6:15, around 6 to 6:15, we will start with ear and we will complete it by today end. Okay. Thank you. To begin with, you all- hope you all remember the anatomy of pharynx, where I discussed you about all the spaces which are present. So starting with your space of gillet, then we had a alar space, alar fasciacum, prevertebral fasciacum, nodula, we had a danger space, and between your prevertebral fascia and your vertebra, we had a prevertebral space. So in the spaces, there is a high chances of infection that can occur. So whenever there is going to be infection that is occurring in all these spaces, what happens? So they are going to cause compression over the adjacent structures. For example, so can you all respond in the chat box? If the abscess is going to be present in the parapharyngeal area, somewhere around here. So if my abscess is going to be placed somewhere around here, what are the structures that are going to get involved? The structures that are going to be present in this area. For example, your medial pterygoid is placed here. So your medial pterygoid is going to get problem. Or can you tell me what is the three nerves, guys? What are those three nerves which I have mentioned here? They are going to be the branches of mandibular nerve. What are those branches of mandibular nerve? Anyone? What are those branches of mandibular nerve? Anyone, can you let me know? Can you tell me what are those branches of mandibular nerve which are present over there? Over your parapharyngeal space? It is going to be your, yes, it is going to be your three important branches of your mandibular nerve. What are the three important branches of the mandibular nerve which is present here? It is going to be your auriculotemporal nerve. So it is going to be your auriculotemporal nerve, auriculotemporal nerve, auriculotemporal nerve. And second one, it is going to be your lingual nerve, and third one is going to be your inferior alveolar nerve. And what is this artery? It is going to be your maxillary artery. So whenever there is going to be any abscess in this area, in the pre-styloid component of your parapharyngeal space, it is going to affect all these structures. So ultimately, what I am requesting you all is, you should be memorized with this image. You should never forget this image, the one which we are going to discuss right now in the abscess heading. Everything is going to be easier if you understand this image. So what are the structures that are present in the post-styloid component? You're going to have your internal carotid artery, internal jugular vein, 9th, 10th, and 11th, 12th nerve, and you're going to have sympathetic chain. So whenever there is going to be abscess in your post-styloid component of your parapharyngeal space, that is going to cause compression to those areas. So that is ultimately what happening. Now let's move into in discussion about your the next spaces. So we are going to see all these spaces. One is your parotid abscess, Ludwig's angina, peritonsillar abscess, then your retropharyngeal abscess, acute retropharyngeal abscess, then chronic retropharyngeal abscess, parapharyngeal abscess. All these are asked as a short note question. If you're going to go through your papers, most commonly one question out of these 7 will be there in every year exam papers. So that means that if you are going to be thorough with these 7 topics, you can sure shot you're going to get 5 marks in your exam. Okay. So are you all ready to listen to it? Yes. So first, let's move towards the easiest one. That is going to be your peritonsillar abscess. So do you remember where is your tonsil present? Any idea? Where is your palatine tonsil present? Can you put in the chat box? Your palatine tonsil is present between the anterior pillar and your posterior pillar. This is going to be your anterior pillar. This is going to be your posterior pillar. Between your anterior and posterior pillar, you're going to have tonsil like this. Over that, you're going to have your buccopharyngeal fascia. Then after buccopharyngeal fascia, you're going to have your alar fascia. You're going to have your prevertebral fascia. Then you're going to have your vertebra. And afterwards, what you have, very simple, if this is going to be your buccopharyngeal fascia, okay, so you're going to have, after your buccopharyngeal fascia, you're going to have your muscle. what muscle? You're going to have your constrictor muscles. After the constrictor muscle, so you're going to have your constrictor muscle next, constrictor. Then after constrictor muscle, you're going to have the next layer that is going to be your pharyngobasilar fascia. So this is going to be, I'm sorry, this is going to be your pharyngobasilar fascia, pharyngobasilar fascia. Then you're going to have constrictor muscle. Then you're going to have your buccopharyngeal fascia. Buccopharyngeal fascia. After buccopharyngeal fascia, you're going to have your mandible like this. So above, medial to your mandible, you're going to have one muscle. What is this muscle? Medial pterygoid muscle. And you're going to have laterally, you're going to have your masseter muscle. Okay, so hope you all can visualize what I am telling. So you're going to have your tonsil here. This is your anterior pillar. Then you're going to have your posterior pillar. Above your posterior pillar, you're going to have pharyngobasilar fascia. Above that, you're going to have constrictor muscle. Then you're going to have buccopharyngeal fascia. After buccopharyngeal fascia, you're going to have your mandible. Above your mandible, medially, you're going to have medial pterygoid. And laterally, you're going to have you're going to have masseter. And here, you're going to have your parotid gland. Parotid is going to be present here. You're going to have your submandibular gland here. You're going to have your submandibular gland here. So you're going to have submandibular gland. So this is how you are going to just visualize whatever present here. Now the point is, now we are going to discuss about peritonsillar abscess, which is called as peritonsillar area. Between your posterior, you're going to have a posterior pillar, and you're going to have something here that is going to be your you're going to have your pharyngobasilar fascia. Between this pharyngobasilar fascia and your tonsil, this area, you're going to call this as peritonsillar area. In this peritonsillar area, you're going to have a vein. What is that vein called as? That vein is called as your peritonsillar vein. Okay, so now you know what is peritonsillar area, what is peritonsillar vein. Again, I am repeating, peritonsillar area is the area between your, what? Between your capsule of your tonsil. So you're going to have a capsule here, between your capsule and your constrictor muscle. Between your capsule and your constrictor muscle, you are going to have a big area that is called as your peritonsillar area. This is called as peritonsillar area. So any infection of oropharynx, they are going to affect your tonsil through the crypts. So your tonsil, you all know that your tonsil is going to be something like this, right? So you're going to have a tonsil, which is going to be something like this. And this is called as your crypts of your tonsil. Now, what happens whenever there is going to be infection that is going to affect the tonsil, they are going to go in depth of your crypta magna and they reach your peritonsillar space. So it's going to be ulta direction like this. So you're going to have your crypta magna. Now, any infection, they are going to seep inside and they are going to go into the peritonsillar area. Now, whenever they are going to go into the peritonsillar area, these pus are going to form a collection, and that's what we are going to call it as a peritonsillar abscess. Since the tonsil is going to become atrophic in the adult, the crypta magna can easily get reached up to your capsule. See, in the children, it is going to be a size of your tonsil will be like this. But as the age advances, what happens is there is going to be atrophy of your tonsil and your crypta magnus is going to become deep like this. So can you compare and tell me in which position or in the which age group the pus is going to seep into your crypta magna and reach your peritonsillar area? Definitely it is going to be in the adult state. In the adults, it is going to reach to the peritonsillar area. So that is why peritonsillar abscess is common in which people? Can you tell me in which people peritonsillar abscess will be common? Yes, it will be in the adult age group or at least in the age group of adolescents. So around 21, 22 years on the age group. Okay, now let's see what is going to be the cause of it. Okay, so this is going to be what is going to be your cause? Usually it follows acute tonsillitis. Can you tell me what is the most common organism that is going to cause acute tonsillitis? Anyone from the morning session? Aishwarya, Balashruti, Berlin, Ravi Krishnan. Can you tell me what is going to be the organism that is going to cause acute tonsillitis? Most common organism. I told you, right? Any try? Others also can try. Jayashri, Sam, can you try? What is the most common cause? Okay, Aishwarya is telling streptococcal pneumonia. Others? Others? Do you remember the slide? I was telling you, right? So the most common organism is going to be group A beta hemolytic streptococci. Apart from that, you're going to have your Haemophilus influenza, viral, respiratory gram-positive, pneumococcus, staphylococcus, streptococcus, diphtheria. Ellame they are going to cause acute tonsillitis, guys. But if I ask you most common, okay, it should be group A beta hemolytic streptococci. They are going to be the most common condition. Okay, clear, right? Next. So now you know what is the most common infectious agent. It is going to be group A beta hemolytic streptococci. And then you have to understand that, okay, so this peritonsillar abscess will be always presenting unilateral. Why? Because so you're going to have infection only in one tonsil. Unlike your adenoid presenting as a bilateral feature, your palatine tonsil will be presenting unilaterally initially. Even though at the later stages, they may get transmitted to bilateral condition, but initially it is going to be unilateral. Clear, right? Now, let's move on towards the clinical presentation. So how the clinical presentation is going to be in these patients? So I told you it is going to affect adults more than the children, and I have given you the explanation why adults more than your children. And usually this is going to be unilateral, occasionally bilateral, it can be there. And clinical features are, you're going to divide it into general and local. So first, general thing, you all know, fever will be there in every patient whenever there is going to be any infection. So there will be chills and rigor, general malaise, body ache, headache, nausea, constipation. இது எல்லாமே they are going to be features of septicemia. Okay, va? So இதெல்லாம் வந்து not specific to your tonsillitis. It can be due to any other infection per se. Now you are going to move towards a local cause. Now let's see one by one. So your tonsil is present in your oropharynx. Now what happens whenever there is going to be enlargement of tonsil? Whenever you're going to eat something, whenever you're going to try to swallow something, what happens? It is going to irritate your tonsils, and that is going to cause pain during swallowing. Pain during swallowing is called as odynophagia. Odynophagia. So odynophagia is the first earliest clinical finding you're going to see in case of your peritonsillar abscess. Second thing is going to be, there will be a muffled and thick speech. Why do you get this muffled or thick speech? So any painful oropharyngeal mass can lead to a voice which resembles as if there is a hot potato in the mouth. Okay, that is called as your hot potato voice. And then the patient is going to have a drooling of saliva. The patient will be having a drooling of saliva. That is also a very important point. And then there is going to be a pain in the ear. Referred pain occurs to your ear. And can you tell me which nerve is involved in the referred pain to ear? So referred pain to ear is caused by which nerve? Referred pain to ear is caused by which nerve? Anyone? Can you put in the chat box? Referred pain to ear from your tonsil to your ear. It is going to be your very good Berlin. It is going to be your ninth nerve. That is going to be your glossopharyngeal nerve. That is going to be a glossopharyngeal nerve. Clear up. Next, you are going to have your trismus. Can you tell me why your trismus is occurring? You already told me that. Okay, when in this picture, can you see? So what happens in this picture? Whenever there is going to be abscess here, that is going to involve your medial pterygoid muscle. Medial pterygoid muscle is necessary for opening of your mouth. So whenever there is going to be a peritonsillar abscess, that is going to involve your medial pterygoid muscle. Since it is involving your medial pterygoid muscle, you are going to have a trismus. So now you can see this image and tell me, guys. So one is going to be, you're going to have your glossopharyngeal nerve here. So you will be having an entry of glossopharyngeal nerve somewhere around here. You have your facial artery, which is going to come around somewhere at this point. So what are the points you're going to get here? Number one, there is going to be odynophagia. I told you the explanation. Number two, there can be a hot potato voice. Number three, there is going to be involvement of your ninth nerve, glossopharyngeal nerve. Therefore, there is going to be a referred pain to your ear. Number four, medial pterygoid muscles are involved. Therefore, you're going to have trismus. And finally, fever will be there as there is going to be a cytokine storm caused due to the abscess. So in the facial artery இருக்கு பாத்தீங்களா, இது வந்து it is going to supply your areas of your tonsillar bed. Now what happens is whenever there is going to be any inflammation over there, that is going to enter into your blood vessels, and this blood vessels will be taking into your inside your blood circulation, and அங்க வந்து there is going to be a interferon gamma and TGF beta involvement. They are going to cause cytokine storm. அந்த cytokine storm நால தான் உங்களுக்கு fever வருது. Clear up? So now on examination, now these are the symptoms. Okay, these are the symptoms on examination. So it's ரொம்ப important because you will be like, you may get a short case. I think in Viluppuram Medical College, I guess they kept peritonsillar abscess as short case. So I want you all to remember that. Okay, so because of the pus collection lateral to the capsule of tonsil, your tonsil is going to be pushed medially. So because there is going to be collection at this area. So because of what happens, because there is going to be collection of your peritonsillar abscess in the media, in the lateral aspect, what happens? Your tonsil is pushed medially. Since your tonsil is pushed medially, you can actually visualize. So uvula பக்கத்துல, so normally it will not be visualized properly. But if you're going to see in a patient who is going to have peritonsillar abscess, they will have a proper visualization of this tonsils. Okay, they are going to have proper visualization of tonsils. But what happens most of the time is this is peritonsillar abscess. But people will be getting confusing with the chronic or acute tonsillitis. இங்க tonsil நல்லா இருக்கு. So நல்லா புரிஞ்சுக்க வேண்டிய பாயிண்ட் என்னன்னா, இங்க tonsil is very good. He is not having any problem. But around the tonsil, there is going to be collection of pus. So that is called as peritonsillar abscess. Okay, clear up. Now, what you have to do? Now what happens when your tonsil is going to be pushed here somewhere? This is going to be your two sides of tonsil. So you're going to have your anterior pillar, you have posterior pillar, and you're going to have your uvula like this. You're going to have your uvula like this. Now what happens? Slowly they both are going to come out. Because they're going to come out, what happens is your uvula will be getting swollen now. So now your uvula also is getting swollen, and you're going to have abscess all around here. You're going to have abscess all around your peritonsillar area. Because of that, what happens is there is going to be a bulging of soft palate. So this is called as your soft palate. So this entire region is called as soft palate. Since there is going to be, so this area is called a soft palate basically. So now what happens, since there is going to be accumulation of pus inside all over them. So what happens, your soft palate is going to get bulged away, and your anterior pillar will also get bulged off. Your anterior pillar will also get bulged off. Now can you visualize and tell me? So your anterior pillar is going to get bulged off. Your posterior pillar is going to get bulged off. Your soft palate is going to get bulged. Your uvula is going to get swollen. And what happens is, if there is going to be infection at this point, now, this uvula is going to be pushed towards this direction. If it is going to be unilateral, if you're going to have your peritonsillar abscess only at the right side, now what happens? Your uvula is going to be pushed towards your left side. So that's what I'm meaning, that the uvula will be pushed to the opposite side. If you're going to remember by using these images, you will never forget what are the symptoms and signs which you are reading now. Otherwise, symptom and sign, if you're going to mug up, definitely it is going to get forgotten while you're going to sit in your exam. So that is why I'm just explaining every symptom with a diagram. Clear, right? Next. See here. So this is what happens whenever there is going to be abscess. Now the uvula is going to be pushed towards opposite side. Can you see here? This is a peritonsillar abscess. So you're going to have your entire tonsillar area is going to get bulged away, and your uvula is going to be pushed to the opposite side. Okay. Then you will have a mucopus that is going to cover your tonsillar region. Cervical lymphadenopathy is commonly seen. This involves jugulodigastric lymph nodes, and torticollis because from this area, it can subsequently seep into your, okay, they are going to subsequently seep into your each individual spaces, especially your retropharyngeal space. From your peritonsillar area, the pus is going to be seeping into the retropharyngeal space. அதனால retropharyngeal space குள்ள enter ஆகும்போது, that leads to neck abscess. So it is going to cause neck is going to be kept tilted on one side. That is called as your torticollis. Now, what is going to be your treatment of choice here? Management is very simple, guys. You have to incise, you have to drain the pus. That's all. The incision is given either at the maximum bulged area or just lateral to the vertical line drawn at anterior border of anterior pillar. So if this is going to be your anterior pillar, so you're in the anterior border of anterior pillar, you're going to just draw, you're going to cut like this. You're going to just put an incision like this. Okay, wow. So this is going to be called as your incision and drainage. So second, what you can go is you can go for an antibiotic. So you can go for antibiotic. So you're preferably, if you're going to ask me what antibiotic, preferably it is going to be your beta-lactam group of drugs. Beta-lactam, can you just put a example of beta-lactam group of drugs in the chat box? Beta-lactam group, an example of beta-lactam group. Along with beta-lactam, you will add a metronidazole. Metronidazole. Can you put an example of your beta-lactam group of drugs? What is beta-lactam group of drugs? Just you would have passed last year in your pharmacology, right? Can you just put in the chat box? Very good. Penicillin, cephalosporin, all these are going to be your beta-lactam group of drugs. Okay, so your beta-lactam group of drugs is actually helping you. Okay, it is going to help you. Along with that, you are going to add your metronidazole because you have to cover your anaerobic organisms also. Now, coming to, you have to give analgesic so that the pain will be relieved. Oral hygiene has to be maintained. After a period of 6 weeks, so after you're going to prescribe all these things, after a period of 6 weeks of interval, okay, so what you're going to do is you're going to perform a interval tonsillectomy. You're going to perform interval tonsillectomy. So first, you're going to give all these things. Okay. You can go for hospitalization, you can go for IND, you can go for intravenous fluid, antibiotic, analgesic, oral hygiene. இதெல்லாம் பண்ணதுக்கு அப்புறம் ஒரு 6 weeks gap put, you're going to go for interval tonsillectomy. Now you will ask me, why should I do tonsillectomy when the tonsil is not having any problem? Because remember, so in spite of initial incision and drainage, there will be repeated collection of infection. Okay, after your course of your antibiotic. So what happens is after the effects of antibiotic vanishes, there will be again collection of fluid, collection of abscess over there. That is why what we are doing is, so we are going to just, okay, so we are just going to remove the tonsil. Now you'll ask me the next question. Why should I remove the tonsil? Instead, when I'm going to get the fluid again, now I can again do an incision and drainage. If you're going to do a repeated IND, so when you're going to perform a repeated IND, what happens is it is going to lead to fibrosis and adhesions. So once fibrosis and adhesions is going to happen, what happens is you cannot next time, subsequently, second or third time, you cannot remove the pus completely because they will be like adhered to the mucosa over there. So you cannot completely remove the infectious material. Therefore, that is going to complicate your condition. That is why you will remove your tonsil. So instead, what you will do, you will just remove your tonsil. And after removing your tonsil, what you will do is you will just stitch that area between the anterior and posterior pillar. You're just going to put a suture so that that space is not there further. So on the space illana, on the space la future la collection of fluid nadakadu. Okay, so that is the rationale behind your interval tonsillectomy. Okay, so this is your incision and abscess. You can go for a horizontal incision or you can go for a vertical incision. So interval tonsillectomy removal with after 4 to 6 weeks after the attack of quinsy, and abscess or hot tonsillectomy. What is that? It has a risk of rupture of abscess during anesthesia and excessive bleeding can occur. So previously what happened is they were doing a tonsillectomy during the time. What is hot tonsillectomy? So tonsillectomy done at the time of acute infection. At the time of acute infection, that can actually cause a complication. Therefore, nowadays we are not using this method of hot tonsillectomy. Is it clear? So complication, they are rare with modern therapy. Parapharyngeal abscess, edema of larynx, tracheostomy may be required. Septicemia can occur. Pneumonitis or lung abscess can occur. Jugular vein thrombosis, spontaneous hemorrhage from your carotid artery and jugular vein. So these are the complications. Now moving on to talk about the next important space, that is going to be your parapharyngeal abscess. So let's complete parapharyngeal abscess and come back to your retropharyngeal abscess. Now you all know what is that parapharyngeal abscess, right? So you all know, I'm just coming back to the anatomy again. So this is going to be your parapharyngeal space. Now, whenever there is going to be an abscess in your parapharyngeal space, so in spite of very small space, it is going to be the most commonly infected space. If you're going to see here, from your tonsil, this is going to come easily to your parapharyngeal space. So you all know that tonsillitis are very common in the child. So tonsil and the infection will be seeping into your parapharyngeal space easily. Therefore, most common among all these infection is going to be your parapharyngeal abscess, and that is the reason why they ask you most of the time from your parapharyngeal space. Parapharyngeal abscess is asked as a common short note question. That's why I'm discussing it first. Okay, so now, whenever there is going to be a abscess in your parapharyngeal space, it is going to involve your parotid. It is going to involve your prevertebral space. It is going to involve your danger space. It is going to involve your retropharyngeal space. எல்லா இடத்தையும் involve பண்ணிடும் your parapharyngeal space மட்டும். Okay, so now parapharyngeal space, you know that you're going to divide into a pre-styloid process and post-styloid compartment. Can you tell me what are the muscles that are going to be attaching to your styloid, or muscles that are originating from your styloid? Anyone? What are the muscles that are originating from your styloid? Can someone respond in the chat box? I'll give you one clue: stylohyoid. I'm telling stylohyoid. Others? Stylohyoid. What are other muscles? It's going to be your stylohyoid, styloglossus, and stylopharyngeus. So that is what I have given a 3 ring-like structures. So these 3 are the muscles that are coming from your styloid process. This is going to divide into your anterior compartment and posterior compartment, or pre-styloid and post-styloid compartment. So whenever there is going to be a pre-styloid abscess, something like this, this is going to be your pre-styloid abscess. So this is going to be your pre-styloid abscess. This is going to be a pre-styloid abscess. So whenever there is going to be a pre-styloid abscess, what happens? Now, it is going to push your tonsil towards the medial aspect. So now what happens? Your tonsil is going to be pushed towards medial aspect. That is going to be the first clinical feature you're going to see. Second, you are going to have an involvement of your medial pterygoid. So if the medial pterygoid is involved, can you put in the chat box what is going to be the symptom you're going to get? Can you put in the chat box, guys? What is the symptom you're going to get when your medial pterygoid is involved? When medial pterygoid is involved. Very good, very good. Only Berlin is answering. What about others? Balashruti, very good. Others? Aren't you understanding anything? If you are not having any understanding, or if you have any doubt, kindly put in the chat box, guys, because you don't have time to revise again. So this should be the last revision of you. Okay? Trismus, and others? Okay, so remember, trismus is going to be the one that is going to be occurring when there is going to be involvement of your medial pterygoid. And the third important thing is, so this is going just below the mandible. You're going to have your jaw, isn't it? From your mandible, you will be having your jaw, right? So, அந்த இடத்துல உங்களுக்கு jawல என்ன ஆகும்னா, especially at the neck of your jaw, neck of angle of jaw, what happens? There will be a bulge. So, there is a bulge present in the neck of angle of jaw. So there will be a bulge that is present in the neck of angle of jaw. Okay, wow. So neck of angle of jaw, you will have a bulge. 1 minute. Just hold on. Yeah. So retropharyngeal, parapharyngeal abscess. So, okay, now your parapharyngeal abscess, the infection can seep either from your pharynx or from any teeth ache. So any teeth infection or ear infection or any other infection from other parts of the body. So that can come, and that is going to cause accumulated over here. So this is the exact image which I tried to represent as my own image, but I'm not sure how that was conveyed to you. But this is the image. If you find it easy, whichever I drew, if you find it easy, just try to replicate it in your exam. Okay, guys. So now coming to the clinical features, it depends on which compartment is involved. So if there is going to be an anterior compartment involved, I told you there will be a prolapse of your tonsil. There is going to be a trismus, and there is going to be external swelling behind the angle of jaw. This is all about your pre-styloid compartment. Now, whenever there is going to be involvement of your post-styloid compartment, so you know that in your post-styloid compartment, you are going to have 9th, 10th, 11th, 12th, internal carotid artery and your internal jugular vein, and you're going to have your sympathetic trunk. So all these are going to get involved along with your upper deep cervical lymph node. So this upper deep cervical lymph node will be communicating with your retropharyngeal, submandibular, carotid and visceral lymph nodes also. So this is how exactly it is going to occur. So remember, whenever there is going to be your posterior compartment, that is going to be a post-styloid compartment involvement. Post-styloid compartment involvement, what happens is there will be a torticollis. So there will be a torticollis because of spasm of your prevertebral muscles and also involvement of your 9th, 10th, 11th, 12th cranial nerves. Now, what is going to be your treatment of choice for these patients? So treatment of choice will be, again, you will be having a fever, odynophagia, sore throat, torticollis, toxemia. All these are common with every infection. So that I don't want to repeat once again. But then you can just write it down for all infection, whichever the examiner is going to ask you. Now coming to the treatment. So as usual, you're going to go for a drainage of abscess. How you're going to put an incision here? 2 to 3 centimeter below the lower border of mandible. 2 to 3 centimeter below the lower border of mandible. You're going to put an incision and you're going to give IV antibiotics. So this is going to be your treatment of choice for your parapharyngeal abscess. So any infection in the neck, always given 2 fingers below your lower border of your mandible. So on the lower border of mandible, you're going to give 2 finger breadth, you're going to put incision. Can you tell me why 2 finger breadth is given in the incision? While putting an incision, anyone? Because so if you're going to have your submandibular gland here, so there's going to be a submandibular gland here. Between that, after 2 finger, you're going to put an incision somewhere around here. Why you're putting like this is, in this intermediate space, you're going to have a very important nerve that is passing by. That is called as your fascial nerve. Do you remember? So here you're going to have your fascial nerve, which is going to be passing by. So you will be having a fascial nerve. So if you're going to have here, you're going to have your parotid. Over the parotid, you're going to have the division of 5 important nerves, and this fascial nerve will be like coming from here, and it is going to be traveling in the lower angle of your mandible. That is the reason why fascial nerve will be affected if you're not going to give 2 finger breadth below your angle of mandible. Okay, this nerve curves to ascend up from the neck, crossing your mandible, and to supply the corner of your mouth and lower lip. Injury to ear. So when you're going to have an injury at this point, what happens is there will be inability. There will be a inability of, okay, inability of corner of mouth and the lower lip and your lower lip to move down while you're speaking, to move down while you're speaking. So அதனால என்ன ஆகும்னா, the cosmetically when the people is seeing that patient, they will have some irritation. Like அந்த people யார் அவங்க கூட பேசுறாங்களோ அவங்க சொல்லுவாங்க, ஏன் வாய் வந்து கோன்ன மாதிரி இருக்கு. So வாய் வந்து ஒரு பக்கமா இருக்கிற மாதிரி இருக்கு. அந்த மாதிரி they will be telling because the lip is not going to move along with their while they are speaking. So that is a very important thing. So that's why the people comes to you and you have to understand and you have to rectify. You're going to understand, you're going to rectify. I'll give you a typical case scenario that was asked in your exam for your parapharyngeal abscess. A 50-year-old diabetic man with fever, neck swelling, outer 1/3 of the sternocleidomastoid and tonsils on same side pushed medially. So இந்த மாதிரி ஒரு கண்டிஷன் கொடுத்திருப்பாங்க. So say tonsil pushed to same side medially, that is 1 point. And second thing, there is going to be a bulge in the lateral sternocleidomastoid that is going to bulge along the angle of mandible, and you're going to have your fever. So all these are going to be pointing towards parapharyngeal abscess. Okay, all this points towards your parapharyngeal abscess. Clear? So now coming towards the end of your parapharyngeal abscess. Now complications of parapharyngeal abscess includes acute edema of your larynx with respiratory obstruction, thrombophlebitis of jugular vein with septicemia, spread of infection to retropharyngeal space, and spread of infection to mediastinum along your carotid space, and carotid blowout with massive hemorrhage can occur because you know that you're going to have your internal jugular artery and you're going to have your internal jugular vein. So these two along with your sympathetic chain, they are going to be covered by a fascia. This fascia is called as your carotid fascia. Whenever there is going to be a blowout, of your carotid fascia, that is going to injure your carotid vessels. So that will lead to massive hemorrhage. This you're going to understand. Clear, right? Any doubt in this? Okay. Next, we are going to move towards the third important question. That is going to be your Ludwig angina. Ludwig angina is repeated question asked in your university exam. So I want you all to be little careful. So to understand what is Ludwig's angina. So Ludwig's angina, if you're going to see this image. Okay. So this is going to be your sublingual space. This is going to be a submaxillary space. And this is submental area. So you're going to have your mylohyoid muscle. So this is your mandible, guys. Basically, this is your mandible. I've just cut down your mandible. So from here, you're going to have your mylohyoid that is going to be running like this. You're going to have your mylohyoid muscle that is going to be running like this. And this is going to be your sublingual space and submaxillary space. Clear, right? Any doubt in this? So any infection in the submandibular space that is going to be okay, that is going to be your below your mandible. So this everything is called as your submandible. So this entire region is called as your submandibular area. So submandibular area, like any infection that is going to be occurring or any pus collection that is going to be occurring, what happens is they are going to cause Ludwig's angina. So angina means pain. Ludwig's angina means pain that is going to be caused due to dental caries. So whenever there is going to be infection to your tooth, what happens? That infection is going to slowly seep into your submandibular area. Now, the organism responsible here, what is the organism that is responsible for dental caries? It is going to be mixed aerobic. Mixed aerobic. What are the mixed aerobic? Number one, it's going to be your alpha hemolytic streptococci, alpha hemolytic streptococcus, streptococcus. Number two is going to be your staphylococcus. Staphylococcus. Okay, staphylococcus. These two are going to be the organism responsible. Apart from that, you have anaerobic organism. Anaerobic organism example is going to be your bacteroids. The submandibular space is going to divide into two space. Your submandibular space is divided into two space by your mylohyoid muscle. It is also called as oral diaphragm. The space above your mylohyoid is known as sublingual space, and that is below your mylohyoid is going to be called as submaxillary space. Remember, sublingual space is the one that is going to first get affected because of the premolar tooth. Sublingual space will be affected if the involved tooth is going to be premolar. If it is going to be molar tooth, okay, then you're going to have the involvement of submaxillary space. Involvement of submaxillary space. Now, how will the patient present to you? So, what is the presentation to you? I have told everything. So, usual dental infection, premolar, sublingual, molar causes submaxillary. Clear? So, now moving on to talk about your bacteriology. I already told you it's going to be a mixed infection. Now, coming to the clinical features. So, infection of your sublingual space will lead to raised floor of the mouth. So, there will be a difficulty in eating and difficulty in speaking. And the infection of your submaxillary and submental space will be causing a very tense swelling, and this is going to give you a woody art feeling. So this is going to impart a woody art feel. So it will be swollen and tender, and they will be imparting a woody art feel. Clear? Okay, clear, right? Now coming towards, along with that, the patient will also have a trismus. The patient will also have trismus. Trismus here is due to the tense mass below your mandible. Okay, ultimately, both these spaces get involved as they communicate with each other behind your medial border of myloid. So behind your medial border of myloid, both your sublingual space and submaxillary space, they are going to get communicated with each other. Okay, now you have to remember 4 important diagnostic criteria that is called as gold ring diagnostic criteria. Gold ring criteria. What is that gold rings criteria, guys? Listen carefully. This will always present like a cellulitis. Though we call it as abscess, they always present like a always present as cellulitis. Can you tell me what is cellulitis? What is a cellulitis? Cellulitisல தான் உங்களுக்கு இந்த மாதிரி ஒரு பெயின் இருக்கும், swelling இருக்கும். So that is called as your cellulitis. If abscess is present, then you don't call it as a Ludwig's angina. Instead, you're going to call it as a submandibular abscess. Only when you're going to have a cellulitis presentation with pain, you're going to call it as a Ludwig's angina. That is why I'm not telling it as a Ludwig's abscess. I'm telling it as a Ludwig's angina. Clear? And second thing, it will always be bilateral. It will never be unilateral. Number 3, they are going to spread through tissue spaces. They are going to spread through your tissue spaces, and they are not going to spread. They are not going to spread through the lymphatics. And fourth one is it does not involve the submandibular and sublingual salivary gland. So it doesn't involve submandibular and sublingual salivary glands. Sublingual salivary glands. Clear? It doesn't involve your submandibular or sublingual salivary glands. Now coming towards your management. How do you manage this case? Number one, you're going to give a incision and drainage. In spite of Ludwig's angina being a cellulitis and not abscess, you have to perform incision and drainage. So cellulitis la நம்ம usually வந்து எடுத்தோனே incision and drainage பண்ண மாட்டோம். So வெறும் abscess la தான் நம்ம பண்ணுவோம். But in spite this is going to be a cellulitis, you're going to perform an incision and drainage. Now, where will you put the incision? Horizontal incision you're going to put. Horizontal incision is going to be given 2 to 3 centimeter below. 2 to 3 centimeter below the lower border of mandible. Lower border of mandible that is going to extend from one angle of mandible to other. So that is going to extend from one angle of mandible to other. One angle of mandible to other. Clear, right? So this is given to relieve the tissue pressure and accelerate the healing. That is why you're going to perform an incision and drainage. Now, apart from that, you're going to go for antibiotics as usual, which is going to cover both your aerobes as well as anaerobe. So if you want to cover both aerobe and anaerobe, what is going to be your treatment of choice? What is going to be a drug of choice? Can you put in the chat box? If you want to cover both aerobes and anaerobes, what will be your drug of choice? What will be your drug of choice? You have to give 2 drugs. What are the 2 drugs you're going to give? Come on, guys. You all know the answer. Just before last இதுக்கும் நம்ம இதே தான் சொன்னோம். என்ன antibiotics நீங்க கொடுக்க போறீங்க? Metronidazole and very good Sam. Metronidazole and beta-lactams. Excellent. Excellent. Leander Sam, Ravi Krishna, Balashruti, everyone are excellent. So you're going to give beta-lactam and you're going to give metronidazole. Okay, the last and important abscess you're going to have is going to be your retropharyngeal abscess. Now you're going to see the last and important one. That is going to be your retropharyngeal abscess. Okay, so why I made this retropharyngeal abscess as the last one? Because your retropharyngeal space is going to be lying between. Now going back to the anatomy, you all know retropharyngeal space is going to be lying between your retropharyngeal space is going to lie between your buccopharyngeal fascia and your alar fascia. So between your buccopharyngeal fascia and alar fascia, you have this midline raphe that is going to divide your retropharyngeal space into 2 spaces, 2 lateral spaces. They are called as space of Gillette. Now, retropharyngeal space is going to extend from, can you recall and tell me? It is going to extend from the base of the skull to T4 vertebra. It is going to extend from your T4 vertebra. It is going to extend from the base of the skull to T4 vertebra. This will be extending to your T4 vertebra, retropharyngeal space. Okay, wow. So now these are the 2 points which already you all know, and it is going to divide by longitudinally by your paramedian raphe, that is called as your Gillette space. Now, first topic which we are going to discuss is acute retropharyngeal abscess. The first one which we are going to discuss is acute retropharyngeal abscess. Acute retropharyngeal abscess. Okay, மெயினா வந்து பாத்தீங்கன்னா இந்த retropharyngeal spaceல உங்களுக்கு என்ன இருக்கு அப்படின்னு பார்த்தோம்னா we have something called as nodes of Rovier. So can you see here? All these are called as nodes of Rovier. So these are going to be the small lymph nodes that are present. So any abscess in your retropharyngeal space will be presenting as a retropharyngeal lymphadenitis. So you're going to have your acute suppurative lymphadenitis. So that lymphadenitis, what happens? They will be like, from there only the infection is going to seep outside and they're going to come into your retropharyngeal space. So first you're going to have your lymphadenitis. So what are the lymph nodes here? Nodes of Rovier. From those lymph nodes, you're going to have your pus that is going to come outside and collect in the retropharyngeal space or your space of Gillettes. Clear, right? So or you're going to have the space of Gillette. So now what happens is this one is most common. So this is going to be most commonly due to your adenoid or nasopharyngeal infection or posterior nasal sinus infection, nasal cavity infection. But they are going to come to your nodes of Rovier. Because your nodes of Rovier is the one that is affected here, you are going to have your acute retropharyngeal abscess. Retropharyngeal abscess you are going to get. Clear? So, since nasopharyngeal and oropharyngeal infections are more common in the children, acute retropharyngeal abscess is also more common in the children than adult. In adult, it is going to be more commonly due to penetrating injury. உங்க கழுத்துல யாராவது கத்தியை வச்சு குத்துறது, the compass வச்சு யாராவது குத்துவாங்க. So இந்த மாதிரி நீங்க ஏதாவது ஒரு இன்ஜுரி ஏற்பட்டதுன்னா அதனால வரக்கூடிய இன்ஃபெக்ஷன் வந்து it is going to cause a acute retropharyngeal abscess. Clear? Now we are going to move towards, and I'll tell you another one also. When you're going to eat fish, so in the fish bones, when what happens, they are going to go and cause laceration over your posterior pharyngeal wall. So because of that, there will be a collection of pus in your retropharyngeal space. So these are more common in the adult than the children. Okay, well, more common in your adult than your children. Now coming to the clinical features. Now tell me, what are the clinical features you have? So you're going to have your esophagus, which is going to run down, and you're going to have your trachea in front. So because of that, what happens? There will be a dysphagia will be there, and there will be a difficulty in breathing. And apart from that, you can have stridor or cough will be present. Torticollis, because your neck is going to affect one side neck, there is going to be collection of infection. Because of that, you're going to have torticollis and bulge that is occurring in the posterior pharyngeal wall. When you're going to go for a radiograph, post soft tissue lateral view எடுத்தீங்கன்னா, this will be showing widening of prevertebral shadow, and possibly even the presence of gas can be present. So now what is going to be your treatment of choice for these patients? The treatment of choice is going to be, you're going to go for an incision, and then you're going to go for a drainage. So you will be going for an incision and drainage, followed by your systemic antibiotics. So you're going to give systemic antibiotics. Okay, so incision and drainage, systemic antibiotic, and tracheostomy can be done. Now coming to the chronic retropharyngeal abscess. Now, whenever there is going to be a chronic retropharyngeal abscess, what happens is that retropharyngeal abscess, it will be seeping into your, so there will be a seeping of your infection into your prevertebral space also. That is the only problem you're going to have here. So what happens is there will be a seeping of your infection into your prevertebral space. So that is the only big problem you're going to have. So this mainly in the type of infection is going to be tubercular in nature. Tubercular carries of your cervical spine. So tubercular infection of your retropharyngeal lymph node, secondary to your tuberculosis of deep cervical lymph node. So here you're going to have your spinal cord. So spinal cord முன்னாடி இருக்கிற area வந்து you're going to call it as a prevertebral spaces. Prevertebral spaces like you're going to have some lymph nodes. And the lymph nodes வந்து they will be draining into the node of Waldeyer. So they will be draining into the nodes of Waldeyer. So when this from here, when it is going to drain into your nodes of Waldeyer, what happens? They will not affect your danger space very particularly. Danger space மறந்து போயிடுறாங்க. Prevertebral space இருந்து உங்களோட retropharyngeal space direct infection is going to come, and they are going to get accumulated. So what is going to be your treatment of choice here? So I already told you it is tubercular. So treatment is ATT. So anti-tubercular drug will be the mainstay of treatment. And one big problem is they are going to compress some nerves. Because they are compressing some nerves, or because they are compressing your the trachea, esophagus, you have to immediately try to give a aspiration of all the abscess. Once you're going to aspirate, they will be having a relieving of symptom. So you can perform an incision or drainage. You can go for aspiration also. So you can go for aspiration also. With this, we are completing almost all the abscesses which we had. Okay, now the only abscess which is left is your parotid abscess. That also I will be discussing, so that with that, all your head and neck infections will be over. Now coming to the parotid abscess. They are going to be the suppuration of parotid space. So there's going to be a pus collection in your parotid space. Pus collection that is going to occur in your parotid space. And deep cervical fascia will be splitting into two layers, superficial layer and deep layer. So it is going to enclose your parotid gland and associated structure. Parotid space lies deep to the superficial fascia. Now, the parotid space is going to include your parotid gland, parotid lymph node, facial nerve, external carotid artery, and retromandibular vein. You're going to have your retromandibular vein. These are the components of your parotid space. These are going to be the components of your parotid space. Now, what happens? Because of the dehydration, particularly post-surgical cases, or infection in the oral cavity, which is going to travel through your Stensen's duct, or multiple small abscess, which is coalescing to form a major abscess in your parotid area. Because of that, what happens? Because of staphylococcal, streptococci, anaerobic organism, there is going to be a swelling, redness, induration, tenderness, and opening of Stensen duct is going to become congested. So all these will be occurring within 5 to 7 days of a surgery. post-surgery 5 to 7 days, all these will be occurring. So this is called as your frenulum, and can you see this is your parotid papillae, where your Stenson's duct is going to come and attach. Okay, how do you diagnose this? By using USG scan, CT scan, or aspiration of pus can be done for culture and sensitivity. So how do you treat it? You're going to correct the dehydration. You're going to improve the oral hygiene. You're going to promote salivary flow, and intravenous antibiotics is going to be given. And surgical drainage under local or general anesthesia is carried out by the preauricular lesions, preauricular incision. With this, we are completing a very important topic, that is going to be your neck abscesses. So I'll go, okay, now as we have completed your neck abscess, now we are going to move towards next important topic, that is going to be your this also we have discussed, I guess, acute pharyngitis, chronic pharyngitis I have discussed, but okay, I'll just give you a brief summary. So remember, you will be having a inflammatory conditions that is occurring in your pharynx. So this we are going to call it as a pharyngitis. So common exam OP la, when you're going to sit, you're going to get this pharyngitis case. Pharyngitis is nothing but your throat pain. So throat pain, they are going to have a pharyngitis. You're going to check. So on inspection, you're going to see your oropharynx. You're going to palpate your oropharynx, and you have to perform a neck inspection. This is the post-nasal examination. When you're going to perform, you will see the nasal septum, superior concha, middle concha, inferior concha, and uvula will be seen like this. So this is your indirect laryngoscopy image, and I hope we have discussed this in the larynx yesterday. So what is the acute pharyngitis? Either it can be a viral cause, or bacterial cause, or fungal cause, or environmental cause, or it may be a local trauma. So chronic pharyngitis now, due to some endogenous or exogenous factors, due to TB, syphilis, leprosy, vaginous granulomatosis, all these conditions will be causing a chronic pharyngitis. You have to take a throat swab, endoscopy has to be performed, and radiological investigations can be done. How do you manage? You're going to manage by treating the underlying cause, symptomatic treatment, and treat the complications. Okay, right? So diphtheria also I have discussed already. This is your Vincent's angina. Can you see? So this is going to be your Vincent's angina, otherwise called as your trench mouth. I discussed this already in the morning session. This is called as your trench mouth. This is going to be due to your Coxsackie virus or enterovirus. Coxsackie and enterovirus leading to Yerpangina. This is going to be a tubercular pharyngitis. This is going to be a tubercular pharyngitis. Okay, and this is syphilis pharyngitis. So syphilis leading to condyloma. Okay, and now coming to this is going to be a keratosis pharyngeus. So orny exacerbation as a result of hypertrophy and keratinization of your epithelium. So with this, we are completing the entire pharynx, guys. So I'll give you a 10 minutes break. We will be back again at 4:40 to start with the nose. Okay, we will come back at 4:40 to start with nose. So these are the important questions. Meanwhile, if you are in the break, if possible, try to copy these important questions. These are the repeated questions asked in your university exam. So these are the essays that are asked in your university exam. So we will be discussing about all these essays in the upcoming session at 10:40. Okay. So if possible, someone can take a screenshot and you can just put it in the group also, so that let others also will be able to copy it down. Okay. Thank you. Come back at 4:40 again. So at 4:40, we are going to start with nose. Okay. If you have any doubt in between in your larynx and your pharynx, you can just put it in the chat box. I will be answering. Okay. Thank you. I'll be waiting for you. At 4:40, we will start back. So anatomy and physiology of nose and paranasal sinuses. So we are going to start with the next section, that is going to be your nose. Okay, so first let's understand about the embryology of nose. So embryology of nose is going to be starting from 4th to 8th week of intrauterine life. There is going to be 5 swelling that is going to be arising. What are those 5 swelling? Can you tell me what are those 5 swelling you're going to have? So you're going to have, number 1, lens plug cord will be there, both the sides, and then you're going to have your nasal plug cord that is going to present both the side, and in the middle you're going to have your maxillary process and your mandibular process. So remember, both your lens plug cord and your nasal plug cord, they are going to be arising from the ectodermal thickening. Okay, so both are going to be arising from the ectodermal thickening, whereas your maxillary process and mandibular process are arising from the first arch. Okay, now what happens slowly is, first there is going to be you're going to have your lens plug cord and you're going to have your nasal plug cord. So around your nasal plug cord, what happens slowly, this nasal plug cord is going to get deeper. So இப்போ என்ன ஆகுதுன்னா இந்த nasal plug cord வந்து slow-ஆ it is going to become deeper. When there is going to be deepening of your nasal plug cord, what happens? There will be a prominence around your plug cord, right? So you have your nasal plug cord around. Whenever this nasal plug cord is going to get down, whenever they are going to become whenever what happens, they are going to become like deeper, they are going to form nasal pit. Around your nasal pit there will be a prominence that is called as your nasal prominence. Clear up? Now this nasal prominence is going to be into two types, okay, into two divisions. One is going to be around the lateral aspect, one is going to be present in the medial aspect. The one that is present in the lateral aspect is called as lateral nasal process, and the one that is present in the medial aspect, you're going to call it as a medial nasal process. So now your nasal prominence is divided into lateral nasal process and your medial nasal process. Now slowly what happens is both your nasal process are going to get fused together. So because of this, what happens? The medial prominence or your medial nasal process of both sides of your nasal plug cord, nasal pit are going to get fused together. Now you have a lateral aspect, and two medial nasal process, and in center you're going to have your nasal pit. In center, you're going to have your nasal pit. So this nasal pit, so can you see here now you have two openings, isn't it? Now you're going to just visualize you have two openings in your nose, right? These two openings are your two nasal pit. Okay, you have two nasal pit, and around it you're going to have your lateral nasal process. In the center, you have the fusion of the two medial nasal process. Clear? Now this area. Now what happens slowly, you have something called as a mandibular process and maxillary process, isn't it? So I told you here you're going to have your maxillary process and here you're going to have mandibular process. Now what happens is slowly your maxillary process as well as your mandibular process is going to come. It is going to slowly gets attached. So this is going to be your maxillary process. Now your maxillary process and your lateral and medial nasal process, they are going to get fused together at the center, and this area is called as your philtrum. So the mustache area is there, right? That mustache area is formed by the fusion of lateral and medial nasal process along with your maxillary process that is coming from both the sides. So this area is called as your philtrum area. Now you have a philtrum area. Now what happens? You are going to see one important condition that is called as conal atresia. What is conal atresia? During the development of primitive nasopharynx, this is going to be separated from your primitive oropharynx. So you're going to have a primitive nasopharynx and you're going to have primitive oropharynx. This is going to be your primitive nasopharynx and you're going to have your primitive oropharynx. Between your primitive nasopharynx, this is your nasopharynx and there's going to be a oropharynx. Between them, you're going to have a membrane. That membrane is called as oronasal membrane or bucconasal membrane. Now you have a bucconasal membrane. But what happens is, once there is going to be a development of your palate, okay, once there is going to be development of palate, this bucconasal membrane will be starting to disappear. Okay, this will be starting to disappear. If at all, if this bucconasal membrane is going to get persisting, if your bucconasal membrane is persisting, that leads to communication between your incomplete communication between your nasopharynx and oropharynx. This condition is called as conal atresia. Persistence of bucconasal membrane is called as conal atresia. Why this occurs? If the mother is consuming a hyperthyroidism tablet like methimazole, carbimazole. So because of the hyperthyroid woman consuming methimazole, carbimazole, they are going to have this conal atresia. Conal atresia can be unilateral or bilateral in the ratio of 2:1. It may be mixed, bony, as well as membranous or pure bony. Okay, so unilateral conal atresia is asymptomatic. Bilateral complete conal atresia may be life-threatening and the child is born with respiratory distress. In such a child, nasogastric tube does not come out into your oropharynx. So if you're going to put you all would have seen, right? If you're going to go to your casualty, so casualty medical officer will be there, CMO will be there. If you're going to see some poisoning case, what they will put? They will be putting a nasogastric tube or your Ryle's tube. While putting a Ryle's tube, they will be putting from your nose, nasal cavity into your oropharynx. So அந்த மாதிரி உங்களுக்கு வந்து பாஸ் ஆகாது. எதுல conal atresia. Why? Because there is a persistence of your bucconasal membrane. So this bucconasal membrane persistent will be leading to respiratory distress. So main this is going to lead to respiratory distress, especially when the baby is crying. What happens is the cyanosis will be decreased. When the baby is crying, the cyanosis will be decreasing. So child is normal while crying, whereas the patient will be having a cyanosis and breathlessness when they are quiet. Cry பண்ணும்போது cyanosis கம்மி ஆகும். Whereas if the patient is going to be quiet, there is going to be a cyanosis will be increased. For immediate management of such a patient, what you are going to do, you are going to put a transnasal endoscopic excision. Transnasal endoscopic excision at 1.5 years. Post-surgery, mitomycin C has to be given. So this is called as your McGovern's technique, but this cannot be the immediate management because it is going to be occurring at 1.5 years. So what will be your immediate management? So for immediate management, you're going to go for any idea? White bore nipple. So you're going to give white bore nipple is inserted in the mouth of the patient, mouth of the infant, so that your mouth will be actively kept open and the child can respire. So that is going to be the immediate management. And finally, you can go for a transendoscopic excision at 1.5 years. Okay. Now you can also go for a mitomycin C. Now coming to the conal atresia. Conal atresia can be associated with a syndrome called as charge syndrome. What is charge syndrome? C stands for coloboma of eye. H stands for heart abnormality. A stands for atresia of nasal cona. And R stands for retarded growth and development. G stands for genital malformation. And E stands for ear malformation or deafness. Okay, now coming to the investigation. What you are going to perform here? What is going to be your investigation of choice here? Investigation of choice is going to be, any idea? What will be an investigation of choice for your Chart syndrome? You are going to go for a CT scan. So you're going to go for CT scan to confirm. And what is going to be a management? You're going to go for your McGovern technique. McGovern technique followed by your mitomycin C post-surgical. Why do you give mitomycin C? Any idea? Why do you give mitomycin C for this patient? Mitomycin C for this patient. Why do you give mitomycin C for this patient? Any idea? You're going to give mitomycin C post-surgery because you need to reduce the chances of restenosis. You have to reduce the chances of restenosis. Clear, right? Yes. Now moving on towards the next important condition that is called as nasolabial cyst. So what happens in your nasolabial cyst? It is a epithelial inclusion cyst which is present extraosseous, that is outside your maxillary bone, and they are located in the region of nasolabial fold. So you have nasolabial fold, right? So this is going to be your nasolabial fold. So in the nasolabial fold, you're going to have the epithelium entrapped. Okay, wow. So this is going to be either the entrapment of epithelium, or sometimes it can be sometimes it can be what? Sometimes it can be a remnant of your nasolacrimal duct. Sometimes it can be a remnant of nasolacrimal duct. Since nasolabial cyst is not odontogenic origin, it is otherwise called as non-odontogenic cyst. They are present since birth, but comes into notice only after they get enlarged or they get infected. The presentation is usually late in nature. So they are unilateral and present as a swelling in the region. So they are going to be present as a unilateral swelling in the region, and management is going to be sublabial approach you are going to do. Next important question is going to be from your embryology. You will be asked is your encephalocele. What is encephalocele? From the name itself, you are going to have en, brain, cephalocele. From your brain, your cerebri is going to get herniated outside your cavity into the nasolabial folds. That is called as your encephalocele. So it is a congenital condition where you're going to have a midline defect in the base of the skull, leading to herniation of intracranial tissues like meninges, or sometime along with brain. If only meninges, you're going to call it as meningocele. If it is going to be along with your brain, it is going to call it as meningoencephalocele. Okay, so the patient will be having a frontal encephalocele, and this frontal encephalocele, if you are going to see, they are going to be having a subcutaneous trans-illuminating mass at the root of the nose near your glabella. There will be a cystic polypoidal mass inside your nasal cavity, and CSF rhinorrhea will be present, which is going to cause recurrent meningitis. This mass will be increasing when the child is going to cry or cough. Okay, so this mass is going to increase whenever the child is going to cry or whenever child is going to get any cough. So that is called as your positive Furstenberg test. That is called as positive Furstenberg test. Furstenberg's test. Positive Furstenberg's test. So that is going to be when the mass increases when the child cries or cough. Therefore, a small child presenting with a nasal polypoid mass should be evaluated by CT or MRI scan, for it can be encephalocele. Here, CT provides the bony details and soft tissue appears better on MRI. Therefore, both of them are complementary to each other and thus helpful during the reconstruction surgery. Remember, biopsy is contraindicated. So what will be your treatment of choice for your encephalocele? The treatment of choice is going to be restoring the functional brain tissues in the cranial cavity. Finally, you're going to have your nasal glioma. As the term suggests, glioma means you all will be thinking like any brain tumor. But this is not a tumor. It is similar to your encephalocele, but here intracranial connections are obliterated. Here there is no connection. Intracranial connection is obliterated. So thus it is going to be present during the infancy as an external nasal mass along with the nasal dorsum or internal nasal mass causing obstruction. So the patient is going to have a firm, the patient is going to have a non-compressible, there is going to be a non-pulsatile, non-pulsatile. Then there is going to be a Furstenberg's test. Furstenberg's test will be negative. So that is important. It is going to be positive in encephalocele, whereas it is going to be negative in your nasal glioma. Your management is going to be a MRI. MRI is going to be the best investigation to manage, to differentiate the glioma and your nasal encephalocele. You can also go for CT scan to check on the bony details. And the management is going to be your surgical excision. So I will be completing the anatomy of nose and I'll give you a break for 45 minutes. You can go, you can take rest and come back. Afterwards, we will discuss about the nose soda features, because if I'm going to continuously load you with information, it will be like again a headache for you all. So that is why I'm just giving an adequate break in between. Okay. So now let's start with your nose. So the nose is divided into external nose and internal nose. Your external nose is going to be osteocartilaginous framework. Okay, it is going to be osteocartilaginous framework. You're going to have your upper 1/3, which is bony, and you're going to have lower 2/3, which is going to be cartilaginous. You all know that you have a frontonasal process, maxillary process, medial, lateral nasal process, and mandibular process. From each and every process, there is going to be some structures that are going to be formed. So that is what it is depicted in this table. Now, the upper 1/3 of the external nose is formed by two nasal bones. So the upper 1/3 of the external nose is formed by the two nasal bones, and the lateral to the nasal bone, you're going to have your frontal process. Lateral to your nasal bone, you're going to have your frontal process of maxilla. You're going to have frontal process of maxilla. If you want to draw and show, see here. So this is going to be your nose. If you're going to see, you're going to have something like this. Okay, you're going to have something like this. This is going to be your nasal bone. This is going to be your nasal bone. So below your nasal bone, you're going to have your cartilage. Below your nasal bone, you're going to have a cartilage. So below your nasal bone, you're going to have a cartilage like this. Just hold on. And below that, you're going to have your like this. So this is going to be your lime. This is going to be called as your, you're going to have something like this. And then you're going to have something like this. Then you're going to have adjacent part. So this is going to be your orbit of the adjacent area. So there's going to be orbit of your adjacent area. Okay. So then you're going to have your next one. Okay. So this is going to be your nasal cavity. So you're going to have your nasal cavity like this. Okay, this is going to be your nose. So this is going to be your nasal opening, and here you're going to have your lip. Okay, so if you're going to see, this is going to be your upper lateral cartilage. Upper lateral cartilage. This is called as upper lateral cartilage. This is going to be your nasal bone, and just adjacent to your nasal bone, you're going to have your frontal process of maxilla. You're going to have. Here you're going to have your sesamoid cartilage. This is called as your sesamoid cartilage. Sesamoid cartilage you're going to have, sesamoid cartilage you're going to have, and this is called as your lower lateral cartilage, lower lateral cartilage, and this one you're going to call it as a lateral crus, lateral crus. So this is what which is going to make up your external bony framework of your nose. Clear, right? External bony framework of your nose. The intersection between the two nasal bones. Can you see here? There is an intersection that is going to present between your two nasal bones. Okay, so this is going to be a nasal bone. Means what happens? You're going to have another nasal bone like this. So this is also going to be a nasal bone. So between the two parts, left and right nasal bone, between that you're going to have a line, right? This line is called as your nasion. This line is called as your nasion, and the line that is going to be the junction of your nasal bone with upper lateral cartilage. This line, you're going to call it as a rhinion. This line, you're going to call it as rhinion. You're going to have your nasion and you're going to have your rhinion. Clear? Then coming to the cartilaginous lower two-third of external nose. Now coming to the lower two-third of external nose, you're going to have your upper lateral cartilage and your lower lateral cartilage. This is going to be your upper lateral cartilage, and then you're going to have your lower lateral cartilage. This is going to be your lower lateral cartilage. Then you're going to have your sesamoid cartilage. Then you're going to have your sesamoid cartilage. Then you're going to have your sesamoid cartilage. And then you're going to have your alar cartilage. Then you're going to have your alar cartilage. Then you're going to have unpaired cartilage. What are those unpaired cartilage? Just if you're going to remove this upper lateral and if you're going to remove this lower lateral, in between. So in between the two sides, that is going, if you're going to just put your finger inside your nasal cavity, and if you're going to see, you will be having some straight cartilage that is present between the two nasal opening, right? That is called as your unpaired cartilage. That is called as your quadrilateral cartilage. This quadrilateral septal cartilage is the one that is going to separate your both sides of your nasal valve. Okay, both sides of your nasal valve. That you're going to call it as a septum. Okay, now if you're going to look into in this aspect, if I'm going to look into this aspect, I'll just draw you and show you guys. So if you're going to look into this aspect, so this is going to be my nose. Okay, this is going to be my nasal opening. This is going to be my nasal opening. Then I'm going to have something like this, and I'm going to have like this. So here I'm going to have the inferior turbinate. So first, I'm going to have a septum like this. This is called as your septum. Okay, and here you're going to have your lateral nasal wall. You're going to have your lateral nasal wall. Okay, so here you're going to have your inferior turbinate. Here you're going to have your inferior turbinate is going to be present, and this is going to be your septum. So this is going to be the internasal valve region cross-sectional view. Okay, clear, right? Now we are going to move towards the internal nose. Now, after completing the external nose, skin and other things, I'm just moving into the internal nose. See, this is going to be your alar cartilage, this is your septum, this is your sesamoid bone, nasal, frontal process of maxilla, and your frontal point. Okay, I hope I have just showed my artistic skills and I have helped you out. Okay, now I am going to move towards the next one. That is going to be my internal nose. So what I will do is, internal nose is an important essay question. Lateral wall of nose is going to be an important question. So I will be starting at around exactly around 6 p.m. So at 6 p.m. we will start with the lateral wall of nose, because I want to give at least a 1 hour break in between, so that you will all get refreshed and come back instead of 10 minutes break. So I hope you all understood the external framework and how this nose is formed, right? So after 6 p.m., at 6 p.m., we will again start with, and we will continue with the entire disease of nasal septum, because now how I will be taking it, I'll be starting with your nasal septum, then I will go for your disease. So I'll be talking about your blood supply. I will go to the epistaxis. Then I'll talk about your lateral wall. I'll go for your rhinitis. So like that, I'll be like mixing and taking, so that I want you all to take adequate rest. Come back at 6 o'clock. At 6, I will be discussing about. I'll be starting with my discussion in the nose. So you can just come back at 6 o'clock. Okay. Thank you. Let's start with the lateral wall of nose. Lateral wall of nose is a essay question that is most commonly asked in the exam from anatomy point of view. So how to write the question if you are going to get the lateral wall of nose as a essay? Okay, remember, lateral wall of the nose. It is you're going to start with the introduction. You're going to write the relationship. Then you're going to start with the blood supply, nerve supply, and lymphatic drainage. blood supply, nerve supply, and you're going to talk about the lymphatic drainage. Okay. In the lateral wall of the nose, you're going to have three bones which are going to be projecting. So that is called as concha or turbinate. If you're going to see, there are few bones that is going to be projecting out. That is called as concha, or we are going to call it as turbinate. This turbinate increase the surface area of your nasal mucosa for better humidification and temperature regulation. So you're going to have three turbinates basically. What are those three turbinates? They are going to be called as superior turbinate, then you're going to have middle turbinate, then you're going to have inferior turbinate. Rarely, above your superior turbinate, you will be having a fourth turbinate that is called as your supreme turbinate. Okay, but rarely you can get the supreme turbinate, but basically you're going to have only three turbinates. Okay, so the turbinates are going to be changes in the size, and they will be helpful for the thick mucous membrane formation, and there may be hypertrophy of these turbinates. There can be a atrophy of this turbinate. So thus those important things we will be seeing it later on. Now, when you're going to enter into your nose, okay, this is your septum, and you're going to have the first one that is going to be your inferior turbinate. The largest turbinate is going to be your inferior turbinate, which is going to occupy almost whole of your lateral wall from your anterior end to your posterior end. And after that, you're going to have the second one that is going to be your middle turbinate. So second one is going to be your middle turbinate. First is going to be your inferior turbinate, then you're going to have your middle turbinate. Middle turbinate almost occupies the posterior half of your lateral wall, followed by your superior turbinate, which is going to occupy the posterior 1/3 of the turbinates. Okay, the superior and middle turbinates are going to be part of your ethmoid bone. Remember, your superior and middle turbinate, they are going to be part of your ethmoid bone, whereas your inferior turbinate, it is going to be a separate bone. It is going to be a separate bone that is going to be attached to it. Okay, so if you're going to see this picture, this is going to be your superior turbinate, this is going to be your middle turbinate, and you're going to have your inferior turbinate. I have just cut down the bone. That's why you are not able to visualize it. Okay, and this is going to be your nasal cavity. This is going to be, can you tell me what is this? Can you tell me what is this? A? Can anyone put in the chat box what is this? A? This is going to be your frontal sinus. It is going to be your frontal sinus. Then this is going to be your sphenoid sinus. This is going to be your sphenoid sinus. Okay, some anatomical pictures you should never forget, you should have in your mind. And this area is there, right? So this is called as your cone. Okay, you're going to call this as cone. And this is going to be your adenoid pad. This is going to be your adenoid pad, where you will be having your adenoid tonsil. Okay, wow. And then this is going to be your nasopharynx. This is going to be your nasopharynx, which we discussed already under the heading of pharynx. And this is going to be your eustachian tube. This is going to be your eustachian tube. And this is going to be your fossa of Rosenmuller. This is going to be your fossa of Rosenmuller. Rosenmuller. And this is going to be your nasal vestibule. This is going to be your nasal vestibule. Okay, nasal vestibule. Clear, right? Now moving on to talk about your middle meatus. Remember, middle meatus, if you're going to see, they are clinically and surgically important because they are going to receive your maxillary, frontal, and ethmoidal sinus drainage. Okay, frontal, it is going to receive maxillary, and it is going to receive your ethmoidal sinus drainage. Okay, middle meatus is separately asked as a short note, guys. Middle meatus is separately asked as short note. So remember, so bulla ethmoidalis is a bulge formed by the anterior ethmoid, your middle ethmoid air cells. And then you're going to have a small opening between your bulla ethmoidalis and your lateral wall that is called as hiatus semilunaris. So through your hiatus semilunaris, if you're going to enter inside, there will be a small area where it is good, there will be a small projection which is going to act like a door for your maxillary sinus. That door is called as your infundibulum. Infundibulum is a small space. It is going to be the way to go into your maxillary sinus. Then you have your uncinate process. Then you have frontal sinus, anterior ethmoidal sinus. Then you have maxillary sinus. And these area mostly you're going to go through your fes. That is going to be your, what does FES stands for, anyone? something endoscopic procedure. Can you just put in the chat box what is the full form of your FIS? What is the full form of your FIS? Functional endoscopic sinus surgery. Okay, so you have to go for a functional endoscopic sinus surgery. Now, if you're going to go enter into it, so this is going to be your superior. First, you have your inferior turbinate. So through your inferior, if you're going to go through, you're going to have your middle turbinate. So then this is going to be your bulla ethmoidalis. This is going to be a bulla ethmoidalis. This is going to be your middle meatus. This is going to be a middle turbinate. And between the turbinate, if you're going to go enter, you can see actually a small opening. So this area is called as hiatus semilunaris. When you're going to enter into hiatus semilunaris, you can see a small opening here. This is called as your infundibulum. Through infundibulum, if you're going to go further, you will be reaching your maxillary sinus. So this is your osteomeatal complex. Again, I'm just showing you one. Again, I'm just showing you one more image. There's going to be your uncinate process. This is going to be your middle turbinate. This is going to be a middle turbinate. This is going to be your inferior turbinate, and this is going to be a frontal septum. Okay, so this is going to be a frontal sinus. Frontal sinus. When you're going to enter through here, so this is going to be your hiatus semilunaris. This is going to be your hiatus semilunaris. Through this, when you're going to enter, you will be entering the sinus. But afterwards, again, you have another opening that is going to be your infundibulum. Through infundibulum, you can reach your maxillary sinus. This entire thing is called as your osteomeatal complex. You're going to call this as osteomeatal complex. Okay, osteomeatal complex. They are going to be the narrow cleft between your uncinate and your bulla. Between your uncinate process and your bulla, you're going to have your, this is going to be a bulla ethmoidalis. There's going to be a bulla ethmoidalis. Between your uncinate and your bulla, you're going to have a narrow cleft that is called as your osteomeatal complex. Before moving into all these important points of osteomeatal complex, I like to discuss about the medial, lateral, and your superior relationship of your entire lateral wall of your nose. So when I'm going to talk about your lateral wall of your nose, listen carefully. So you're going to talk about superior. Let's come back to this image. So let's come back to this image. So in this image, we are going to check. So in this image, what you're going to see is, now you have to know what are the things that are present laterally. In the lateral wall, if you're going to see, you're going to have your superior middle turbinate, and you have something called as lamina papriciae. What is this lamina papriciae? It is a bony projection which is present in the superior aspect. It is a bony, can you see here? So when you're going to remove the skin layer, if you're going to see, there is going to be orbit, right? This orbit is going to be separated from your lateral wall of your nasal cavity by a thin paper-like bone. So that is called as your lamina papriciae. So hence, you're going to call this as a weakest bone. You're going to call this as a weakest bone. Among everything, which is going to be the weakest bone, that is going to be your lamina papriciae. So that is going to be your lamina papriciae. Okay, so then after talking about your lamina papriciae, next we are going to go for uncinate process. What is this uncinate process, guys? Listen carefully. Uncinate process is nothing but, okay, so this is going to be, if you're going to see, you will be having, right? So in this picture, I guess it was very clear. So this is your uncinate process. This uncinate process is a sickle-shaped bone. Okay, it forms the lower boundary of your hiatus semilunaris. So this is going to be, this area is called as your hiatus semilunaris. This is called as your hiatus semilunaris. This hiatus semilunaris, or the lower border is going to be, lower boundary is going to be by your uncinate process. The lateral wall of your ethmoid bone is actually pneumatized. So you're going to have various small air cells. So among these air cells, you divide it into anterior ethmoidal air cells and posterior ethmoidal air cells. So these are the things that are present over the lateral aspect. This is going to be your lamina papriciae, lamina papriciae, papriciae. Okay, papriciae, and you're going to have your uncinate process. Now let's see medial aspect. In the medial aspect, you're going to have your perpendicular plate of ethmoid bone. It is going to form the bony nasal septum. This is going to be your perpendicular plate of ethmoid bone. Perpendicular plate of ethmoid bone. They are going to be forming your medial septum. Okay, it's going to form your septum. Then superiorly, if you're going to see here, you're going to have your cribriform plates. Here you are going to have your cribriform plate, and it is divided into two parts, medial and lateral lamellae. Then you have your crista galli, which is a medial ridge of your bone. that projects from your cerebriform plate of your ethmoid bone. Then lateral to your turbinate. Between your turbinate, you're going to have three important structures. That is going to be your superior meatus, middle meatus, and inferior meatus. So this is going to be your inferior meatus. So just lateral to your inferior turbinate, you're going to have inferior meatus. This inferior turbinate is going to be the largest turbinate. So this meatus is going to be giving rise to the opening of inferior turbinate is going to give rise to opening of your nasolacrimal duct. Nasolacrimal duct. Okay, nasolacrimal duct, and the nasolacrimal duct begins at the lower end of your lacrimal sac. They are going to run downwards. They are going to run downwards, backwards, and lateral. They are going to run downwards, backwards, and lateral. Remember, you have two NLD. So you have two nasolacrimal duct. Remember, like double nasolacrimal duct, double nasolacrimal duct. So D stands for downward, DO stands for downward, and then you're going to have your BL stands for your backward and lateral. Downward, backward, and lateral. This is how your nasolacrimal duct is going to go. This is how your nasolacrimal duct is going to go. Now, after completing that, okay, where is they going to? So they are going to just open up in the anterior 1/3 and posterior 2/3 of the inferior turbinate. They are going to open in the anterior 1/3 and posterior 2/3 of your inferior turbinate. Now, after traveling into the down and backward and lateral, it is going to open in the inferior turbinate. But you need some valve, isn't it? Inferior turbinate, like you need some valve, isn't it? That valve is called as valve of Asner. Valve of Asner. That is called as your valve of Asner. Clear? Now coming towards your middle meatus. Middle meatus is going to be the center part. So this middle meatus is the opening of your anterior group of sinuses, like your maxillary sinus. You're going to have ethmoidal sinus. You're going to have frontal sinus. All three are going to drain into your middle meatus. The frontal sinus opens the antero-superior part of your middle meatus. This is your anterior superior part of middle meatus. So it is going to open somewhere around your antero-superior part of middle meatus. Then what happens is you are going to have the anterior ethmoid. The anterior ethmoid is going to open on the surface of bulla ethmoidalis. So there's going to be an anterior ethmoid. There's going to be an anterior ethmoid. In that open agumbode, it is going to actually open into the bulla ethmoidalis. Then you're going to have the third one, that is going to be a bulla ethmoidalis. This bulla ethmoidalis is going to be the most prominent anterior ethmoidal sinus cells. So you have various anterior ethmoidal sinus cells. Among various cells, one which is prominent is called as your bulla ethmoidalis. So this is nothing but your bulla ethmoidalis. This is going to be a bulla ethmoidalis. So this bulla ethmoidalis is also going to open just below your bulla ethmoidalis. You are going to have a sickle-shaped bone called as uncinate process. In between the bulla above and uncinate below, you are going to have your semilunar opening into your nasal cavity. That is called as your hiatus semilunaris. So once we enter into hiatus semilunaris, we enter into a three-dimensional area. This three-dimensional area is called as your infundibulum. So through infundibulum, you're going to go into your maxillary sinus. All these structures of your middle meatus, together you're going to call it as osteomeatal complex, otherwise called as, you can otherwise call it as Picardal circle. It's otherwise called as Picardal circle. Okay, Picardal circle. It is known as a complex as all the three sinuses are opening together into a common area. So any sinusitis of one sinus in this area will be spreading to the other sinus also. Also, any deformity by your middle turbinate, any deformity that is going to be occurring in your middle turbinate. Just hold on, guys. Just hold on. I am getting bulum. We are going to call it as a Picardal circle. It is known as a complex as all these three sinuses are going to open into one area. Any deformity in your middle turbinate, like your concha bullosa, paradoxically curved middle turbinate. So all this will be leading to all the three sinusitis. It can be maxillary sinusitis predisposing to your frontal sinusitis and ethmoidal sinusitis. Okay, wow. So that's what I want you all to remember. So the middle turbinate is usually not pneumatized. The pneumatization of your middle turbinate, you're going to call it as concha bullosa. The bullosa turbinate blocks the drainage of middle meatus. Now remember, whenever I'm going to have this middle meatus, when I'm going to have the pneumatization like this, if I'm going to have a pneumatization like this, what happens? It is going to block the airway. So because it is going to block the airway, what happens? They are going to cause sinusitis. So middle turbinate is usually concave towards your middle meatus. So a paradoxically curved middle meatus turbinate becomes convex facing the meatus, leading to interference with the drainage of not just your maxillary sinus. It is going to intervene with your ethmoidal sinus as well as your frontal sinus. Therefore, we will actually never, try to block this area. So pneumatization should not be happening here. Okay, next is a agar nasi. Remember, agar nasi is a anterior most anterior cell. The prominent anterior cell is going to be your bulla ethmoidalis, whereas the anterior most part of your anterior ethmoidal cell, it is going to be agar nasi. Almost all individuals just anterior to the anterior free margin of middle turbinate, you are going to have this agar nasi. Then comes your superior turbinate. In your superior turbinate, you're going to have a drainage of posterior ethmoidal sinus. So it lies lateral to your superior turbinate. Here there is going to be a posterior ethmoidal sinus that is going to open. And this is above the superior turbinate. Now coming to this picture. So just going to the next picture. So you're going to have your opening through which you're going to have your posterior ethmoidal sinus. But apart from this posterior ethmoidal sinus that is going to drain, you have something called as your sphenoid sinus. So there is a recess. Can you see it? Can you see here? This is going to be your sphenoethmoidal recess. So in the sphenoethmoidal recess, you're going to have opening of your sphenoid sinus. Clear? Now coming to the important structure in the nasopharynx in relationship to your lateral wall of the nose. You all know that you're going to have the opening of eustachian tube. So behind the inferior turbinate, behind your inferior turbinate, okay, then you're going to have sphenopalatine foramen. Then you're going to have this one. Can you see here? This is called as sphenopalatine foramen. So it is going to be about 1 centimeter posterior and little inferior to the posterior end of middle turbinate. And it is the opening of sphenopalatine foramen. Okay, wow. So foramen, sphenopalatine foramen, what happens is the sphenopalatine ganglion is present. Maxillary artery and maxillary nerves are going to be passing through. So this is going to be your sphenopalatine foramen. So in the sphenopalatine foramen, you're going to have two important structures. Number one, you're going to have your maxillary artery and your maxillary nerve. Okay. And second one is going to be your sphenopalatine ganglion. Sphenopalatine ganglion. Sphenopalatine ganglion is going to be there. Okay. You're going to have sphenopalatine ganglion. Okay. Wow. So that is important. This sphenopalatine fossa lies just posterior to your maxillary antrum. This fossa can be reached by a procedure called as. So if you want to reach this area, you have to go for the procedure called as Caldwell-Lux procedure. Caldwell-Lux procedure. So this Caldwell-Lux procedure or approach, you're going to have your sublabial incision. You're going to perform a sublabial incision and then drilling anterior and posterior wall of maxillary antrum and then drilling anterior and posterior wall of maxillary antrum. Wall of maxillary antrum. Okay, wow. So the boundaries of your sphenopalatine fossa is going to include the boundary of your sphenopalatine fossa. This area, it is going to include anterior wall, posterior wall will be your maxillary antrum. Posteriorly, you're going to have your maxillary antrum and posterior wall of maxillary antrum will be there. Okay, so write it down. Sphenopalatine fossa. I'm just talking about the sphenopalatine fossa. Sphenopalatine fossa. So what is the anatomy of sphenopalatine fossa? Remember, anteriorly you're going to have the posterior wall of maxillary antrum. Posterior wall of maxillary antrum. Then posteriorly you're going to have. So posteriorly we are going to have the pterygoid plate. So posteriorly you're going to have your pterygoid plate. Pterygoid plate is going to be there posteriorly. At the roof of the pterygoid plate in the base of the skull, you're going to have two important foramens. What are the two important foramens? We have foramen rotundum. So what is this foramen rotundum? So through this foramen rotundum, you're going to have your maxillary nerve. You're going to have maxillary nerve that is going to enter into your sphenopalatine fossa. Then comes your foramen that is going to lead into pterygoid canal. Foramen leading to pterygoid canal. Pterygoid canal. So foramen that is going to lead to pterygoid canal through which Vidian nerve is going to enter. So through which what nerve is going to enter? You're going to have your Vidian nerve that is going to enter into the sphenopalatine fossa and they relay in the sphenopalatine ganglion. And next comes your medial most. So medially you're going to have the lateral wall of the nose. Medially you're going to have lateral wall of nose and laterally you're going to have the infratemporal fossa. Infratemporal fossa via your pterygomaxillary fissure. Via your pterygomaxillary fissure. Pterygomaxillary fissure. So then comes your floor. So floor வந்து பாத்தீங்கன்னா it is formed by the plate containing the palatine canal. So floor is going to be formed by the plate containing palatine canal. So you're going to have your palatine canal is going to be there and the roof is going to be formed by the orbit. Roof is going to be formed by the orbit. Now coming to the why we are discussing about the sphenopalatine fossa. Two important reasons. You're going to have the sphenopalatine foramen. This sphenopalatine foramen, through this, you're going to have the main vessel that is going to supply your nose. That is going to be a sphenopalatine artery branch of your maxillary artery. This sphenopalatine artery, okay, enters your nose through this foramen. So this is known as the artery of epistaxis. Why? Because whenever there is a epistaxis, what you can do is you can ligate your sphenopalatine artery by locating at this fossa. If you can locate this fossa, you can easily ligate your sphenopalatine artery. That is the reason. If epistaxis does not get controlled, then maxillary artery can be ligated in the sphenopalatine fossa. So behind your sphenopalatine foramen, you're going to have your sphenopalatine fossa, where you're going to have your maxillary artery. You can just ligate your maxillary artery directly in this particular area. The sphenopalatine foramen is the most common site. Second thing is, this sphenopalatine fossa is going to be the most common site of origin of, can you tell me? The one which we have seen already in nasopharynx. One benign tumor, which is originating from your sphenopalatine fossa or foramen. Can you name it in the chat box? Which one? JNA, very good. So it's going to be a juvenile angiofibroma. Juvenile nasopharyngeal angiofibroma. Excellent. This comes to the end of your importance and all the structures and everything that is going to be related to your lateral wall of the nose. Now we are going to move towards slowly into the medial wall of the nose. Okay, so now we have completed the lateral wall. Now we are going to move towards the medial wall of the nose. So median wall basically consists of septum. It is going to support the dorsum and they divide the nose into two nasal cavities. What they are actually going to do is they are going to divide your nasal cavity into two cavities. The septum has three parts basically: columnar septum, membranous septum. What is this columnar septum? This is formed by the fusion of two medial crurae of your alar cartilage. So between the two medial crurae of your alar cartilage, you're going to have the first one that is going to be a columnar septum. Okay, then you're going to have membranous septum. Membranous septum is going to be just above your columnar septum. Just above your columnar septum, you're going to have membranous septum. Okay, this membranous septum is going to lie above the columnar cartilage, and this area is devoid of any cartilage. Only the skin of both sides are meeting here. So you're going to have the skin of both sides meeting here. And next we are going to move towards the septum proper. What is a septum proper? So above your membranous septum, you're going to have your septal cartilages. Above your membranous septum, you're going to have a septal cartilages. Clear? This septal cartilage above your membranous septum, it is an osteocartilaginous framework. So first you're going to have anterior-inferior, you're going to have your quadrilateral cartilage. You're going to have quadrilateral cartilage. Okay, so why you are naming it so? Because of its quadrilateral shape. The anterior side of this cartilage forms the lower two-thirds of dorsum of external nose. So it is going to form the lower two-thirds of dorsum of external nose. So one has to be very careful while dealing with this septal cartilage, because if it is going to get damaged, it is going to lead to saddling of nose. The postero-superior or postero-inferior and your inferior sides are going to be in contact with your perpendicular plate of ethmoid bone. Can you see here? This is going to be a perpendicular plate of ethmoid bone. So it is going to be in contact with your perpendicular plate of ethmoid bone. Then you're going to have your vomer bone and you're going to have your anterior nasal bone. So this is going to be a nasal spine. This is going to be anterior nasal spine of maxilla respectively. Then superiorly by the perpendicular plate of ethmoid bone and posterior inferiorly you're going to have your vomer bone. This is going to be the septum proper and its relationship. And if you're going to see along these major compartments, some small bones are contributing to the septum. The nasal spine of frontal bone, then you're going to have your nasal spine of frontal bone, then you're going to have your rostrum of sphenoid. This is going to be a rostrum of sphenoid. Can you see it? This is going to be a rostrum of sphenoid, and you're going to have perpendicular critical of rethmoid bone, crest of maxilla, and crest of palatine bone inferiorly. So roof of the nose is formed mainly by the cribriform plate of ethmoid bone, and floor of the nose is the palate formed by the palatine process of maxilla anteriorly and horizontal process of palatine bone posteriorly. Now coming back towards the blood supply. So blood supply of your septum, mainly it is going to be by external carotid artery and your internal carotid artery. Okay, wow. So external carotid artery is going to give you the main blood arterial blood supply. So the area below the upper part of middle turbinate, okay, so mainly supplied by your carotid artery, whereas the area above it is supplied by your internal carotid artery. Let's see one by one. From your external carotid artery, you're going to have maxillary artery and a fascial artery. This maxillary artery give rise to two important arteries. What are they? One is your sphenopalatine artery and other is going to be your greater palatine artery. Sphenopalatine artery, it enters the nose through the same named foramen. That is going to be a sphenopalatine foramen. So this is going to be the main artery that is going to supply your nose. Then comes your greater palatine artery. It supplies the palate, then enters the nose to supply it. Then you're going to have your facial artery. You're going to have septal branch of superior labial artery. So this is going to supply your nose. So what are the three arteries which we have seen from external carotid artery? It's going to be a sphenopalatine artery, greater palatine artery, and superior labial artery. Sphenopalatine, greater palatine, and superior labial artery is going to be the three arteries which you're going to remember. And coming back to the okay, just அடுத்தது வந்து பாத்தீங்கன்னா you're going to coming back to the next one. That is going to be okay, that is going to be your from internal carotid we have two branches, ophthalmic, so anterior ethmoidal artery and posterior ethmoidal artery. So from the internal carotid we have two branches of your ophthalmic artery. So that is going to be anterior ethmoidal and posterior ethmoidal artery. Okay, so anterior ethmoidal artery and posterior ethmoidal artery are given off by the ophthalmic artery in the orbital cavity. Okay, each of these artery then pierces the medial wall of orbit. Each of them, they are going to pierce the medial wall of the orbit through the same named foramen. That is going to be superior orbital foramen. Superior, you're going to have your ophthalmic artery is going to be there. Superior ethmoidal foramen and inferior ethmoidal artery is going to come through your inferior ethmoidal foramen. Whereas your anterior ethmoidal foramen is going to be present. It is going to be lying 24 millimeter posterior to the lacrimal crest. It is going to be 24 millimeter posterior to the lacrimal crest. And your posterior ethmoidal artery comes through the posterior ethmoidal foramen, which is going to be 12 millimeter. Okay, posterior to the anterior ethmoidal foramen. Okay, this posterior ethmoidal artery, it's going to act as a landmark for your optic nerve, which lies 6 millimeter posterior to your posterior ethmoidal foramen. இது எல்லாமே okay, they are going to be part of a Kieselbach's plexus except your posterior ethmoidal foramen. Except your posterior ethmoidal foramen, all others are going to be part of your Kieselbach's plexus, otherwise called as Little's area. Okay. So the components of Kieselbach's plexus are sphenopalatine artery, greater palatine artery, superior labial artery, and septal branches of anterior ethmoidal artery. Little area is the most commonest site of epistaxis in a young, and here epistaxis occurs because of some trauma or nose pricking. Since sphenopalatine is a main artery supplying the nose, you're going to call that sphenopalatine artery as a artery of epistaxis. In the posterior part of the inferior turbinate is another plexus formed by the anastomosis of the posterior nasal branch of sphenopalatine and pharyngeal arterial branches. This is considered as most common site of epistaxis in the elderly person. Posterior part of inferior turbinate, there is another plexus called as Wood's plexus. In the Wood's plexus, you have your sphenopalatine pharyngeal artery branches. Whenever there is going to be any blood pressure, hypertension, excess hypertension crisis, in the நேரத்துல என்ன ஆகும்னா the sphenopalatine artery which is going to form here, they are going to get they are going to get injured, and they are going to cause epistaxis. That is called as your posterior epistaxis. That is most common place in the elderly individual. Epistaxis can also be from the veins, retrocolumnar veins, which is part of its name, runs behind your columella and causes floor of the nose and forms a venous plexus on the lateral wall of the nose. Now coming towards the nerve supply and your venous drainage. Okay, so remember about your venous drainage. So venous drainage, superior part drains into the ophthalmic vein, posterior part drains into your sphenopalatine vein, and your dangerous area of space and the anteroinferior part of the nose, they are going to drain into the deep facial vein, which is going to communicate with the pterygoid plexus of veins and therefore with cavernous sinus and your dural venous sinus. எல்லாத்தோடையும் merge பண்றது யாரு? உங்களோட venous drainage done by your pterygoid plexus. Okay, that is going to be draining into your sphenopalatine vein. Okay, wow. So what happens is you're going to have your sphenopalatine vein. I'll just write it down, don't worry. You're going to have your sphenopalatine vein. This sphenopalatine vein is going to drain into the pterygoid plexus. Pterygoid plexus. This pterygoid plexus have a communication with the cavernous sinus. Cavernous sinus that has communication with the dural venous sinus. That is have communication with the dural venous sinus system. Okay, dural venous system. So the dangerous area of the face and anteroinferior part of the nose that drains into the deep facial vein, which communicates with the pterygoid plexus of vein. Therefore, with the cavernous sinus, and that is the reason why venous drainage here is going to be a potential vehicle for spread of infection intracranially. So that's why you're going to call this area as a dangerous area of space. So, okay, face. Now coming to the nerve supply. The nerve supply of your external nose, it is going to be your ophthalmic division of trigeminal nerve and your maxillary division of trigeminal nerve. Okay, wow. So both are going to be draining. Now coming to the internal nose. Internal nose, you're going to have your olfactory nerve. Okay, that is going to come to your cribriform plate of ethmoid bone. Can you see here? Through your cribriform plate of ethmoid bone, you're going to have your olfactory nerves. Or 12 to 20 olfactory nerve is going to pass and they end as a olfactory bulb. Then rest of the sensory supply of your internal nose is taken care by your V1. What is your V1? V1 is going to be your anterior and posterior ethmoidal nerve. While here it is going to go to your ophthalmic nerve. So then in the part. And below you're going to have this V2. That is going to be your mandibular maxillary nerve. Okay, wow, they are going to be maxillary nerve. And you will have some fusion. In this point, you're going to have a fusion of all the nerves. So example, your Vidian nerve is formed. What is a Vidian nerve? It is formed by the fusion of greater superficial petrosal nerve and deep petrosal nerve. Greater superficial petrosal nerve and your deep petrosal nerve. These two are going to fuse in the cranium to form Vidian nerve, which then exits through the foramen in the base of the skull at the root of your pterygoid plate. In the foramen is going to lead to your pterygoid canal. Adinalda, Vidian nerve is also called as nerve of pterygoid canal. After passing through the pterygoid canal, it is going to enter into your sphenopalatine fossa. So once it enters your sphenopalatine fossa, you're going to have your sphenopalatine ganglion. In the ganglion, there is going to be parasympathetic fibers that is going to be relayed, which is going to give rise to a parasympathetic supply to your nose, nasopharynx, palatine mucosal gland, and your lacrimal gland. Therefore, Vidian nerve is suctioned in your parasympathetic overactivity, which is seen in the vasomotor rhinitis. அதுக்கு தான் நம்ம இவ்வளோ ஸ்டோரி சொல்றோம். Vasomotor rhinitisல நம்ம அதை பிரிச்சிடுவோம். Now coming towards after completing all these things, next we are going to move towards a very important part that is going to be your sinuses. So we are going to go to the anatomy of paranasal sinus. Remember, paranasal sinus பொறுத்தவரைக்கும் there are 4 paranasal sinuses basically. The horizontal attachment of the middle turbinate to the lateral nasal wall is called as ground lamella, or we are going to call it as basal lamella. This divides your paranasal sinus into anterior and posterior group. Anterior group is going to include your maxillary, frontal, and ethmoidal, whereas posterior group is going to include your sphenoid and posterior ethmoidal group. Sphenoid and you're going to have your posterior ethmoidal group. Clear up. So that comes to the end of discussion of your paranasal sinus. Now let's move on to talk about the individual paranasal sinus. The first one is going to be your maxillary antrum. To understand about maxillary antrum, see, listen carefully, see this image. So this is going to be your maxillary sinus is going to be a pyramidal shaped sinus with the apex lying towards the zygomatic bone. The base is going to form the lateral wall of the nose, and the roof forms the floor of the orbit, and it is going to be transversed by infraorbital nerve and vessels. The floor of the maxillary sinus lies 1 centimeter below the level of the floor of nose, and it is going to be related to second premolar and first molar. So this area is going to be related to the second premolar and the first molar. Therefore, while extracting a teeth, this can lead to a oroantral fistula. The maxillary sinus opens into. So where does your maxillary sinus opens into? It is going to open into the it is going to be opening into your infundibulum. So this is going to be an infundibulum. It is going to open into the infundibulum of your middle meatus. Since the osteo of middle meatus is much above the floor of the sinus, drainage becomes anti-gravity, leading to the collection of secretion. And therefore, remember, so most common sinus which can get affected is going to be your maxillary sinus, because it is going to have the relationship anti-gravity. Now, moving on to discuss about your post-ethmoidal sinus. Your ethmoidal sinus, basically, remember, you're going to have multiple air cells. Among them, can you name down which is going to be the anterior most ethmoidal air cells? Which can you name in the chat box, which is the anterior most ethmoidal air cells? Which is called as anterior most ethmoidal air cells. Agar nasi, which is going to be most prominent ethmoidal air cells, which is going to be the most prominent ethmoidal air cells. Can you put in the chat box? Which is going to be the most prominent ethmoidal air cells? Bulla ethmoidalis. Excellent. Bulla ethmoidalis. It's going to be there. Now, anti-ethmoidal cells, you know, two cells, right? And now the third important cells of your anti-ethmoidal cells. So, anti-ethmoidal cell is also present in the floor of the orbit. That is called as alar cells. So, in the floor of the orbit also, you're going to have some cells like this. This is called as your alar cells, HALLER, alar cells, or infraorbital anti-ethmoidal cell. By doing a CT scan, you can see that there will be by doing a CT scan, you can see some alar cells will be visualized by doing a CT scan. Posterior ethmoids are going to open into your superior meatus. One posterior ethmoid cells has been named. So the posterior most part of the posterior ethmoidal cell extending lateral to the sphenoid sinus, you're going to call it as onode cell. Posterior most part of the posterior ethmoidal cell, which is going to project anteriorly into the sphenoid sinus, is called as onode cell. While removing the disease from the onode cells, there are major chances for injury to your optic nerve and internal carotid artery. Now coming to your frontal sinus, it is a superior most placed sinus in the head. So the septa that divides the frontal sinus, paramedian and obliquely placed as a two frontal sinus and are symmetrical. It opens in the middle meatus by frontonasal duct or frontal recess. Now coming to the next one, the last one, which cannot be visualized by the anterior aspect, that is going to be your sphenoid. That is going to be your sphenoid. Can you see here? This is going to be your sphenoid cavity. This is going to be your sphenoid sinus. One minute. Yeah. So you're going to have your sphenoid sinus. This is going to be a sphenoid sinus, and it is going to be located in the sphenoid bone. Like the two frontal sinus, sphenoid sinus also do not have any symmetrical shape. When the sphenoid sinus grows, it begins to pneumatize the body of your sphenoid bone. The pattern of pneumatization of your sphenoid sinus significantly affects the safe access to your pituitary gland in transsphenoidal approach for pituitary adenoma. There are three types of sphenoid sinus pneumatization that can occur. Number one, you're going to call it as conchal, precellular, and postcellular. You can have conchal, precellular, and postcellular. Can I say this is your sphenoid sinus? There's going to be a conchal, there is going to be precellular sinus, and you can have a postcellular sinus or sphenoid sinus. Is my screen visible, guys? Can someone put in the chat box if my screen is visible? I think my screen is not visible, right? Just hold on, just hold on. Yeah. So going to have a conchal type, precellular type, and you have your sphenoid type, otherwise called as postcellular type. Conchal type, you can see that there is no pneumatization and all. So there is a solid black bone, okay, solid block of bone beneath your cella. Then you're going to have your precellular type. So pneumatization does not extend the anterior border of your sella turcica. This is your sella turcica, guys. This is going to be your sella turcica. There's going to be your sella turcica. So just below it, you're going to have your precellular. And this is going to be a postcellular. Your pneumatization is below and posterior to the cella turcica. This is the most common type of sphenoid pneumatization. This is going to be the most common type of sphenoid pneumatization. This is going to be the most common type of sphenoid pneumatization. Clear? So this is all about your sphenoid sinus. The roof of your sphenoid sinus is related to your pituitary gland, and they are going to carry important arteries and nerves like your internal carotid artery, cavernous sinus, cranial nerve 3, 4, and you're going to have your 6, and you're going to have your mandibular nerve and your maxillary nerve. The roof of the sphenoid sinus is related to the pituitary gland. Okay, that you're going to remember. Now, finally, you're going to move towards the this is going to be a sphenoid sinus. How you're going to remember? So there's going to be a pituitary. There's going to be a V3, V2, V1, internal carotid artery, fourth nerve, third nerve. Okay, fourth nerve and third nerve. This is going to be a sixth nerve. Okay. So floor is going to have median nerve, roof is going to have olfactory tract, optic chiasma, frontal bone, and pituitary gland. And laterally, you're going to have your cavernous sinus, and posteriorly, you're going to have your clevius. Okay, now moving on to discuss about, we have already discussed what is dangerous area or space. Then you have to know one important question here. So what are the openings? So we have already discussed where are these openings that are going to be present and everything. Now moving on to talk about the physiology of your nose and paranasal sinus. Now we are going to move towards the physiology of paranasal sinus. So physiology, if you're going to see, number one, you have to know the olfaction. It is going to help in the passage of respiration. It is going to help in the filtration. It is going to help in the temperature regulation. It is going to help in vocal resonance, nasal reflex, and etc. So you have to know an important question called as what is Cotil's line. Cotil's line is a line, okay, that is drawn between the spine of your frontal bone. That is drawn between the spine of your frontal bone and the spine of your maxillary crest. Spine of your frontal bone and spine of your maxillary crest. So in this, I want to add a few more important things. So மீதி எல்லாமே உங்க புக்லயே இருக்கும், அதெல்லாம் நீங்க படிச்சிருவீங்க. ஒரு விஷயம் நீங்க படிக்காம போறது கொஸ்டின்ல இந்த வாட்டி கேட்க சான்ஸ் இருக்கிறது வந்து rhinomanometry. So what is this rhinomanometry? It is a diagnostic test. It's a diagnostic test to evaluate the respiratory function of nose. So what are the uses of it? So let me tell you one by one. The first one, it is a measure nasal airway resistance. It is going to measure nasal airway resistance. So by measuring the pressure and flow during the normal inspiration. It is also helpful for differentiating between the anatomical and mucosal abnormality by actually performing tests with decongestant. So test with decongestant. So you're going to perform by decongestant. Okay, wow. So it can also be used to check the impact of other treatments like your nasal steroid spray and in conditions causing nasal blockage. So what are the instruments? Can you tell me what are the instruments you use to see the nose, to examine the nose in your OPD? Can you put in the chat box? What are the instruments you're going to use to examine your nose in the OPD? So what are the two instruments you're going to use? Come on, you all know this. What are the two instruments you're going to use in OPD? Anterior and posterior rhinoscopy. So you will be using Tuticum speculum, excellent. Then you use, that is going to be your anterior rhinoscopy. Tuticum speculum is going to be your anterior rhinoscopy. It is going to be helpful for visualizing your anterior cavity. Then comes your posterior rhinoscopy. This is done to examine the posterior nasal space and your nasopharynx. So what are the structures that are visualized in your posterior rhinoscopy? You can see adenoid, you can see Eustachian tube, you can see corona. Okay, wow. So then you can go for your nasal endoscopy. Nasal endoscopy is performed with two important instruments. You're going to have 0 degree and you're going to have your 30-degree rigid endoscope. It is going to consist of 3 important phases. First one is called as your first pass. What is first pass? It is your endoscope is going to be passed along the floor of the nasal cavity between your inferior turbinate and your septum. The scope is then advanced into your nasopharynx. Then you're going to have your second pass. So from your nasopharynx, it is going to go to the superior turbinate and its meatus and sphenoethmoidal recess. Then third pass is going to be your middle meatus is going to be examined. Middle meatus is going to be examined. Okay, so with this, you are completing the anatomy of your nose. Now moving on to talk about the this is going to be a lateral wall of the nose. So this is how you have to write your essay question. I'll just share you. So whatever I spoke to you, whatever topics I have just discussed with you, I have just written in the essay format. Okay, I'll just send you this file. Okay, don't worry. Now moving on to talk about the disease of your external nose. So what is going to be the diseases that can occur? Number one, fracture of nasal bone, maybe due to the fall or punch by your friend or punched by your ex-girlfriend or ex-boyfriend. So they are going to punch, and that is going to cause bones of your facial-maxillary region is going to get broken. So what are happening? So because this area is going to be richly supplied by your blood vessels, you can have epistaxis. You can have nasal obstruction and cosmetic deformity can occur. So what is this bone and what is this bone? Can you name? What is this 1 and what is this 2? Can you name the bones here? What is your 1 and what is this 2? Can you name the bone here? Come on, guys. What is your 1 and what is your 2? What is that 1 and what is this 2? 1 is going to be your, anyone? What is 1 and what is going to be your 2? 1 is a nasal bone, excellent. What is 2? What is 2? 2 is going to be your upper lateral cartilage. It is going to be your upper lateral cartilage. Okay, now moving on to talk about the investigation. You perform a radiography, treatment, correct it immediately in the early case. After few days, na reduction by LA or GA. So late case, na you have to do rhinoseptoplasty. Then comes the next one, dermatitis of nose. It can be either eczematous dermatitis or seborrheic dermatitis. External nose and vestibule is the area where you're going to have dermatitis, and treatment is going to be cleanliness, and you have to go give a hydrocortisone ointment. Then comes your lupus erythematosus. What is lupus erythematosus? So this is going to be your SLE. In SLE, you're going to have your lupus erythematosus. Now, a favorite question which I always ask, be it a second year or be it a final year or be it a pre-final year, can you tell me what are the drugs that leads to SLE? Drugs that lead to SLE. Any idea? Any idea what are the drugs that can lead to SLE? Always remember this mnemonic ship drug. So sulfur drugs, H stands for hydralazine and I stands for isoniazid and P stands for procainamide. So these are the 4 drugs that are going to actually cause SLE, and they are going to be a butterfly-like distribution. Then you have your erysipelas. So it is going to be acute streptococcal inflammation of your skin and subcutaneous tissue of your nose. So there will be redness, local pain, headache, fever, malaise, and treatment is going to be your penicillin G. Okay, then comes your acne rosacea. So it's going to be present in the woman at the menopause. Clinical features, enlarged superficial blood vessels in the skin, nose, and the cheek, and your secondary hypertrophy of sebaceous gland. Okay, then comes your herpes simplex. Herpes simplex is going to be a virus. Clinical features, vesicular eruption, attack of cold, acute debilitating illness. Treatment is going to be no specific treatment. Local application of neomycin or polymyxins with hydrocortisone. Then comes your herpes zoster. Okay, then you're going to have cellulitis. Remember, cellulitis is very important. Nasal skin invaded by your streptococci or staphylococci. Treatment is systemic antibacterial, hot fermentation, and analgesia. Common உங்களுக்கு கேட்கிற question வந்து rhinophyma or potato nose. So we are going to talk about your that all now. So what is a saddle nose? Depressed nasal dorsum involving bony cartilaginous compartment of your nasal dorsum. So something like this. This is called as your saddle nose. This is your supratip depression, humped nose, and a normal nose. So where will you have this? Where will you have this saddle nose? So in the nasal trauma. Okay, removal of septum in the submucous resection, leprosy, tuberculosis, syphilis. And treatment is going to be augmentation rhinoplasty, and you can keep an implantation of silicone of Teflon. And now coming to the next one, what is hump nose? It is going to involve bone and cartilage, or it can involve both. What is the treatment? Rhinoplasty, removal of hump and narrowing of lateral wall by your osteotomies. Now coming to the crooked or deviated nose. Crooked nose, frontonasal angle to the tip, curved as C or S-shaped manner. Deviated nose, na midline is straight but deviated one side. That is called as your deviated nose. Pharyngeal is a 2-mark question. Usually they ask in your exam. Now they can ask a part of your 5-mark also. So staphylococcal aureus infection of the air follicles in the nasal vestibule. So they can be due to diabetes, repeated infection, swollen reddish area in the apex of the nose you can see. Okay, then comes your cavernous sinus thrombosis. That's why you're going to call it as a dangerous area of space and of your face. And your stenosis or atresia of nares are possible. So you can see here, can you see here? So the nares, you are going to have your stenosis. So you have to correct it by rhinoplasty. Then congenital atresia. Then you can have tumors. So what are the tumors you can have commonly? The first important thing is rhinophyma or potato tumor, a 5-mark question. So they are going to be slow growing benign tumor due to hypertrophy of sebaceous gland at the tip of the nose. It is seen in long-standing case of acne rosea, something like this. This is called as your rhinophyma. So clinical features, pink lobulated mass over the nose with superficial vesicular dilatation. Skin is porous and pitted. Mostly men past middle age are affected. Unsightly appearance, obstruction in breathing and vision. Now coming to the treatment, it's going to be subepithelial enucleation, decortication, and carbon dioxide laser. Sometimes excision of raw area, skin graft is done. Malignant tumor, basal cell carcinoma, rodent ulcer. So most malignant tumor involves your skin of the nose. So இது காமனா கேட்கிற question. So tip of the nose or ala is usually involved. Clinical features are cyst or papullae. அதுக்கப்புறம் you have slow growing cartilage, nodal metastasis. Treatment depends on cryosurgery, irradiation, surgical excision. Okay, wow. So then comes your squamous cell carcinoma, second most common malignant tumor. So 40 to 60 years of age. So this is your squamous cell carcinoma. Okay. So surgical excision and radiotherapy is done. Final is melanoma, surgical excision is performed. Then comes a dermoid cyst. 5-mark question. So dermoid cyst, they are 2 types. Simple dermoid are associated with the sinus. Simple dermoid, now midline swelling under the skin, but in front of your nasal bones. They doesn't have any external opening. They are associated with sinus, seen in the infant and children. They are represented by pit or sinus in the midline of dorsum of nose, and air may be protruding through the sinus opening. Treatment is splitting of nasal bone to remove any extension. Finally, I have already talked about your encephalocele, meningoencephalocele, glioma. So this is going to be a glioma. So that's all. With this, we are coming to the end of the external nose. I give you 2 options. Shall I continue for next half an hour and shall I give you rest? Or otherwise, I can continue the freshly tomorrow morning with disease of nasal septum. Because already I've loaded with you so much. So you can take your time remaining next to 2 hours or 3 hours. You can revise the entire pharynx which is taken today and your nose up to this. Because after this, it's going to be very small. We are going to just rush through all the diseases. Okay, anatomy and basics is over. So I'm going to rush through the diseases. If you want me to continue now, that will be incomplete only at the end of 8:30, or else I can start it tomorrow morning freshly and go with your ENT. Now itself, I show you the ENT notes. ENT notes are prepared with my own handwriting. So you can just copy it down. So ENT notes la வந்து பாத்தீங்கன்னா நீங்க அப்படியே copy பண்ணிக்கலாம். That's all. It's going to be a self-explanatory notes. I'll be just teaching you with this notes only. Okay. So with this, I'm just asking your opinion. Can you put in the chat box if I want to continue notes now or tomorrow morning? Come on, guys, put in the chat box. Do you want me to continue nose now? Because from morning I have completed pharynx, we have completed larynx, and we have started anatomy and physiology of nose. External diseases are completed. Others, apart from Berlin, others? Okay. Berlin, your name itself is Berlin edema, or is it a eponym or something? Okay. So Balash to the morning, others? Okay, so I will start with tomorrow morning, the disease of nasal septum. So you have disease of nasal septum, acute and chronic rhinitis. Then we will go for sinusitis. Sinusitis is a big topic. Then you have nasal polyp, granulomatous condition. We will talk about epistaxis. Then last topic is going to be fracture of your face. Okay, so then you have your nose tumors. Romba important kadayadu. Not commonly asked. Okay, wow. This is what they are commonly asking. I think I have explained you most of the thing. So let's see tomorrow morning. Then we will move towards a very big and very important topic here. Here, I don't want to annotate anything. Everything is present in my notes. Just I'm going to help you to understand my notes so that you can just read it afterwards also. Okay. Thank you so much.